Plaque reversal is possible. This video shows you exactly how to do it. This is not hype. It's the most complete guide we've ever released on reversing plaque. In this video, we'll show you practical strategies that work. But let's back up a minute. You may be thinking, wait a minute, I looked at it. This is a 6-hour video? I don't have time for this. I understand. I know. This is what a compilation video is. So we've taken our very best content about plaque reversal. We've compiled it in one masterclass. Think of it as a masterclass. And no, you don't need to try to get through the whole class all in one sitting. In fact, just save it. You can put it in a watch list. You can put it in a rewatch. You can do what I do. Just click on the part that says share, then click on the link. Get a copy of the link and save it in your notes. Now, there are chapters in this compilation. Each chapter is like a video. You can jump ahead, review that video. You can jump back. You can pause, rewatch, save it for later. Some people can save this as a podcast or even audiobook and listen to it that way. My name is Ford Brewer. I taught preventive medicine at Johns Hopkins. I taught the other doctors there. I do know what I'm talking about. This is what a clogged artery looks like. Unfortunately, most people are not aware that their arteries look like this until they end up in the ER, emergency department, having a heart attack or a stroke. Even worse, many die from a sudden and lethal heart attack. Some sources say over 50% of heart attacks are sudden death. And that's definitely the worst way to find clogged arteries. So today, I want to talk to you about the best way to find out if you have clogged arteries and how it helped my patients find theirs. Let's discuss how to find arterial plaque, also known as clogged arteries, and how to live a longer, healthier life so you can spend time with your family, keep doing your hobbies, and enjoying retirement. Now, the quick note, because when I say best, there's a big caveat. The best test is easy to find, easy to get done, easy to interpret, and affordable. I know. What might be affordable for one person might not be for another. The tests I'll show you today all have pros and cons, so keep that in mind. The first test is called a CT angiogram. Many consider the CT angiogram the best way. A CT angiogram uses CT technology. It stands for computed tomography. It's just a high-tech type of X-ray. During CT angiogram, a medical specialist will place a thin tube called an IV, which stands for intravenous, line into your arm. You'll be injected with a special dye called contrast. The contrast will flow through your vein and reach the heart, the coronary arteries, the arteries that supply your heart. This produces a good image of your arteries when combined with the CT machine and technology. In most places in the world, the radiologist and the cardiologist will look at those images and tell you if you have obstruction caused by arterial plaque. That's what we call clogged arteries. But there are multiple problems with this approach. One of them is that most cardiologists think like plumbers. They see clogged arteries and they recommend a stent. A stent is a piece of metal designed to open the artery and prevent heart attacks. Now, why does all this happen? Well, there's a fundamental problem in understanding what makes arterial plaque dangerous. Let's go down a quick bunny hole here. Stents don't prevent heart attacks. That's right. You heard me correctly. I said stents don't prevent heart attacks, and there's plenty of evidence that supports this. I'm not saying that stents don't work. They do. And they can unclog arteries, especially when you have an active heart attack. They can be life-saving at that point. Evidence also shows they can decrease chest pain associated with blood flow reduction. That's what we call angina. But if you don't have symptoms, or even if you do, stents give you a false sense of security that you can keep living a poor lifestyle. And that's just not right. It's not a plumbing problem. It's a lifestyle problem. The evidence is clear. 2/3 of heart attacks happen in people who don't even have a 50% blockage. What this means is even small amounts of arterial plaque can cause heart attacks. You don't need to have blockage to have a heart attack, just a small amount of plaque. And even if plaque is blocking the blood flow, up to 17% of people who get a stent can have a heart attack within the following year. So it's not just the blockage, it's something else. That's the problem behind cardiologists thinking like plumbers. They miss the root cause of heart attacks, and it's not cholesterol. It's not the plaque itself, it's metabolic disease. It's cardiovascular inflammation. More on that in my video. I'll leave a link in the end. Let's go back to the CT angiogram. In most countries, when you get a CT angiogram, the cardiologist sees blockage, recommends a stent, you get a stent, and if you don't change your lifestyle, you may still have a heart attack. Don't get me wrong. If you've been offered a stent and you want to do it for peace of mind and save some time for a lifestyle change, go for it. Just don't neglect the metabolic disease and the lifestyle change. Don't rely on stents or medications to prevent a heart attack or stroke. So what's the point of finding clogged arteries? Well, there's a benefit to doing it because you can identify your risk. In my practice, I don't focus on blockage alone like cardiologists do. I look at the type of arterial plaque that you might have. There are 3 types of plaque: soft plaque, calcified plaque, and mixed plaque. Each type of plaque results in a different level of risk. The most dangerous one, by far, is soft plaque. This is the plaque that you start building up as you age. You get exposed to junk food, lack of exercise, cigarettes, alcohol, or other diseases like high blood pressure, high triglycerides, and especially high glucose and insulin levels. Many of you will recognize that these last 4 are all due to insulin resistance, prediabetes. The inner layer of your artery wall gets inflamed. It means you start recruiting immune cells that are supposed to defend your artery. Instead, they start attacking what's inside there, the plaque. One thing that's inside there is cholesterol. But when dealing with inflammation, some cholesterol, when crossing through the artery wall, gets attacked and oxidized by the immune cells, inflaming the plaque. Inflammation is like goo or snot, liquid pus. In the intima, the layer of the artery wall, in contact with the bloodstream, you get a rupture. That gooey liquid filters into the bloodstream and it triggers a clot. And that is what causes heart attacks and stroke. If that clot's big enough and it goes to the heart, it's a heart attack. If it's big enough and it goes to the brain, it's a stroke. CTA or CT angiogram is one of the best ways to see this type of plaque. It's called low-density, non-calcified plaque. And if it's present in 4% or more of your vessel diameter, that's considered high-risk plaque. But our body is smart, and it will work to heal the plaque. Now, we must support our bodies in doing this work. Lifestyle is the key factor here. It might sound repetitive, but it's the truth, and so many people want to avoid it. Now let's talk about calcium for a minute. Calcium is clearly a marker of plaque progression, and for some people, plaque stability. For those eating a low-carb diet, exercising regularly, sleeping well, and avoiding stress and environmental toxins like plastics, the chances are that you are calcifying that artery for stability. You see, in arterial plaque, you have 2 key components, a core and a cap. That cap is made out of smooth muscle cells. Having a thick, fibrous cap is good. It's stable. Lifestyle helps that cap to become thicker and more stable. It'll also calcify the plaque. Some people say calcium acts like mortar between bricks, but I'm not so sure. I think it's more like a marker of stability and decreased inflammation. Regardless, building up a thick cap is critical to stabilize plaque. A stable plaque won't break, so it won't cause a heart attack. Suppose you're eating the SAD diet, the standard American diet, eating Doritos, drinking soda. In that case, chances are you're calcifying your artery. Oh, and I forgot, eating cereal. You're calcifying your artery in the wrong way. You're adding more soft plaque and increasing the burden of inflammation, creating a bigger job for your body, more mess for your body to clean up. Your body's building patches of calcium, but it can't keep up. It's creating calcium islands surrounded by liquid pus. That's an unhealthy form of calcification, and this type of plaque usually has a very thin cap. This is a setup for a heart attack. Mixed plaque is at a point between soft plaque and healthy calcification. You have significant calcium, but not enough to make the plaque as stable as needed. This mixed or non-calcified plaque is still far better than soft plaque alone. Unfortunately, standard CT angiograms, interpreted by radiologists and cardiologists, often don't give you this level of detail. In the U.S., there's a new company called Clearly. It uses artificial intelligence to provide a more detailed description of the different types and amount of arterial plaque. Clearly's stated company purpose is to avoid heart attacks and strokes, to avoid unnecessary stents, and empower the patient to find the right options for their treatment. But not everything is sunshine and rainbows. Getting Clearly AI has its challenges. It's like getting a CT angiogram. That's challenge number one. It can be expensive, and that die, and having to go to a hospital and taking a few hours. The AI analysis is usually not covered by insurance. It's not cheap. The other downside's having to go to the hospital, the X-ray facility that can do IVs, get the contrast dye, which you might be allergic to, and exposing yourself to some radiation. Additionally, you might need to prepare with a dose of a beta blocker, a medication to slow down your heart rate. That will allow the radiologist to see your heart more clearly. Pun intended. Surprisingly, that's still not the worst part. The worst part to getting those results is getting them to a doctor who thinks like a plumber. And despite the report, you can still end up with an unnecessary stent and neglect the necessary lifestyle changes that need to be done. Even with these challenges, I think Clearly is the best way to see plaque in your coronary arteries, at least the best way available to the public and the best way to see the anatomy. There are more advanced ways to see coronary plaque, like IVUS, intravenous ultrasound, and OCT, but those are usually more academic. They're not worth discussing right now. I won't take your time. There's one more downside. Those with significant plaque or previous stents and some patients with kidney disease just might not be able to get this test. There might not be candidates. So, what happens if you can't or you don't want to do a CT angiogram with AI, like Clearly? Well, I have another option. And I've been promoting this test for years. It's called a CIMT. It stands for Carotid Intima Media Thickness Test. It's a special neck ultrasound, specifically the carotid artery. That's the artery that connects the heart with the brain right here in the neck. It will measure the thickness between your intima, remember the inner layer of the artery wall, the one that gets inflamed, and the layer beneath it, the media, the muscle layer. That's where plaque starts to build up. That's why it's called Carotid Intima Media Thickness Test. A CIMT uses ultrasound technology, meaning no radiation. It's a non-invasive test proven in the evidence to predict up to 98% of cardiovascular events. Plaque builds up in multiple vessels, not only in the heart, and studies like the Cafe de Cave study and the Honda study, as well as multiple other studies, have shown that if you build plaque in your neck or the arteries in your leg, the femoral arteries, you're building up plaque in your heart. A proper CIMT can potentially find soft and dangerous plaque, though it's not as good as the CT angiogram at showing the actual anatomy. It's still a very reliable way to assess your cardiovascular risk, because what we want to know is not so much the anatomy. We want to know the degree of calcification or the degree of softness. The more that it's soft, the more dangerous. Not to mention, CIMT is far cheaper than the CT angiogram, about 10 times less expensive. Maybe not cheaper, maybe more affordable. But a CIMT has its own challenges too. Since it's an ultrasound, it depends heavily on the technician's ability to perform the test. Some centers will tell you they do a CIMT, but they'll perform a traditional carotid ultrasound. They're not the same thing. The CIMT has added analysis, added analytics using information technology. A traditional carotid ultrasound might report plaque, but it won't report either the type of plaque or the intima media thickness that we've been talking about. Traditional carotid ultrasounds usually focus on blood flow. It's a blood flow test. Here we find definitely the biggest challenge with a CIMT: finding a good provider. 3 of the best ones in the country are CardioRisk, Carotid Care, and Vasolabs. However, they're only available in some states. The other problem is that most doctors won't know how to interpret the results. We do that every day. But creating awareness about this test, which can help hundreds of thousands of lives, has been an uphill battle. Well, we've covered the best ways to find clogged arteries, and both can give you similar information. I have a bonus option for you, though. If you can't or won't have a CT angiogram, and you can't get a CIMT, there's also the option of a calcium score. The calcium score is also a CT scan. It's of your chest and coronary arteries, the arteries of your heart. It will show how much calcium you have built up with a lot of accuracy. In general, a higher calcium score is associated with a higher cardiovascular risk for most people. A calcium score of 1 or more means there is calcium in your coronary arteries. That's calcified plaque. Like the other tests, it also has some challenges. You need to be aware of them. First, it involves an insignificant dose of radiation. Not IV contrast, but radiation. That's actually the least of the problems. The big problem is that it won't show soft plaque. You see, calcium detected in a calcium score is like the tip of the iceberg. If you remember, calcified arteries develop from soft plaque. Calcified plaque is stable. Soft plaque is dangerous. If you have calcium in your arteries, it's very likely that you do have significant amounts of soft plaque. That's what we need to know. Especially if you're deep into an addiction to carbohydrates and junk food and you don't exercise or sleep well, the interpretation of the calcium score turns out to be another problem. Remember, we said there are 2 types of calcification: healthy and unhealthy. If you actually have a very healthy lifestyle, you lose weight, you avoid unhealthy carbs, you exercise, and you're back in good shape, you might be promoting healthy calcification. Guess what's going to happen with your calcium score after going through that health improvement journey? Yep, you'll be taking your soft plaque, which is dangerous, calcifying it, and stabilizing it. And guess what's going to happen to your calcium score? It will go up. Research shows that some people with a calcium score of over 1,000 actually live longer. That's because their plaque is now stable. So, is a high calcium score a good or a bad thing? Dr. Vega, our channel manager, hates it when I say this, but it depends. It depends on whether you're working every day to stabilize your plaque in a healthy way, or if you're still building both calcified and soft plaque. Now you have 3 ways that I recommend to assess cardiovascular plaque: CT angiogram, CIMT, and calcium score. There's one more test that I'm neglecting to mention, and you've probably already gone through it. You may have anyway. It's called a stress test. A cardiologist will put you on the treadmill and ask you to walk and run, maybe, or even inject medications, or make your heart go faster. An EKG, electrocardiogram, it's a machine that measures the electrical activity of the heart. It will assess your heart and show reduced blood flow as a response to physical effort. Do you see the problem here? Exactly. The focus is on blood flow. A stress test is another flow study, just like a regular carotid ultrasound without the CIMT. A stress test is usually done to predict if somebody will have a heart attack. Unfortunately, 90% of those are done for that reason, prediction of heart attack, and they don't do that. If you have a positive stress test, then that means they've found some level of blockage. Now, you might be on a slippery slope because following a positive stress test, expect the cath lab, then a stent, and most likely still even a heart attack after all of that. But that's not the worst part. The worst part is what happens when you have a negative stress test and they didn't find anything and you still have your heart attack 6 months later. You pass your test with flying colors, you think you're fine, and then you have a heart attack 6 months later. That's exactly what happened to Tim Russert. Now, you can say he wasn't in the best physical shape, but he was a runner, and he passed his stress test. It's clear that the stress test did not predict his heart attack, and he's not the only one. He's just an example of so many people that have passed their stress tests and then had a heart attack. Stress tests are good for evaluating fitness, but fitness doesn't always mean heart health. There's some correlation, but it's not great. So what about a nuclear stress test? Is that really better? It's basically the same thing. The difference is you'll get injected with some radioactive dye. That'll be seen on a special machine. The problem is again the same. Both types of stress tests are based on the assumption that blood flow is the problem, not the type of plaque. Stress tests won't be able to evaluate problems until there's a 50 to 70% blockage. And do you remember? We've said it multiple times. 2/3 of heart attacks happen with less than 50% blood flow blockage. That's why I don't recommend stress tests for heart attack prevention. I prefer that you get your plaque risk assessment from a CT angiogram, a CIMT, or even calcium score. So now you know some actions you can take to address your cardiovascular risk. But as I have mentioned, lifestyle is king. Now that you know which tests actually detect dangerous plaque and why stress tests, the ones that doctors most often rely on, they usually miss the mark. Why? Because they're really more of a test for cardiovascular conditioning, not cardiovascular risk, event risk, heart attack risk. And here's the real tragedy. For far too many people, the first sign of plaque isn't chest pain. It's death. Sudden cardiac death. No warning, no second chance. They felt fine. Sudden cardiac death. That's a big deal. It kills a lot of people. In fact, half of heart attacks begin with sudden death. These people don't get a second chance. But believe it or not, there's a huge opportunity here. You think of sudden death happening like lightning striking out of the blue. A couple of really good medical institutions have done a lot of research on this, and they're clear that's not what's happening. It is sort of like that lightning out of the blue. It's a Hollywood myth, maybe an urban myth. Lightning really doesn't happen out of blue sky. It happens in a storm with clouds, wind, and rain. Guess what? Sudden cardiac death and heart attacks are the same way. They don't happen out of the clear blue. They happen in the middle of a metabolic storm. Did you know that half of heart attacks present their first sign or symptom is sudden death? These people don't get a second chance. That's 50%, 5 out of 10, half of them. And the worst part is the test that most doctors use, the stress test, that cannot predict heart attacks. So about 10 years ago, I found I had arterial plaque. The first thing that crossed my mind was I could have a heart attack anywhere, anytime. I lived in the bluegrass area of Kentucky, near Lexington at that point in time. I used to run in beautiful horse country, some of the most beautiful horse country in the world. And I thought, if I have a heart attack here, The week that I discovered my plaque, I went out for my weekend long run. It was a couple of hours. And if I have a heart attack here, it'll be hours or maybe even days before they find my cold, stiff body in a ditch next to a beautiful horse farm. Now, I know that sounds dramatic, and I got over that. And I said, look, I do this for a living. That's not a problem. I need to head on out. And I did, and I was fine. Now, here's the question. If there's a storm that precedes these heart attacks, why don't people recognize that storm? Could we recognize it? And if we could we actually even intervene and prevent that heart attack? That would have a lot of promise. And let me tell you, we can. In this video, I'll show you how to recognize the storm, why stress tests don't predict heart attacks, and let me give you an example. This is a typical story. You probably have heard of this event. Let's go through the details and see if you can guess. The setting is Washington, D.C. The date was April 29, 2008. The office of Dr. Michael Newman. It's in that Tony district there of Georgetown. He was like the doctor or the internist to a lot of D.C. stars. It's a familiar patient story. 58 years old, non-smoker. Family history was not that remarkable. His waist size has grown to over 40 inches. He had high blood pressure. It had been controlled on an ACE inhibitor, but he was having more trouble with it. Total cholesterol, LDL cholesterol, these were not remarkable. C-reactive protein, his doctor even had checked that. It wasn't a big deal. Cardiovascular risk estimate, less than 10% over the next 10 years. So relatively low risk. But he said, hey, doc, I'm worried. Could we just do a stress test? Because he'd been gaining weight. He had to eat out a lot as part of his job. He was a runner, a jogger, but didn't do a whole lot of high-intensity interval work or resistance work. They did the stress test, and it was normal. They changed his meds from an ACE inhibitor to an ARB, and again, you don't have to remember any of these technical terms. The patient went back to work. 6 weeks later, on Friday, June the 13th, 2008, he collapsed suddenly at work at 1:30. A CPR was performed within minutes. EMS arrived at 1:40, and he arrived at the hospital at 1:44. 3 shocks were administered en route to the hospital. He arrived at Sibley Memorial Hospital and was pronounced dead at 2:23 p.m. The autopsy showed soft plaque, a clot in the LAD. You've heard of it, the widowmaker. That's the place where if you're going to get plaque in the arteries of the heart, it's the most likely place. Now, look at what Dr. Newman said on this video. This is the sad story of Tim Russert. He had just returned from family vacation in Rome. He was celebrating his son's graduation from Boston College and his birthday. His wife and son had remained in Rome while he returned to prep for that Sunday's Meet the Press. He was the longest-running host and the most loved host of Meet the Press, where he would take a Washington, D.C. politician and show videos of 3 years ago and say, well, wait a minute, this is what you said you were going to do. You're not doing anything like that. That's what the public loved Tim Russert for doing. He walked over to the sound room to do some voiceovers. On the way, he greeted the editing supervisor, Candace Harrington, and he said, what's happening? If you weren't around in 2008, that was sort of like what people mean when they say, what's up? Same thing. Those were his last words. He collapsed, and you know the rest of the story. He'd been the host of Meet the Press since 1991. Passion, research, ability to find clips of inconsistencies in his guests' past, again, had endeared him to the country and the whole world. A plaque had ruptured and ended those interviews in his life. Why did this happen? A ruptured plaque ended his life. He'd had a positive calcium score 10 years earlier. It was 210, that was the score, and that was back in 98. Doctors Newman and Brown said the autopsy showed a surprising amount of plaque, and the pathologist said The lining of that artery looked like the face of a teenager with a severe case of acne. There was just a lot of these pockets of inflammation. Carl Levy of the Oxner Review said, you know what? He had to have less than 50% occlusion or blockage because the stress test was totally fine.
There's no way to anticipate or detect them. An hour before this happened, he could have had a stress test and it would have been perfectly normal.
If we went through that whole interview with Dr. Newman earlier, that's one of the things he said. He said, we could have done a stress test the morning he died, it would have been normal. So they knew he had plaque. They knew he had problems. Why didn't they fix it? Well, they couldn't. Well, that was 2008. That was 15, 16 years ago, right? So they can fix it now, right? No. We can't. So again, in fact, most people are never going to see it. Just like Michael Newman and Tim Russert's doctor, Tim Russert, did not see this coming. Here's the reality of America. Half of Americans don't know that the number one cause of death is heart disease. Half of heart attacks end up in sudden death. 93% of Americans are metabolically unhealthy. They're not at optimum metabolic health, and therefore they're at risk. There is a better way to predict a heart attack, CIMT. CIMT finds plaque. Arterial plaque is a waxy substance that deposits in the artery. CIMT would pick up all of those pimples that they described in the arteries in the path report when they did the autopsy for Tim Russert. So again, it's a waxy substance. It deposits in the wall of the artery. When it gets inflamed, it can rupture, creating that look of pimples like the face of a teenager with acne. Now, if you go back and look at actually what happens during the heart attack, inflamed plaque can leak back into the flow of blood. If it does, it can cause a clot. It's the clot that causes the heart attack, not the plaque itself. That's when the plaque is inflamed and soft, full of immune cells and immune fluids, and the consistency of mucus or snot. And it's very similar to mucus or snot. It's full of immune cells and liquid. There are three types of plaque: soft, calcified, and mixed. Carotid arteries are the windows into our cardiovascular system. There was a study of over 10,000 people. It was called the Cafe to Cave study. It looked at what they thought were healthy subjects, and they followed them for 10 years. 40% were female, 35 to 65 years old. Carotid and femoral ultrasounds. So they did ultrasounds of the carotid artery right here and the femoral artery. 98.6% of those with plaque suffered a cardiac event within 10 years. So you've heard us in different shows talking about the CIMT saying this picked up 98.6% of heart attacks. And let me tell you, that is a lot better record than stress test. Now, is calcified plaque really more stable? So once you start studying plaque like this, you begin to realize that calcified plaque is very, very different from inflamed plaque. This is from the Honda study. We're going to show you a chart here. It's got a Kaplan-Meier curve on it, basically showing every time each of these lines drops, that's another event. So as you can see, the people that had calcified plaque had a couple of drops in the very beginning and then stabilized. Their plaque was just as stable as basically having no plaque at all. The people, on the other hand, that had uncalcified or soft plaque continued to have events. Now, what are the advantages of CIMT? Well, it's painless, it's non-invasive, there's no radiation, there's no needles, it's inexpensive, no disrobing, you don't have to take your clothes off, and it's safe for all ages. That's why you'll see on nomograms plenty of surveys done on children as little as 5 years old and even younger. There's no prescription needed. Now, it sounds like it's a perfect study. Not really. There's some problems with perspective. If the person that does your CIMT isn't really clear on their standards and how they went in, they can see places that look like a lot more or a lot less plaque than you actually have. So it's very technique driven. The research and the evidence shows some challenges. A lot of the research was done by people who didn't know how to do these. So you ended up with an effect of garbage in, garbage out in terms of the research. The standards have suffered because of that. But here's the biggest issue: access. To get a good one, you can't just go to the local x-ray department or the local hospital. There's only a few places in the country that I've found that get good CIMTs. Now, a couple of them do them in many parts of the country. So people throughout the country can access them. It's just not that easy. A company called Carotid Care has found that 85% of their patients showed plaque and are at risk. So as you see, heart attacks don't just suddenly happen. Heart attacks happen within a storm. Get the right tests, change your lifestyle, and ask the question, why is this so common? And why is it so common that the people that have these problems don't know? You would think that we would all learn the common signs and symptoms of a pending heart attack that's getting ready to happen. We might, if there were any. You will hear people talk about, oh, this is a sign of a pending heart attack, or that's a sign. The bottom line is, if you're waiting for a sign to tell you about heart attack to prevent it, I hope you're feeling lucky. Because for most people, there are none. So then I guess you would ask, what are the doctors doing? Doctors are supposed to be helping us stay out of this mess. 3/4 of doctors don't know how to diagnose metabolic dysfunction, metabolic disease. We go into depth in that in a couple of other videos. A1C, it misses more than it catches. Even the ADA has said that. A1C can miss up to 70% of cases. You know, if you ask your doctor how he or she diagnoses diabetes, he or she will usually say A1C. And that's what they think. The vast majority of diabetes cases that have been diagnosed are actually diagnosed with fasting glucose. And it was usually done for a surgery or something else totally unrelated, and surprised both the patient and the doctors. So as you see, 75% of doctors just don't know how to test for diabetes and prediabetes, let alone diagnose it. So how do you diagnose it? Metabolic disease, insulin resistance, prediabetes, diabetes, oral glucose tolerance tests. And even with an oral glucose tolerance test, you do need to get the insulin response. What that turns out into is a Kraft insulin survey. Those of you who have watched a lot of YouTube have heard many of us discuss the Kraft insulin survey. We do that every day with our patients. I mean, we'll have patients coming in. Our recommended cadence for that test is once a year. And we do these all the time. And it's really clear. You'll still miss about 15% of cases if you don't do that insulin response. The bottom line is we see patients coming in all the time that have totally normal fasting glucose, totally normal A1C. And yes, the academicians want to talk about HOMA-IR, totally normal HOMA-IR, but still have diabetes, prediabetes. How is that? Well, again, it's not any one specific time period. It's how our body metabolizes glucose from start to finish. Now let's talk about cardiovascular inflammation. I've mentioned that a couple of times. What is it? You know, most doctors don't even understand cardiovascular inflammation. They understand that inflammation is an immune response. They talk about it. For example, there was a lot of attention paid to it with that lymphocyte storm or that immune cell storm. It's an exaggerated immune response. It can happen with lymphocytes, polymorphs, any of the different types of immune cells. And you don't need to remember any of those clinical names. It's just an exaggerated immune response. That can hurt the blood vessels in the crossfire. See, that immune response is directed towards plaque. Your body does not want to have plaque inside the walls of the vessel. Your body also doesn't want to get the lining burned with high glucose and high insulin. Those things will cause this inflammatory response. And that inflammatory response hurts those blood vessels. Chronic inflammation leads to soft plaque. Soft plaque leads to heart attacks, strokes. It's the number one cause of blindness. strokes, heart attacks, Alzheimer's, kidney failure, and for the men, even erectile dysfunction. So when you think about it, metabolic disease is the hurricane. It is the major underlying driving force. And cardiovascular inflammation is like one of the many tornadoes. We just had Hurricane Helene come through this part of the country. And yes, it was devastating. The major power came from that hurricane. But there were places where tornadoes just came down and beat up major sections. Again, metabolic disease is like the hurricane. Cardiovascular inflammation is like the tornado. Now, how do you figure that out? How do you know if you have that? Well, here's the thing. Please test. Don't guess. A1C misses 75% of this, and there are better tests. Oral glucose tolerance tests with an insulin response, a lipid panel with fractionation, an inflammation panel. So the OGTT, oral glucose tolerance test, has 90% accuracy. It does require drinking 75 grams of glucose, and a lot of people don't like to do that. It requires a couple of finger sticks, too, or blood draws. So 3 or 4, in fact. What you do, you fast for at least 8 hours. Then you get a fasting blood sample, blood glucose, and insulin. You take the 75 grams of glucose. Then you get a 30-minute level, a 1-hour level, and a 2-hour level. There are at-home test options. If at all possible, would like to get an insulin response. Sometimes we see people whose blood sugars are staying fairly within range, but the insulin required is skyrocketing, going way out of the norm. So measuring insulin at the same time as glucose is a very, very helpful thing. Now, you want less than 10% of margin of error to diagnose metabolic disease. You don't want 75% margin for error like you get with the other tests. Lipid panel is a very helpful test. Triglyceride over HDL is one of the key blood indicators of metabolic disease. The lipid panel measures fats and oils and cholesterol inside the bloodstream. There is a major focus on triglycerides and HDL. Elevated triglycerides and low HDL are major risk factors for cardiovascular inflammation and indicators of metabolic disease. We also actually break that down into what we call a lipid fractionation. We look at the actual bell curves for that, quote, HDL, what used to be called the healthy cholesterol, and LDL, what used to be called the bad cholesterol. We measure the particle sizes. We look at problems including loss of HDL large and loss of that large fluffy LDL, which you've heard is healthy. Maybe it is, maybe it isn't, but it's clearly associated. Loss of large fluffy LDL, loss of large HDL are clearly associated with warning signs for metabolic disease. They show that those particles, the proteins, well, I will just mention them quickly, ApoB and even a little bit of ApoA1. Those are those proteins. And you've heard of ApoB. Big increases in that are associated with what we call remnant cholesterol. Remnant cholesterol is a big cholesterol particle. Unlike HDL and LDL, it carries mostly triglyceride. And don't you remember? We said high triglycerides are a major sign of this problem. High triglycerides, high remnant cholesterol. So, why are we taking up protein with remnants? Because they're really big. And why are they really big? Why are they taking up a lot of protein? Because we're unable to burn that triglyceride. Let's go back to the beginning of this video. You remember we said high levels of insulin make it impossible to burn fat. And that's one of the reasons that we get fat. Well, think about it. One of the first places our body stores that triglyceride, that fat that we're not able to burn, is right here in our cholesterol particles, the ones called remnant. And guess what? Your doctor doesn't know that in most cases. So what's happening here is that remnant cholesterol, that ApoB particle, is storing and transporting that excess triglyceride. So are we big ApoB guys? No, we've been using ApoB for over a decade, and we have much better bioindicators than ApoB. But we know a lot of people have been talking about it recently. We just want to help you understand what they're talking about. When they say ApoB is a better test, they mean it's a better test than LDL. It's not a better test than OGTT with insulin response, and it's not a better test than fractionation. Fractionation is a great in-depth analysis which helps us understand how much we're struggling to burn those fats, those triglycerides. So what we're looking for is identifying healthy and unhealthy LDL and HDL particles. Inflammation panel. The best way to find cardiovascular inflammation. So there's several different ways. The first thing that you need to remember is it's not just one test. There are a few people. You may remember we mentioned that back with Michael Newman. He had actually even tested Tim Russert. But the only thing he tested was C-reactive protein. And that's what you'll find with most docs. Very few docs are really testing for any kind of inflammation. Those that do only test for CRP. Here's the problem with that. CRP has a very high rate of false positives. Even just getting a flu shot will cause 2/3 of people to have a false positive C-reactive protein. So we look at a full panel. The first one is microalbumin creatinine ratio. And again, we're going to geek out for just a second. You don't have to remember any of these names, any of the tests. Just be aware of the concept that there's not one good test. You really need to do a few tests to make sure that you know what you're talking about. Microalbumin creatinine ratio. It shows whether or not we're spilling protein. We only spill protein if we've got damage to that lining of our artery wall, that intima. It's a good systemic marker. C-reactive protein, we've already talked about. It's a good marker for inflammation, but there are way too many false positives. Like we talked about with flu shots or even cuts or bruises can cause incorrectly elevated CRP. There are a couple of other markers that we look at too. One is called MPO or myeloperoxidase. Another is called LPPLA2. And we have discussed those in other videos. I'm not going to go deep into that because that gets a little bit geeky. What do you do if you have plaque or metabolic disease? Well, you can start thinking about all these medications and all these supplements and stents. The bottom line is you cannot out-stent, you cannot out-bypass, you cannot out-prescribe, and you can't out-supplement a lifestyle. And among the lifestyle components, diet is the most effective and most important. You need to start with cutting carbs. Over 90% of this problem worldwide is undiagnosed prediabetes. And undiagnosed prediabetes means you cannot metabolize carbs in the healthy way that you could when you were younger. Now, exercise. Body composition is huge. Increasing body fat causes more of this problem. Decreasing muscle mass also causes more of this problem. So in the old days, a few decades ago, my generation, they used to think, well, you just need to go out and jog. Aerobic helps, but you really have to get some resistance training in there and high-intensity interval training. Sleep needs to be healthy. Sleep is going to turn out to be one of the biggest things over the next decade in the research area. It's already starting to show that way. Sleep is critical. Stress, toxins. Now, these are all important things that we need to consider when we're following a healthy life. Unfortunately, the U.S. government is not always that helpful. You look at the food pyramid, what's now called My Plate. I hate to say it, but that's a lie. You know, what they do is they want you to get most of your calories from grain products. So you do need to reduce carbohydrates. You need to include protein and healthy fats. Intermittent fasting is a great way to go. Prolonged fasting. I often get people coming in that have lost 30 pounds. They're motivated and they want to keep going. And they'll say, yep. I'll say, you've already saved your life to a large extent here. What did you do? They'll say, I cut my carbs and I did some intermittent fasting. What else can I do, Doc? One of my next places is prolonged fasting, resistance training, and high-intensity intervals work, and rehit, reduced exertion, high-intensity interval work. You want to include nutrient-dense foods in what you're eating. Nutrients are tools for the body, tools the body needs to perform basic metabolic activities. A good nutrition goes way beyond just carbs and calories. We use a thing called Chronometer app. It's one of those apps that's pretty detailed, and you have to just take a couple of weeks and say, okay, I'm going to spend some little extra time each day entering my information. Once you get better, it becomes easier, and it's incredibly informative. So one of the things that you want to think about, you want metabolically active muscle. And when we talk about resistance training and muscle, men just start thinking about those guns. Think about it. We're talking about your metabolism here. As big as your muscles might be, Arnold Schwarzenegger, bodybuilder, really big upper body, but still his upper body was dwarfed by the muscles in his legs. The muscles in your legs change your metabolism. That's where to focus. Yes, you want to get a little bit of aerobics, but you got to get that resistance. You got to get that hit and rehit. As we said, sleep is critical, and it's been a major neglected factor. And it's more than just sleeping 8 hours. It's the quality of your sleep. Sleep hygiene. Getting that resistance and hit training so you do sleep better. You start to reverse that vicious cycle. There are so many vicious spirals associated with prediabetes, diabetes, loss of insulin receptors, loss of those capillaries in those leg muscles. You want to reverse all of that vicious spiral. As I said, medications and supplements can help, but lifestyle is the key. You can track your progress with something like a Whoop or an Oura Ring. I'm doing both. And here's the thing. The Whoop is very picky and very critical. The Oura Ring, well, the Apple Watch is very forgiving, and the Oura Ring is probably the most realistic. It's the balance between the two. I keep thinking we need to do some more videos on that because that's going to be growing. Use of wearables. Stress is continuing to be an emphasized thing, but one thing that very few people actually deal with. Things like breath control. They sound kind of woo-woo to some people, kind of silly, but they actually work. If you're actually trying stress management or breath management for stress, and you're not getting a big impact, you're probably not slowing your breath down enough. You need to think about getting from a normal respiratory rate of about 20 per minute down to less than 10. We're talking about really slowing things down. And again, stress is one of the more common risk factors. And of course, yes, look at things like adjusting your work-life balance, healthy relationships, healthy communities, meditation, mindfulness, life purpose, toxins. There are hundreds of toxins. And as we mentioned, we want to avoid them. Anything from microplastics to heavy metals to parabens to phthalates. It's nearly impossible to avoid all of them, but just be aware and start making those initial steps. Now, when you talk about supplements, they're a tool that are just a tool. Again, you cannot out-supplement a lifestyle. Some of the key supplements that we use are vitamin D and niacin, magnesium, vitamin K2, nattokinase, berberine, bergamot. And yes, we use medications as well, like aspirin, metformin, low-dose statins. Never use high-dose or even mid-dose statins. And a lot of times our patients elect not to use statins or any other medication. That's fine with us. We're not Luke Skywalker. Our patient is Luke Skywalker. We're just Yoda. We've been in a lot of these battles, and we have a lot of tools that we can use to help that patient and a lot of good advice. So, bempedoic acid or Nexletol. If you've been hearing about things that lower cholesterol, that's been touted as the kinder, gentler cholesterol-lowering medication. We have some people that want to take that. We got a lot of lean mass hyperresponders, and we got a lot of patients with a thing called FH, familial hypercholesterolemia. Some of those, not most, but some of those elect to take one of the things called the PCSK9s. You may have heard of it, Repatha. And we got a lot of people who are on a weight loss journey. We do have a lot of folks that elect to use Ozempic or Mounjaro. And as you've heard, they have revolutionized weight management, but they have their own issues too. Just like any prescription medication, they are not harmless, and they need care in taking them. Those, by the way, are some of the best medicines that have come up now for management of diabetes. And we also use some things called SGLT2s. You may have heard of those, Jardiance and Farxiga. Those are things that, again, totally changed the world of diabetes management. If you have to take insulin shots, that's a big deal. Those things are dangerous. The GLP-1s, like Ozempic and Mounjaro, and the SGLT2s, like Jardiance and Farxiga, are much, much better ways to go. Here's the bottom line. I've gone through a whole litany of list after list after list. And you know, if you're practicing good medicine, you do go through a lot of lists. But here's the thing. Metabolic disease is by far the number one cause of cardiovascular inflammation, cardiovascular plaque, and therefore the number one cause of heart attacks, strokes, number one cause of death, number one cause of permanent disability, number one cause of kidney disease, blindness, even erectile dysfunction for men, and Alzheimer's is being called type 3 diabetes. There are no signs. There are no symptoms. So get tested. Stop guessing. Stop trying to feel lucky. Here's the thing. You don't want to know if you're sick, but the bottom line is you really do. Once you know if you're sick, you can take that risk right off the table, and the risk of all of those bad things that I just listed. Lifestyle is the most important intervention. Medications and supplements can help in certain situations. So your journey starts here. Plaque doesn't need to block an artery to kill you. In fact, most heart attacks don't come from major plaque blockages. They come from small, soft plaques that rupture like a hidden landmine. And that's why this matters so much. Because if you catch it early, if you understand the right tests, if you change course before the damage is done, you can stop this from happening. We've seen it over and over and over. And that's what we're about to walk through now, step by step. Let's talk about how to catch this silent killer before it strikes, and what you can do today to protect yourself or someone you love. Did you know that more heart attacks happen at age 65 for men and 72 for women than any other age? Yep. And yet most people don't know how to avoid these heart attacks. We're going to tell you how today. It all starts by asking one simple question. Do you have arterial plaque? Plaque in your arteries? Today, I'll show you how to find arterial plaque at home using only a blood pressure monitor. Okay, so are you ready? Let's get started. Picture this. You're starting to feel some slight chest pain anytime you exercise, and you're also starting to feel a little bit weak with low energy. You go to the doctor, and she runs some tests. She tells you, hey, you have high cholesterol, and that's dangerous because it'll get stuck in the arteries of your heart. So here, take this pill. Take a pill. You leave the room confused with a lot of questions like, why do I have cholesterol in my heart? And what did I do wrong? I'm taking better care of myself than I did when I was younger. So why am I sick? When your doc's talking about cholesterol, you should be thinking about plaque, arterial plaque. It's the real driver for heart attack and stroke risk. Maybe a little bit more, and in fact, a whole lot more than just cholesterol in your blood. But what is arterial plaque? Most people think plaque is a waxy, fatty substance inside the artery where the blood flows. That's wrong in a couple of key ways. Arterial plaque is a disgusting goop. It's like mucus or snot. And like mucus or snot, it's mostly inflammation, not cholesterol. This goop builds up in your arteries, and just like a pimple, if this inflammation ruptures, letting all that inflammation and liquid into the bloodstream, it causes a clot. It's a big clot, and it goes to the heart. That causes a heart attack. If it goes to the brain, that causes a stroke. Before starting any medication, I'd recommend testing for plaque. There are multiple ways to detect plaque, but only one can you do easily at home. The technique you will learn today is called ankle brachial index. Just a word of caution. If you already have been diagnosed with deep venous thrombosis or DVT, or if you have severe leg pain, in that case, skip this test. Now that you know why it's important, let's dive into how to test your ABI at home. Now we're going to actually take the video clip of me doing an ABI. I've got my blood pressure cuff, I've got a pen and paper, and I've labeled it left arm and ankle, right arm and ankle. I've got a couch to lay down on, and I've got an iPhone to diddle around with while I'm resting. So Jesus wants to make sure that I rest first. My blood pressure is usually the same whether I'm standing or lying down, but I'm going to go ahead and rest because Jesus, the video director, wants me to do it. We want to get this up next to my artery, which is going through here. And so that needed to be undone. We want to pull it around smooth, firm, but not too tight, not really tight. Then we press the button. Okay, 107/69, right arm. One 107/69. Okay, take this off, put it on my right leg. I was clearing thorns in a nearby woods a couple of weeks ago. That's why I've got all these scratches on my legs. I don't know why that didn't do that the first time we did this. The artery's going up through here. So that's where we want to put the air bladder. Oh, wait a minute. I have to wait for a minute for Dr. Vega. Jesus is requiring a lot of footage here. He's always requiring a lot. I can't really tell how it's doing yet. I know Jesus is nervous. And that is going to be that's it. I can tell you from looking at this already that it doesn't show a lot of evidence of plaque, which is not a surprise given the I certainly wouldn't expect to have enough plaque to cause problems in my legs with the hill sprints and things like that I can do. That's it. All right. That wasn't too difficult, was it? If you haven't done it, don't worry. Pause the video. I'll wait until you get your numbers. All right, let me show you how to calculate your results. These are my numbers. For my right arm, I got 107/69. For my left arm, 114/72. For my right ankle, 120/59. And for my left ankle, 126/74. By the way, the units are called millimeters of mercury, and that's just how high the pressure can push a column of mercury. The first number is called the systolic blood pressure. The systolic blood pressure reflects the pressure from the blood after the heartbeat. And the second number is the diastolic. It's when the heart is resting. So, this is how to calculate the index, the ankle brachial index. First, choose the highest systolic number from your ankles. In my case, that would be 126. Choose the highest systolic number from your arms. In my case, that would be 114. Now, you need to divide the numbers. 126 divided by 114, that would be 1.1. You might have noticed that's for my left leg, and you can do this for the other leg. For my right leg, that would be 120/114, resulting in 1.05. There are other methods to calculate this, but this is by far the simplest and easiest. Let's see what those results now mean. The ideal index would be between 1.0 and 1.4, meaning healthy arteries, at least based on blood pressure. 0.9 to 1.0 is also acceptable. However, if your numbers are 0.8 or less, you probably have plaque, and it's probably causing blood flow obstruction and maybe even higher blood pressure. Also, an index higher than 1.4 indicates hardening of your arteries. Again, another problem. So you don't want it too high or too low. Now, wait a minute. What does all this have to do with arms and ankles? Well, you have arteries almost everywhere in your body. Compared to arteries in other places, the arteries from your legs have bigger challenges. They're more narrow. They depend on your leg muscles to stay flexible. This, by the way, is one more reason not to be sitting all day. By measuring the blood pressure in your arms and comparing that with blood pressure in your ankles, we can find out if you have arterial plaque that's obstructing or hardening your arteries. That would be called peripheral artery disease, or PAD. PAD can be terrible. It causes cramps, pain, swelling, and even hair loss in your legs. Why? Because any part of your body that doesn't receive enough blood is going to die slowly. In PAD, the muscles, nerves, and even hair follicles are slowly dying due to loss of blood supply. And we know that people with PAD have a much higher risk of heart attacks and strokes. Now, remember, the problems here are number one, loss of blood flow to the muscles of the legs, and number two, the risk of clots. The risk of clots is demonstrated by a signal of too much plaque. Too much overall plaque can mean that there's a lot of soft plaque. Soft plaque can rupture, creating a clot, and cause a heart attack. What should you do after getting your results? If your numbers are good, congratulations. You might have some good, healthy arteries. However, I don't recommend just sitting on it. Pun intended. ABI is good for finding severe problems, not so much for subtle problems. And people that have heart attacks often just have only subtle problems. So we have other options to detect subtle plaque problems. If your results are not good, I'm glad you realized it, and you realized it today. There's no better time to take action than now. Let's go back to the scenario from the beginning. Imagine you're leaving the cardiologist's office after being told to take a statin and that's going to fix your problem. You're confused, worried about dying from a heart attack, and worried about how a pill can fix this problem. Now that you've seen this video, you'll understand the importance of doing the right tests. You'll know what to do first to understand your plaque. Now that's one way to screen for severe arterial disease, using nothing more than a blood pressure cuff in the right ratios. It's simple, it's cheap, and it saves lives. Now, here's a bigger question, though. What if you could prevent the problem before it starts, before the plaque even forms, before the arteries stiffen, before that metabolic storm begins? That's where fasting can come in, not just as a tool for weight loss. Although, yes, it can help with that, too. But for something far more powerful. Because when done right, fasting activates a natural cleanup system in your body. Now, in fact, I can tell you from seeing patients all the time, I get tons of patients that come in, they've lost like 30 pounds. And one of the things, I'll congratulate them and I'll ask them how they did it. They'll usually say two things. Number one, I stopped eating carbs, so I got off of that glucose insulin roller coaster. And then number two, I started fasting. Now, usually they're talking about intermittent fasting. We'll get into that a little bit later. But let's talk a little bit more about why, despite all of the debate you hear back and forth about fasting, I will say, yes, it still helps. It clears out damaged cells. It creates autophagy, and that clears out that cellular trash. It reduces inflammation. It even targets the unstable plaque that leads to heart attacks. It's not hype. It is attacking soft plaque. And this is science, evidence. For many people, it is the missing piece. Let's get into it. What is the number one meal to clean out your arteries? It's not what you think it is. Why? Because about 90% of doctors, maybe more, and nearly every other YouTube video on this topic has gotten it completely wrong. They all lack a fundamental understanding of how the dance between your arteries, the plaque inside of them, and what actually causes you to have a heart attack or stroke because of that dance even works. Can you even clean out your arteries? If so, how? And is this even the right question to ask? Does it even matter? What is the insulin spiral of death? Does your LDL really even matter? Should you be worried about it? What markers should you actually be worried about? What are the real grim reapers? What about supplements like apple cider vinegar, niacin, vitamin K2? Do they even do anything? Wait a minute, don't only older people have to worry about heart attack and stroke? What about people in their 20s, their 30s? How does plaque in your arteries affect your blood flow? How can you actually reduce your risk of heart attack and stroke and therefore death itself? What should you really be looking at or looking for? Do those fancy stents that surgeons want to put in your arteries even do anything? Now, see, these are the questions we're going to answer in this video. And the answers to them are likely to surprise you and even likely to save your life if you pay attention. We're going to start off with two major misunderstandings everyone misses about what you'd call clean arteries. Then we're going to dive into four of the real questions that you should be asking and introduce you to an often missed hidden third actor, the Grim Reaper's insulin spiral of death. The real menace in all of this, which you may want to know about. That is, if you don't want to die or be partially brain dead earlier in your life than you should. Next, we'll cover 7 common misperceptions nearly everyone, including most doctors, have, such as the belief that fancy stents placed in one's arteries to try to expand them will actually prevent a heart attack. Or it's just you being scammed by bad science, bad medicine, along with corrections to the idea that LDL even matters as much as everyone says it does. Then we'll kick down the door on 4 supplement distortions you're being told about. Does vitamin K2 do anything, as other prominent YouTube doctors say that it does? What about apple cider vinegar? Is it anything more than a wife's tale? Finally, we'll get to that number one meal that cleans out your arteries and why it is what it is. Before we get to the lowdown on that number one meal that will clean out your arteries, it's important to understand the nitty-gritty of what's getting them all gunked up in the first place and how that even matters. Also, let's just say, for simplicity's sake, dirty arteries means arteries that are packed with plaque. Let's start off by defining what plaque actually even is, because you can't solve something without understanding it. Now, here's the scene. Plaque. That's like the uninvited guest in your bloodstream. It's made of cholesterol, and it's not just floating around. It gets cozy. wedging itself inside the layers of your artery wall. It's like having a squatter in your house, settling in where it's not wanted. Understanding this, it's like turning on the lights in a dark room. You can finally see what's really going on, and then you can start to figure out how to clean up the mess. So before we get to that miracle meal, we got to know the enemy, that cholesterol stowaway in our arteries. First, we'll start off with the two most major core misunderstandings everybody has about cleaning out their arteries. Core misunderstanding number one, how plaque affects blood flow. We've got a bit of a mix-up about how plaque messes with our blood flow. Most folks think our arteries are like the pipes in your bathroom, getting clogged up with plaque like hair in a drain. But hold up, that's not quite right. You see, our arteries, they're not rigid like those old copper pipes. They're more like those newfangled garden hoses, flexible and able to stretch. They can get bigger, they can get smaller. So this whole idea of plaque blocking things up like hair in a drain, that's not really how it goes down, pun intended. Our arteries, they're dynamic, they're living things. They don't just get clogged and stay that way. They react, they change, they adapt. Plaque in our arteries, it's a more complex game than just simple blockage. Misunderstanding number two, plaque doesn't get cleaned out, it gets stabilized. Plaque in your arteries, it's not like you can just scrub it out. What really happens is it gets stabilized. To get this, we need to understand the difference between hot plaque, that's the inflamed kind, and stable plaque. Let's break it down. There are two types of plaque. One's like a ticking time bomb, the soft plaque. That's the stuff that ups your risk for heart attack and strokes. Then there's the other type, the cool customer, almost like taking a chill pill. That's your stable plaque, almost risk-free. So this soft plaque, it's inflamed, it's risky. But stable plaque, that's like the healed version of the inflamed risk. It's chilled out, settled down, almost like it's put its wild days behind it. Now, why does all this matter? Let's take a little detour into academia. There was this guy, Honda, who snapped pictures of soft and calcified plaque. The giveaway? Calcium flecks. When soft plaque heals up, when the inflammation simmers down, it leaves these little calcium souvenirs. The folks with calcium in their plaque, they were like skating by without heart attacks or strokes. But those missing the calcium, not so lucky. So, knowing what kind of plaque you're dealing with is critical because it's the inflammation causing the heart attack, not the hard, chilled out plaque. Here's the play-by-play of a heart attack or a stroke. You've got this inflamed plaque, right? The inflammation gets too rowdy, erupts like a volcano, and spews pus out into your arteries. This goop, this pus, hits the bloodstream. It causes blood to form a clot. Now, if that clot is big enough and it hits the heart, that's a heart attack. If the clot is big enough and it goes to the brain, that's a stroke. Now, let's get to the three real questions that you should be asking in terms of what meal will clean out your arteries. Number one, how can I decrease my risk for heart attack and stroke? Number two, how can I find out if I have soft plaque? And number three, if I know that I have soft plaque, how can I stabilize it? Real question number one, how can I decrease my risk for heart attack and stroke? First off, you got to take a good hard look at what's going on. It's like peering under the hood of a 67 Camaro. You got to understand the mechanics to fix anything. It's not just about shedding a few pounds or beefing up those muscles. It's more about fine-tuning your carb intake to jive with what your body's craving and can burn. At our clinic, we don't play games. We don't guess around. We dive deep with lab tests to get the real picture of what's happening inside of you. It's like having a roadmap to your health. We do this oral glucose tolerance test. It's a bit like a carb challenge. We see how your body dances with those carbs, and then we measure your insulin response after downing 75 grams of glucose. Now, this is a solid way to check if your body's grooving right with glucose. Plus, we've got this lipid fractionation thing. It's the next level of checking out your cholesterol. It helps us understand exactly how you're dealing with carbs and how your carb metabolism impacts your cholesterol. Now for the heart stuff. We're talking soft plaque. We check out the enzymes, the inflammation markers in your blood to catch any trouble earlier. Myeloperoxidase, LPPLA2, C-reactive protein. These are the key players that we're watching. They're technical terms. We can help you with that. We don't overlook the small stuff like albumin in your urine because even a tiny bit can be a big red flag for arterial inflammation. The CIMT test is another ace up our sleeve. It's like a high-tech ultrasound in the neck that tells us if you're at risk by checking out the plaque in the artery in your neck. Well, now wait a minute. Why the neck? Because what's happening there usually mirrors what's going on in your heart's arteries, as in 95% of the time. So the bottom line, to kick health risks to the curb, you got to pinpoint and tackle their roots. It's all about understanding how your body burns its fuel. We use solid lab tests to get the full picture, no second guessing. High blood sugar and insulin levels are like unwanted guests at a party. They can wreak havoc on your artery walls, trapping cholesterol and causing all sorts of trouble. Metabolism precedes damage, usually by several years. Let me repeat that. What's going on in your metabolism precedes damage in your tissues by years, even decades, sometimes by only months. So you've got to watch your metabolism. It turns out a big chunk of folks with heart issues have trouble with carb metabolism, and it often slips under the radar. This can start creeping up in your 30s or even your 20s, and it just gets more sneaky with age, leading to insulin resistance, prediabetes, and damage to your arteries. Studies like the big one from JAMA Network show that it's a common problem, especially as you clock more years. The CDC recently updated these numbers to show that, in their estimate, by the time you're 18, everyone your age and older has a 50% probability of having this problem. Other sources say maybe 80%. Then there's the insulin spiral of death. It sounds dramatic, but it's a real thing. It begins with your body's receptors getting less sensitive to insulin over time, hiking up your blood sugar. Your brain's response, well, if my blood sugar's going up, we need to increase insulin. Crank up the insulin higher. And people don't know this, but high insulin messes with the body's ability to burn fat. Now we struggle burning both carbs and fat. What started off as a problem with one now quickly becomes a problem with both of our key fuels. This ramps up hunger. We can't burn either fuel, so we eat more. This leads to more body fat. Messed up hormone production, insulin resistance. It's a vicious spiral of death. Overeating, metabolic meltdown, and that's the insulin spiral of death. So what's the move? Tailor your carb intake to what your body can handle. If you can't deal with 75 grams of carbs at a time, back off a little bit. Cut them back. It's all about improving your body composition to tackle insulin resistance, prediabetes, type 2 diabetes. And don't forget, body fat isn't just there for the ride. It's not inert. It's not harmless. It actually creates hormones that drive this problem, like resistin, adiponectin, even the satiety hormone leptin. It plays a big role in insulin resistance. Body fat is key. Now, muscle's a game changer too. It's like your body's own glucose regulator. It helps us keep things in check. Resistance, high-intensity interval training are key to building these muscle mitochondria, especially when you do resistance training and muscle training in the big muscle groups of your leg. These are crucial for fat burning, but they're also a safety valve for blood sugar going too high. Even the older crowd can benefit big time from HIIT workouts and resistance training. Now, real question number 2. How do I find out if I have soft plaque? There's a thing called CIMT, Carotid Intima Media Thickness Test. It's the real deal. It's safe, simple, and straight up. It uses ultrasound, but it's a different beat. You see, plaque ain't picky about where it hangs out. It's not just in your heart or your neck or your legs. It's an everywhere kind of problem. Why? Because it's not about just the local scene. It's a global metabolic thing. Remember, we said this is metabolism. Your metabolism is the ringmaster here, not just some spot in the body. Like we said, metabolism causes the tissue problem. So the tissue and arteries are everywhere. And everywhere tissue is supplied with blood by arteries, that's where this can happen. That's big news, bigger than you might think. Let's mosey on over to plaques and heart attacks. If they were just a local party in certain arteries, stents would be the sheriff in town, stopping heart attacks in their tracks. But let's get real. Stents don't stop heart attacks. Are you surprised? Let me repeat it. Stents don't stop heart attacks. It's the truth. Despite most stents being placed, 90% of stents placed to prevent heart attacks, they don't do it. They just don't cut it. You think I'm spinning yarns here? Check out the Courage trial, the Orbita trial, the ischemia trial. What happened next? Well, when it became clear that stents weren't preventing heart attacks, the cardiologists doubled down, then tripled down, putting in 3 times more stents than before these trials demonstrated that they don't work. They're putting in stents like they're going out of style. Now let's circle back to the CIMT. It's going to get some solid pros. It's safer, it's easier, it's got an eye for soft plaque, but it doesn't send you sliding down that slippery slope to the cath lab, thinking it's all just a plumbing problem that we can fix with a stent. But here's the flip side, the cons. Most docs, they haven't even heard of a CIMT. Why? Because the early studies were like putting garbage in and expecting gold out. They were hung up on the idea of arterial age based on some shaky assumptions about plaque. Those early studies weren't up to snuff, so CIMT got shelved too soon. But let me tell you, the current top-notch studies, they're showing CIMT in a whole new light. It's a slow road, but CIMT should be making a comeback, just like a good underdog story. Now let's go back to real question number 3. If I know that I have soft plaque, how can I stabilize it? Well, first, we've got to figure out how much of that sneaky soft plaque we're dealing with. Once you've got a handle on what and how much of it is stirring up trouble, then it's time to put the brakes on whatever's causing the chaos. And that, my friends, brings us right back to the lab. You see, the heart of the matter, about 80% of the time, it's this sneaky critter called undiagnosed prediabetes or even diabetes. It's like a shadow lurking in the background. And most of the time, we're just overloading on carbs, more than our bodies can burn. It's like throwing a wild party in your arteries, and inflammation is the uninvited guest that just won't leave. It's burning up your artery walls like a bonfire. Now, it might not be easy. Nothing worth doing ever is. But it's simple when you break it down. Cut down on those excess carbs. It's like taking your foot off the gas when you're speeding down the highway. Then build up some muscle. It's your body's natural safety net for when that blood sugar starts climbing. It's like having your own personal bodyguard against that sugar rush. All righty, we have arrived at the 7 common misconceptions everybody gets confused by when it comes to your cardiovascular health and the major players in it: insulin, blood glucose, plaque, LDL, stents, and in the end, your risk of having a heart attack or stroke. It's getting us closer to that magic number 1 meal that will clean out your arteries. Common misperception number 1. Isn't LDL associated with cardiovascular risk? Common misconception number 2. People assume that they're in their 20s and 30s, they don't have plaque. Common misconception number 3. People assume if they don't eat sugar, they don't have plaque. Common misconception number 4. You can reverse the cholesterol in your plaque. Common misconception number 5. A stress test will predict a heart attack. Common misconception number 6. A stent will prevent a heart attack. Common misconception number 7. If a stent doesn't prevent a heart attack, a CABG or bypass will. Misconception number 1. Isn't LDL associated with cardiovascular risk? Sure, there's a strong link between LDL and heart risk. But here's where it gets interesting. Correlation isn't the same thing as causation. It's like maybe you wear your lucky underwear to a ball game and your team keeps winning. Does that mean your undies are the secret sauce to victory? Probably not. That's correlation. Causation, on the other hand, is more like eating a bunch of spicy tacos and ending up with a stomachache. That's a straight line. A leads to B. Now, what if it's metabolic disease or prediabetes pulling the strings, causing both rising LDL and heart attacks? And guess what? That's exactly what's happening. Imagine a world where 80% of metabolic disease is flying under the radar, undiagnosed. No wonder there's this widespread belief that LDL is the big bad wolf of cardiovascular disease. The lipidology crew, they're folks who've been knee-deep studying fats and heart attacks, lipids. They're so locked into the LDL narrative that they may be missing the forest for the trees. Now, here's a twist. They talk about this thing called LDL discordance. It's when LDL levels don't line up with the risk they assume that it should. It's like trying to piece together a puzzle, but the pieces don't all fit. They're so focused on finding the correlations, maybe they're mixing up the numbers and ending up with a different story. It's been known for quite a while that in some folks, when they cut carbs, their LDL, their so-called bad cholesterol, skyrockets. But it's not clear that these folks with sky-high LDL, because of carb restriction, are at any greater risk for heart problems. There's this term floating around, lean mass hyperresponder. It's about genetic differences. Some people drop carbs, and while other health markers improve, their LDL goes through the roof. Matthew Butoff, he's a cardiologist known for cardiology research, and Dave Feldman is an engineer who stumbled onto this mystery. They're digging into this with a study. They checked out these lean mass hyperresponders. There were 100 of them. They had an average LDL of 250. That's off the charts. That's 1 in 1,000. And yet, these 100 people didn't have more plaque than people with normal LDL levels. So what's the deal with that? Well, we're waiting to see, but here's the kicker. The same lifestyle factors leading to prediabetes or metabolic disease can also push up LDL and inflammation. Most people with climbing LDL aren't getting leaner. They're gaining weight because they're not burning carbs or fats efficiently or effectively. This excess fat gets stored not just under the skin or around organs. You've heard of peri-organ fat or abdominal fat, apple-shaped gut. This fat's also getting stored in LDL. Can we say LDL isn't linked with plaque? No, we cannot. In fact, high LDL usually does go hand in hand with more plaque, higher heart attack risk, except for those lean mass hyperresponders. But is it as cut and dried as the lipidologists want to believe? A straight line between LDL and heart attack? I don't think so. We got to look deeper. We've got to consider LDL discordance and other factors that we've talked about. Most of all, we have to consider the fact that 90% of people with carb metabolism problems don't know it because it hasn't been diagnosed yet. Common misconception number 2. People assume that if they're in their 20s and 30s, they don't have plaque. There are plenty of young guns, folks in their 20s and 30s, already collecting plaque in their arteries, setting up the stage for trouble. as they cruise into their 40s and 50s. It's like a ticking time bomb. So, what's loading the dice? We're talking age, genetics, and obesity. And don't forget, obesity is often riding shotgun with high blood sugar and hyperinsulinemia. That's a fancy word for too much insulin in the blood. This is just what we've been talking about. Now, picture this, the CIMT graphs. Remember the CIMT, that tool that helps you show the plaque story in your own arteries by taking an ultrasound in the neck? Once you get a gander at this nomogram, it's like a reality check. And this isn't just about folks with special risks. It's your everyday Joe and Jane. The CIMT is safe as houses. No worries there. We've seen this plaque buildup show starting as early as 5 years old. It's like watching a slow motion movie of plaque creeping up year after year, decade after decade. And here's the real deal. You think 30-somethings are immune to plaque? Check out this CIMT picture. Oh, and see those lines? The blue one's for the fellas, pink for the ladies. Think about it. Here's the twist. Does that give you a clue regarding why guys usually face the music, heart attack wise, about a decade before the ladies? Common misconception number 3. People assume that if they don't eat sugar, they don't have plaque. People think if they dodge sugar, they're dodging plaque. But here's the kicker. Table sugar, the sweet stuff we all know, it's got a glycemic index of just 50. That means it's only sending your blood sugar half the roller coaster ride that pure glucose does. Now, this doesn't mean that table sugar is safe. It's just not the only culprit, and it's really not the worst. But hold on, it gets wilder. You know those everyday staples, bread, pasta, juices? Bread and pasta especially are like stealthy ninjas when it comes to hiking up your blood sugar. These bad boys have a glycemic index, and that's through the roof, making them sneakier and quicker at spiking your blood sugar levels than your ordinary table sugar. Common misconception number 4. You can reverse the cholesterol in your plaque. There's this misconception floating around, folks thinking they can just reverse the cholesterol in their plaque like flipping a switch. But here's the real talk. You can't just hit rewind on that cholesterol in your plaque. It's not like erasing a mistake on a chalkboard. What you can do, though, is reduce inflammation. That's like calming the storm, stabilizing your cardiovascular risk. Think about it like this. When plaque calcifies, it's like settling down, finding its peace. Because plaque calcifying, that's its way of healing, of getting stable. You don't just magic away plaque. You make it chill out. You stabilize it. It's kind of like trying to remove water from gelatin. Common misconception number 5. A stress test will predict a heart attack. A stress test will predict a heart attack? That's like, okay, a stress test measures how well you can scale a mountain, how fast you can run, how your cardiovascular fitness is. It's checking your cardiovascular fitness, your heart's mojo. Sure, there's a bit of a connection here to your probability of not having a heart attack, but that's just not the whole story. Take Tim Russert, for example. This guy was a runner, maybe not an Olympian, but he had his game on. Russert, he aced his stress test, colors flying high, and then, out of the blue, a few weeks later, the man's gone. Sudden heart attack. So what gives? Pumping up your heart's muscle does wonders for your pipes, helping them flex and expand, and you get more of those tiny blood vessels weaving into your muscle. Getting your workout groove on, that's gold. It does drop your blood sugar, keeps you fit, and running, high-intensity interval work, resistance training, all of that stuff really works well. But here's the kicker. Just because you can breeze through a stress test, it doesn't mean you're bulletproof against a heart attack. It's like thinking you're safe from a storm just because you've got an umbrella. Life, especially your heart, is a lot more complex than a single test. Common misconception number 6. A stent will prevent a heart attack. We've chatted about this before. There are these big deal trials, the Courage trial, Orbita trial, the Ischemia trial. They all pointed to one clear thing: stents, even those fancy cardiac bypass grafts, they're called cabbages, coronary artery bypass graft. These things don't, they're high-tech plumbing fixes, but they don't prevent heart attacks and strokes. It's a shocker, considering that over 90% of these procedures are done thinking that they will. But hold up. Don't get it twisted. Stents can be lifesavers, real heroes in the clutch. If you're caught in the grip of a heart attack, racing to the hospital or getting an ambulance to the hospital is your best bet. In these moments, a stent can swoop in, clear out the clot, save your life on the spot. So what's the real score here? Less than 10% of stents are used in those life and death moments and can save your heart. The other 90% of stents, they're put in with the hope of preventing a heart attack down the road in the future, but they don't do that. They just don't work out that way. This all circles back to a mix-up in thinking, believing your arteries are like rigid copper pipes when they're more like those newfangled expandable garden hoses. Life, especially when it comes to our hearts, is not as straightforward as fixing a leaky faucet. It's about understanding the whole system, not just patching up parts. Common misconception number 7. If a stent doesn't prevent a heart attack, a bypass will. Now, let's roll back the tape to that earlier mix-up. The ischemia trials, when the Orbita and Courage trials hit the scene, the thoracic surgeons were leaning back, tipping their hats, thinking, all right, this is our time. They've finally figured out that stents don't prevent heart attacks, so it always has to be a bypass graft. That's the thing that prevents heart attacks. Hold on, pump the brakes. The ischemia trials, they were dialed in to put this exact idea to the test. And what did they find? Bypass grafts, they're not the silver bullet for stopping heart attacks, for preventing them either. It's like thinking you need a bigger boat when what you need to understand is the ocean. We're learning that fixing hearts isn't just about diving in with surgery or procedures. It's more about understanding the whole map, your metabolism. It's not just choosing a different route. Remember, it's metabolism that drives tissue damage or tissue health. And with that, we move into the 4 food and supplement distortions that have been touted to you all along about how they can actually help you or do anything for your arteries, the gunk inside them, and how that interacts with whether or not you'll have a heart attack or stroke, leading us to some answers that you may not have heard of before. Food and supplement distortion number 1, apple cider vinegar. Food and supplement distortion number 2, vitamin K2. Food and supplement distortion number 3, vitamin D. Food and supplement distortion number 4, niacin. Food and supplement distortion number 1, apple cider vinegar. Now, there's chat about it working through a satiety thing, apple cider vinegar, slowing your stomach, keeping your stomach emptying slower to decrease the sugar impact in your blood, making you feel full, and maybe tweaking the stomach acid a little bit. It's supposed to slow down how fast your food gets through the old digestive tract. But here's where it gets a little bit wild. Most of the tall tales about apple cider vinegar, they're like a fish story that just keeps growing. We're talking claims that are stretched so thin, they're practically see-through at this point. Some are just plain out there, the kind of stuff that makes you wonder about what planet they came from. Misconception number 2, vitamin K2. So the word on the street is that K2 waltzes in, yanks calcium out of your arteries, and plants it right in your bones. But hold your horses. It's not that straightforward. It's more about those enzymes doing their thing. Now, if I could just pluck calcium out of my artery wall, like picking apples off a tree, sure, that'd be dandy for reducing heart risks, maybe. But here's the real deal. Calcium in those artery walls, it's really more like a telltale sign of how stable your plaque is. So, this whole idea of fishing calcium out of your arteries, what's the point? There was this study, a bunch of middle aged guys with diabetes. They gave one group K2 and the other group a placebo. Here's what happened: the K2 crew showed some improvement in their insulin resistance, their diabetes. So here's where K2 might be playing a sneaky game. It might be messing with insulin resistance or diabetes, maybe even giving it a nudge in the right direction. K2's been on the rise. It's kind of like a rock star in the supplement charts. You've got sources of this stuff popping up left and right and doubling over the past year, all over the internet. It's like a K2 wildfire on YouTube. But when you dig into the nitty-gritty, it's really more of a murky picture. It's not really crystal clear that K2 is playing the calcium relocation game from arteries to bones. But where it might be throwing a punch is in the insulin resistance ring. Food and supplement misconception number 3, vitamin D. There's a heap of evidence, a whole mountain of it, saying vitamin D is the real deal. It works. But let's take a step back, slow it down, and look at this evidence. Most of what we've got on vitamin D is like connecting dots. It's all about correlation. When it comes to hardcore cause and effect proof, well, there's not much of that rodeo. Vitamin D, when you give it a good look, it's like a Swiss Army knife. It helps with sleep, nudges prediabetes in the right direction, boosts immune health, and it seems to be more about hitting the core of the system, maybe getting cozy with the mitochondria. But let's circle back to the whole correlation and causation thing. What we've got with vitamin D isn't like causation. That's really straightforward, like tossing a rock at a beehive and getting stung. That's causation, clear as day. But the vitamin D story, it's more like correlation. It's like wearing your lucky socks to a football game and your team wins. Is it the socks? Well, maybe, maybe not. That's the world of correlation. After going back and forth on this, you may be wondering and asking, what do? I do use vitamin D, D3. I start with 5,000 international units, and then, you got it, test, don't guess. Get it to a blood level between 50 and 90. So, food supplement misconception number 4, niacin. Whenever niacin pops up, you got to think about David Sinclair. This guy's all about the mitochondria, those powerhouses in our cells. Dive into any of his books, like Lifespan, and you see he's got a strong pitch for niacin and niacin-related products. He argues it's like a tune-up for your mitochondria. He wants to create and sell a pill form of the fountain of youth. But here's where it gets interesting. We've got folks coming in thinking niacin's the golden ticket, the answer to everything. Sinclair? He's the brain behind discoveries like resveratrol, the sirtuins, and his latest hit, NMN, what some are calling the forever pill. But let's not get ahead of ourselves. Sure, there's solid evidence backing niacin, but it's not exactly the miracle worker it's often made out to be. I wouldn't bet my whole life on just niacin, you know. It's in our practice. It's one of the big 2 supplements that we use, niacin and vitamin D. But the key? Knowing when to use them, what to hold on to and what to let go. We see a lot more folks walking in all charged up about niacin, more than we actually recommend. It's like they're hearing a whisper about it and they come running. So, we've been through the misunderstandings, the real questions you should be asking, the most common misconceptions, and all those food and supplement distortions you've been deceived by. Which leaves you probably still asking the question, what foods, if any, have beneficial effects on your arteries? What is that number 1 meal to clean out your arteries? Now, when we're talking about what grub might be giving your arteries a high five, first things first, you got to tune into your body's rhythm. Like for some folks, downing 75 grams of carbs, glucose, that's like a large Coke at McDonald's. That sets their arteries ablaze for hours. And for others, a simple hamburger bun or a couple of slices of pizza can kick off a blood sugar storm, a hoedown that lasts way too long, stirring up inflammation in those artery walls. But let's get real. There ain't no magic Roto-Rooter food out there. No Roto-Rooter food. What we do have, though, are foods that don't throw gasoline on the fire. Ever heard that old saying? If you find yourself in a hole and you want to get out of that hole, stop digging. That's the deal with food and arteries. So you might not want to hear this, but yep, salads, broccoli, cauliflower, all that veggie stuff and rabbit food, they can be your arteries' best friends. And protein, that's no trouble either. Fish, good to go. Red meat, all right. We're stepping into that whole carnivore versus plant-based showdown. I know. The plant-based diet fans might not want to hear this, but there's a growing pile of evidence saying that saturated fat isn't the artery arsonist that we thought it was. But here's the kicker. Remember how we talked about our own body fat being a backstage troublemaker in prediabetes? Saturated fat's like a calorie-packed party. A lot of folks find it tough to keep their body fat in check if they're loading up on saturated fat. And what about this keto burn idea? You know, the one where you can eat like a king all you want, as long as the carbs just aren't on the menu? Well, we do burn a little bit less efficiently when we're in ketosis, maybe 20%, and for some people, even 30% less efficient burn when they're not eating carbs. But that's really where it caps out. You can't just triple your calories and suspect ketosis to make it all go away, to make it vanish. So now we're there. We're finally at it. The number one meal to clean out your arteries. And what is it? It's actually the lack of a meal. It's fasting. Let's dive right into that. The why, the how, the magic. Question number one, why is fasting the best meal for cleaning out your arteries? Question number two, which form of fasting has the biggest impact in cleaning out your arteries? And question number three, does having clean arteries actually even matter? Question number one, why is fasting the best meal for cleaning out your arteries? Fasting is not just a weight loss journey, but a path to cellular tune-up. Fasting is often hitched to shedding pounds, but its real star role is in this thing called autophagy. Think of autophagy like a cleanup crew inside your cells, healing out the broken parts and turning them into new energy. This whole process, it's like a reset button, dialing down inflammation and boosting your overall health vibe. Fasting is a crafty tool for fine-tuning metabolic health, turning down the heat on inflammation, all without tipping the scale. But, and this is the key, fasting's a road that needs careful navigation. You got to make sure you're fueling up enough to dodge malnutrition, but that's not as difficult as some people think. Question number two, which form of fasting has the biggest impact on cleaning out one's arteries? Prolonged water fasting, it's like hitting the turbo button. Big, quick impact. But here's the thing. If shedding weight isn't on your to-do list, this might not be your best bet. This health journey we're talking about, it's not a quick dash or even a long-haul marathon. Marathons wrap up in a few hours. But what we're diving into, it's a lifelong gig, a real game changer. It's about reshaping your whole eating playbook for keeps. And let's talk about this yo-yo fasting rodeo. Dropping weight, picking it back, adding 10 pounds, losing 10 pounds, adding it back. That's like a ride nobody wants to be on. So what's prolonged water fasting? Why is that the heavyweight champion of impact? Well, it's simple. It slashes calories like no other, at least on an immediate basis. The steeper and swifter you cut those calories, the faster you're diving into autophagy. But remember, we're playing the long game here. Say your metabolic rate's 2,000 calories a day. Skip eating for 2 days and you dodge 4,000 calories. Trim just 10% off of your daily intake for a week, and you're only sidestepping 1,400 calories. But keep that up every day for a month, and you're cutting out 5,600 calories. So what works for you? That's really the golden question. Some folks ride the wave of prolonged fasting, maybe every other week, sometime once a month or a quarter. Others groove better with intermittent fasting or time-restricted eating. Then you've got the creative ones that are trying things like sardine fasts. Find your groove, something you can jam with for the long haul. And those caveats to fasting for arterial health, some folks worry it's like a risky business. But let's be real. Humans have been fasting since the dawn of time. It's not some major hazard, except maybe for good health. Sure, it might make you a bit edgy, a little bit grumpy while you're at it, but that's just part of the ride with fasting. The assumption that a meal can clean your arteries. So besides the lack of a meal and activating autophagy, it really isn't about one special meal cleaning your arteries. It's the whole lifestyle. Diet's the king of the castle because you can't fast all the time. It's about what you're munching on 24/7, day in, day out, week after week, year after year, decade after decade. It's about reshaping your permanent eating habits. Rule numero uno, get to know your own metabolism. That's the key. Take a gander at some of the latest scoop. It looks like folks over 18 struggle with burning carbs, at least half of them. So when you're not burning carbs right, you start pumping out more insulin. And too much insulin puts the brakes on burning fat. It's like starting with a problem in one fuel tank and ending up with both tanks being on the fritz, leading to the Grim Reaper's insulin spiral of death. We talked about that before. Question number 3. Does having squeaky clean arteries really matter? Well, yeah. That depends on your definition of clean. If we're talking about arteries free of plaque, then it matters a lot. Why, do you ask? Plaque in those arteries is like having a ticking time bomb for cardiovascular events, the kind that can lead to some serious harm and even check you out of the game permanently. But here's the twist. The real McCoy in this story, it's not that plaque itself is the bad guy. It's the inflammation that comes with it. It's like an angry posse in your bloodstream. Inflammation, that's what really stirs up the danger. It's like having a quiet troublemaker in the crowd. You don't even see the trouble until it's already up on you. Fasting doesn't just help with weight. It triggers something a lot deeper, a cellular cleanup system called autophagy. Think of it like a microscopic janitor crew, identifying and removing damaged cells, inflamed tissue, and even the early components of soft plaque. That's right, that's what I said. Even the early components of that soft, dangerous plaque. And that part's critical because it's not just the hard calcified plaque that causes heart attacks. In fact, that usually doesn't. It's the soft plaque, the unstable kind, the kind that's full of what we call cytokines, oozing liquid. It's like a snot. It's not stable. It ruptures suddenly. That in turn triggers a clot, and it turns a quiet artery into a deadly blockage. If it's a big enough clot and it goes to the heart, that's a heart attack. If it's big enough and it goes to the brain, that's a stroke. If it's microscopic and it goes to the heart, that can cause, month after month, year after year, decade after decade, it can cause the heart microscopically to look like Swiss cheese and get into heart failure. That fasting and autophagy slows down inflammation and improves arterial health. That's the goal here, arterial health. Now, that's part of the story because when it comes to heart disease, there's still massive confusion, even among doctors, about what really drives all this risk anyway. Now, you've probably heard people say it's all about your LDL cholesterol, the quote, bad cholesterol. That's a half-truth at best, and in some cases, it's really dangerously misleading. So before we go any further, let's talk about some of the biggest misconceptions, misperceptions about plaque, cholesterol, and what truly matters when it comes to predicting and preventing heart attacks. You might be surprised by what the research actually says.
People are still watching, commenting, and talking about what's that one best meal to clear your arteries. Now, does that meal even exist? Maybe. But can one meal reduce your arterial plaque to 0? That's impossible. You just can't achieve that. But how about stabilizing plaque? Yes, almost every one of us can practically expect to stabilize our plaque. And if we do, the risk is very little, just a tiny bit more than having no plaque at all. And that's about as close as you can get. But that's enough, because you're taking over 90% of the risk off the table. But back to the meal. What is that meal? Well, again, it is the lack of a meal. Fasting. Yep, you heard that right. Fasting. But how you fast carries some challenges, like what is the best type of fasting? Can you eat or drink something during your fast? Should you fast for a couple of hours, couple of days, weeks? Some people have done it for months. What about those diets that mimic fasting? Do those really work? And what about the controversies? Oh yes, I know. There are prominent health influencers right now saying fasting's actually a bad idea. Have you heard the new buzzword for longevity? Autophagy. It's been around for years, at least a decade. But what exactly is autophagy, and why is it important? Is it worth starving yourself to clean out your arteries and to reach autophagy? And if that's the case, is autophagy really the mechanism that cleans your arteries? Or is it just a calorie thing? We're going to be answering all those questions in this video. And we're going to do it in a quick and simple way so that you have the information you need to decide for yourself whether fasting's right for you. Why am I saying that fasting can clean your arteries? It starts with one simple process called autophagy. Now, autophagy, well, maybe it's not that simple, but let's break it down and it becomes clearer. Autophagy literally means self-eating. You break it down. Auto means self and phage means to eat. It is a more complex process. Cells are able to break down old proteins, molecules, and what we call organelles, portions or parts of the cell. The classic one is mitochondria. Why mitochondria? Because mitochondria are so important in the cell. They're like a furnace, the energy factory of the cell. And like any furnace that's 40, 50, 60, 70 years old, you can see some breakdown there. And in fact, with the chemical processes going on in there, you could see some leakage and not good things coming out of it. Anyhow, more about that later. Think about renovating your house, but instead of throwing away the broken bricks, glass, wood, you recycle them. You put them back together and use it to create a totally new house, a better house. It's a renewal process. That's why autophagy's been linked to longevity. Cleaning out old cells and creating new, more efficient cells, or at least cleaning out old cell organelles and creating new, more efficient ones, is what this is all about. And guess what causes the process to happen? You guessed it, fasting. Now, when you fast, you're putting your body into, you can say a survival mode, you can say stress, but it's the kind of stress similar to exercise for your muscles that helps you to grow stronger. It helps your cells to grow stronger, which makes your tissue grow stronger. Getting rid of old proteins, old cell organelles, and molecules and creating new ones is what this is all about. This happens in basically all the cells of your body, but more in the metabolically active cells. For example, the liver. Autophagy in the liver triggers fat burning. Now, you might be asking, what does this process have to do with cleaning out your arteries? In order to answer that, we need to get this part straight. Clogged arteries and arterial plaque are not just caused by cholesterol. There is cholesterol in there, but it is not the main problem. Yes, I'm going to say that again. There is cholesterol in the plaque, but the cholesterol is not the main problem. There's an even deeper problem. It's called cardiovascular inflammation. Cardiovascular inflammation's like having a fire inside the walls of your arteries, and it's actually friendly fire, meaning it's not coming from a foreign enemy, an outside threat. It's actually coming from your own body. Your immune cells, the ones that are supposed to protect you, are trying to do exactly that. But in the process, they're creating havoc and chaos within your artery walls. It's similar to pus or snot. It's filled with those immune cells, and we call it hot inflammatory plaque. And it can rupture. If it ruptures and touches the blood, that causes a clot. If the clot's big enough and it goes to the heart, it's a heart attack. If that clot is big enough and it goes to the brain, it's a stroke. This is more of an event type of activity. That's also why you really cannot predict the timing of a heart attack. If it were a waxy buildup, you could predict it, but you can't. How does autophagy help with all of that? Well, there are two main ways. First, the autophagy process happens in all cells, including immune cells. So by triggering autophagy with fasting, those immune cells in your arteries start to calm down because they're now in the process of autophagy themselves. They're their mitochondria that are not working well. They're using them for energy. They become less and less active in terms of inflammation. The second way is depriving your body from a major cause of cardiovascular inflammation. Carbs, carbohydrates, yep, they are a major cause of cardiovascular inflammation. When you eat a lot of carbs, or even moderate amounts of processed carbs, you get increased blood glucose and increased insulin. Both, either one, can trigger inflammation within your vessels, causing more of that hot liquid in your artery walls. But by fasting, you keep your body from absorbing carbs, and you keep your pancreas from producing excess insulin. You stop putting wood on the fire. But here's the question. How long should I fast? What kind of fast should I do? Well, let's first talk about how long you should fast. And even a 5-hour fast does have positive impact. But the right balance is probably somewhere between 14 hours and 2 to 4 weeks. So as you can see, even fasting's not that simple. Even just the simple question of how long you should fast. We'll talk more about that, about how and when to fast. If you're still skeptical, you might be thinking, if autophagy is such a great thing for living longer, and fasting is great for that, why don't we just fast all day, every day? Well, that's just like a lot of things in life. You got to have balance. And like the old Rally commercial, you got to eat. Excess autophagy can lead to significant cell destruction without enough recycling. So it's not a magic strategy to just do all the time. Autophagy is more like a tool. And tools, one of the most important things to learn about tools, we talked about that back in the aspirin video. One of the most important things to learn about a tool is when not to use it. So let's talk about types of fasting and what are the best types to reach autophagy to clean arteries. With ADF, or alternate day fasting, you can eat unrestrictedly one day and fast the next. MADF, modified alternate day fasting, allows for different variations. For example, eating unrestricted one day and on the other day have some sort of fasting where you just eat less calories. Here's another version of MADF, modified alternate day fasting. On this one, you say, okay, water fast today, one meal a day on the second day, or OMAD. That is a very powerful type of pattern. I've got tons of patients that have come to me that are in the process or have already lost 30, 50, 80, and over 100 pounds using this method, 1 meal a day, every other day, with alternate days on fasting. Now, there's a lot of people like me, for example, I don't need to lose 100 pounds. Like we said, fasting is not so simple. You need to think through what you need and what the timing is that makes sense for you. Let's go back to the other end of the scale, time-restricted eating, TRE. It involves fasting from 12, usually 23, 22 hours each day. Here's another option, prolonged fasting. It can be done with water only. A water fast, you can do it with other things like a sardine fast, like Dr. Boz likes to do. Or Walter Longo has a fasting mimicking diet. But in order to be considered a prolonged fast, let's make sure we define that first. You have to go for at least 24 hours. What does the literature say? There is an umbrella review on fasting. It showed that any type of intermittent fasting will have clear benefits in multiple bioindicators. Intermittent fasting has been shown in the umbrella review and therefore plenty of studies that it decreases waist circumference, body fat, LDL cholesterol, if you have concern about that. It decreases triglycerides, fasting insulin, blood pressure, and it increases HDL, cholesterol, and fat-free mass. All of these are significant positive markers. They'll lead to arterial plaque reversal or at least stabilization, which is what you need. Because of ethical considerations, research in prolonged fasting is hard to find. But I have a couple of examples for you. Here's the first one. A recent paper reports a 64-year-old male with significant heart disease, heart failure, diabetes, and obesity. He underwent a 50-day water fast. He lost 50 pounds, and his hemoglobin A1C went from 10.3 to 8.3. I have to tell you, that was really my biggest surprise when we looked at this study. I would have expected it to go far, far lower. Unfortunately, we don't have more information about changes in his arterial plaque. In this case, we have a big warning to anyone who starts considering prolonged fasting, clearly that the type of prolonged fasting that he did. If you don't recover electrolytes, if you don't keep electrolytes, if you don't supply your body with electrolytes, you have a lot of risk with fasting. You know, there's some recent information coming out about dry fasting. You see a couple of YouTube content creators talking about how much more effective dry fasting is. That's really where other YouTube creators, and myself included, would say, be very careful doing dry fasting. Be very careful replacing your electrolytes. Low potassium can increase heart rhythm problems, and they can be fatal. Additional dehydration, even kidney failure, comes with loss of sodium, and you just feel terrible if you lose too much magnesium. Sodium, potassium, magnesium, these are all very important, and they are the electrolytes that you need to keep an eye on if you're doing fasting, especially prolonged fasting. If you want to review this with a medical provider that understands fasting and you don't have one, again, it probably is a good idea, at least the first few times that you fast. If your provider doesn't understand it, you can call our group, 859-721-1414. Now, the second example, remember that was just one example of prolonged fasting. The second example is Biosphere 2. You remember that? That was way back over 20 years ago. It was headed up by Roy Walford. You know, you may or may not remember who he is, and you may or may not connect the dots. He was the faculty advisor for Walter Longo, the guy doing the fasting mimicking diet, Prolon. Roy Walford, the Biosphere 2. It was a big terrarium built way out in the desert in Arizona. He and a group, Tabor McCallum, Dennis Mock, Roy Verdery, they published an article that described what happened with severe caloric restriction, about 2 years of it, or significant caloric restriction. This included 4 females, 4 males, Walford and McCallum were included in the group. During 7/8 of that time, they consumed 1,750 to 2,100 calories per day. That sounds like a lot, right? Well, they did eat what most would consider nutrient-dense foods. They were all plant-based because they were in that terrarium without animals. It included 77% complex carbohydrates. So even though there was a 77% component of complex carbohydrates, they lost in the first month 17% of their weight on average. That's a lot. They had a decrease in blood pressure, a decrease in blood cell count, a decrease in insulin, a decrease in thyroid hormones, and decrease in lipids, cholesterols. I even have a third example. Me. I reversed 20 years of arterial plaque in about a year, and I've kept that progress up until present day. A part of that journey did involve fasting. About 6 months ago, I did another fast. It was a 5-day water fast. I lost 10 pounds in 5 days. I didn't do a lot of exercise because I'm not that seasoned at prolonged fasting. You really need to be very, very experienced at prolonged fasting if you do any more than just walking. Yes, I did plenty of walking, but that's about it. Doing exercise in the midst of a prolonged fast can really amp up the stress. So let's go back to mine. I lost 10 pounds, 5-day water fast, and then I started refeeding. Now, my goal was not to lose weight. I had a weight of about 160, circumference of my belly of 33 at my belly button. I just wanted to improve my metabolism. I lost 10 pounds. Obviously, most of that's going to come from water weight, glycogen in the liver, and glycogen in the muscles. What happened after I refed? Within 2 weeks of refeeding, I had started my exercises again. And these are aggressive exercises for a 67-year-old. A 60-pound rigorous sled pull, a 4-mile run with HIIT on it, and the HIIT is about 8 different hill sprints, a lot of resistance training. And so, again, within 2 weeks, I was back up to the 160 and then 162. But my belly circumference, it was still at the lower amount of 32, not 33. So the point being is, I gained my muscle back and then some after that 5-day water fast. So as a personal experience, yes, I lost immediate muscle. But again, water in the muscle, within 2 weeks, I had more of it than I had prior to the fast. So, you remember I talked about Walter Longo and the fasting mimicking diet? Let's go back to that for a minute. The fasting mimicking diet that Walter Longo talks about is low calories. So the first of the 5 days, you're like 1,200 calories. Then days 2 through 5, you're 700 to 800 calories. This is moderate to low protein, low fat, very low fat, and high carb, complex plant-based carbs. This is a plant-based diet. It's supposed to mimic the effects of prolonged fasting. When you look at it and you're somebody like me, I monitored my blood sugar when I did those. I did, about a half dozen of these. And then I started monitoring my blood sugar and found that when I would do those soups, like the tomato soup, my blood sugar would go up to like 170, 180. I don't think that was necessarily that caused that much injury. I'd just go out and take a walk. But let's go back and talk about the studies. Studies in adult males and females, humans, that concluded a fasting mimicking diet was at least as good as the Mediterranean diet to decrease insulin resistance and slightly better to keep or even gain muscle. So again, more examples of decreasing calories during a fasting episode and maintaining or even gaining muscle. I mentioned my blood sugars going up. That's when I heard Dr. Boz talking about a sardine fast. So I started doing kipper fasts as opposed to Prolon. So kippers gave me more oil and more protein, and they didn't spike my blood sugars. Now, Let's go back. Let's talk about something else, fasting and cardiovascular health. In an abstract presented at an American Heart Association summit this year, it states that intermittent fasting increases the risk of cardiovascular death by 91%. Wait a minute. Didn't you hear sort of like the scratched record kind of thing? Let me repeat this. In an abstract presented at the American Heart Association summit this year, it stated that intermittent fasting can increase the risk of cardiovascular death by 91%. Well, you see my eyes rolling and you see the nonverbals here. The reality is that these types of publications are often full of flaws. You remember we've discussed multiple times Dr. John Ioannidis at Stanford. He published one of the articles that's the most downloaded article in PLOS, the Public Library of Science. It's titled, Most Studies Are Wrong. And he goes into a whole lot of really good analysis, pointing out that you really should be careful what you read in terms of science. The peer review process to publish a paper like the one we just mentioned, stating that intermittent fasting increases the risk of cardiovascular death, it was a paper at a summit. The peer review process is just not very strict. Speaking of peer review, it's better for publications, but you know from multiple videos that we've done, you've got to be careful of publications as well. The peer review process is better to get into published journals, and it's better for some journals than others. But, we've talked about even some of the top journals in medicine, like the New England Journal, have let some stuff go through that they should regret. So again, think through anything that you read in terms of, quote, science. And let's go back to an item that I brought up earlier, muscle loss. Peter Attia, Rhonda Patrick, they said recently they don't skip breakfast anymore. I agree with that. And I agree with most of what both of them say, not all. Breakfast is important. If you're going to do intermittent fasting, you're better to skip dinner, not breakfast. I could go down that bunny hole of talking about breakfast and the social components of it and the social components of dinner, the value of the two. Let's move on. We've only got so much time on this video. Let's go to one of the most important items in terms of this process and in terms of the title, the meal to clean your arteries or to stabilize your plaque. How does prolonged fasting fit with metabolic reset? What is a metabolic reset anyway? It's pushing your metabolism into autophagy, giving you a boost, getting you adapted to fat burning, and then keeping you in a healthy, low-carb lifestyle. Is the benefit from autophagy or is it from caloric restriction? In a recent claim, Dr. Brad Stanfield, on one of his videos, states the evidence supports the idea that benefits from fasting come from caloric restriction, not autophagy. Again, I'm not going there yet. I think the evidence is not strong enough to say that the only reason, even if you think fasting is only about caloric restriction, that the only reason is calorie restriction, that autophagy is not making an impact. Again, we've had Nobel Prizes won over the deep science associated with understanding time-restricted eating and autophagy. I do believe this. When you're not fasting, it's important to get the most micronutrients that your body needs, or maybe not the most, the correct balance, the correct amount of micronutrients. And with some of the restrictive diets that you see out there, they can be good for helping you manage carbs, which can be poisonous to some people if you have insulin resistance. Be careful with the restrictive diets to make sure you're getting the right micronutrients. You can track this information and avoid making vital mistakes. Now, additionally, if you're very thin, like a BMI 20 or less, consider strongly how you do fasting, especially prolonged fasting, things that will often result in significant weight loss. Not getting enough micronutrients can actually be harmful. So again, and as we mentioned before, loss and failure to replace electrolytes is a very, very big deal. So regardless of the type of diet you follow, how many calories you're eating, I recommend using tools like Chronometer. It's an app, and no, they didn't sponsor this video. They don't sponsor us at all. It's a way to track your macronutrients. There are others out there as well, and they're getting better and better each year. Back in the old days, I had to do it with a paper pocket book, a little book about this size that you kept in your back pocket. Now you've got software that's better and better. Now, this way you can know the type of foods you need to include and what supplements to consider.
So Jesus and I just reviewed the final cut of this video. We noticed something was missing. What's my clear recommendation? So here we go. I believe intermittent fasting, and especially prolonged fasting, they have to be individualized decisions. In general, I believe most people benefit from a fasting period of about 16 hours to trigger autophagy. You don't have to do that every day. I don't. I also recommend prolonged fasting, 24 hours a day or more. Other types of fasts, like sardine fasting, are helpful. I use a kipper fast because I just don't like sardines. Now, it does help to have a few weeks or even months of low-carb or ketogenic diet, plus some form of intermittent fasting. It helps to have your body fat adapted, because when you go fasting, here's what you're doing. It's like you're switching fuel tanks yet again. So our body does know how to switch fuel tanks from carbs to fat, and fat in our diet to fat in our body. We just need to exercise it a little bit, and that's a little bit of stress, just like any other type of exercise. Here's the thing that I feel most strongly about in all of this. Never try prolonged fasting without preparation. Watch out for things like electrolytes. To find out more info, check the description of this video. We have over 20 references for you. Check those regarding fasting and cardiovascular health.
Now you know a lot more about fasting, the evidence that backs it up, and how it can actually help you stabilize or clean your arteries. At least stabilize your plaque, and therefore accomplish what so many of us want to do. Take the risk of heart attack and stroke off the table.
As you've seen, most people, and yes, even many well-meaning doctors, are focused on the wrong numbers. They chase total cholesterol, obsess over LDL, the quote bad cholesterol, and they overlook the deeper drivers of plaque buildup. But once you understand what really matters, inflammation, insulin resistance, metabolic dysfunction, prediabetes and diabetes, the question becomes, what can you actually do about it? This is where things actually, they go the other direction. They're not bad, they're good, because you begin to see a way out of this risk. Because unlike genetics or aging, you can't really change your genetics. You certainly can't change your chronological age. But lifestyle, and especially body composition, is something you can control. And when it's done right, it doesn't just slow down plaque. It stabilizes the plaque. It reverses the risk. It takes that cardiovascular risk off the table. I'm not talking about fad diets. I'm not talking about unsustainable programs. I'm talking about real, research-based changes that have helped thousands of patients, including me, reduce soft plaque, stabilize their arteries, return to arterial health that they had in their youth, and reclaim that cardiovascular health and longevity. Now let's get a little bit deeper. I was able to reverse about 20 years worth of plaque, so I can tell you it can be done. But one of the questions is, how do you do that? How do you actually unclog arteries? We're going to discuss all the aspects you need to address this. The first one is the big one. We're sitting here in the kitchen, obviously, but we're going to be talking about arteries. Like a drain in the kitchen, if it gets clogged, it can wreak havoc. If arteries get clogged, they can wreak havoc. They can kill you. And just like a drain in the kitchen, arteries get clogged by what you put in them. And we have so many people get so worried about the different aspects and warnings about food and diet We decided to try to make it a lot simpler today. If it's on this side of the table, don't eat it. It will clog your arteries. If it's on this side of the table, you can eat it. It's safe. This is cereal. Complex carbohydrates that have just been ground up. Ultra-processed carbohydrates. Anything that comes from a flour is ultra-processed grains, and it's super-duper high-intensity carbohydrates. And the reason that's a problem is that most of us cannot fully and healthily metabolize those kind of carbohydrates. For example, even with cereals, the guys that sell these poisons recommend a dose of about this much, a cup to a cup and a half. And that's small. Your typical person, and 84% of this country eats cereal on a regular basis, and they eat more like twice this much. 30 grams of ultra-processed carbs. It can wreak havoc on your arteries in a full day. This is 60 to 80 grams of ultra-processed carbs. So again, please stay away from this side of the table. Now, when you get to talking about this side of the table, again, there will be a lot of things that come up, and that's why people get so confused. Let's look at this, for example, from the beginning. Who can hate on avocados? They're great, right? A wonderful source of healthy fats. Well, a lot of people do hate avocados. They just don't like them. And I'm telling you, I didn't like them either. But here's what I did. There's such an important part of a healthy diet. I just ate it and ate it and ate it until I started liking it. That's what I did with herring and sardines and some of that kind of stuff. That's actually what I did with cruciferous vegetables. These can also be a very, very healthy part of a diet. Now, I know people will say, oh, wait a minute. They make me bloat. They've got lectins. They've got oxalates. And all of those things are true. But you know what? These can still be a part of a healthy diet. And think about maybe just cooking these more fully, staying hydrated, and that will help with things like bloating. And I've had my own problems with oxalates. I had a major kidney stone that kept me sick for 6 weeks. I'm not going to bore you with that story. In fact, I'm going to go to something else that's very important in terms of a diet. This is salmon. We all get too many omega-6 fatty acids. We need to get more omega-3s, and people recognize that. And for years, everybody just saw salmon as the best, most practical way to do that. Until people started talking about salmon farming and microplastics and mercury. Those can all still be an issue for salmon, but I go back to the fact salmon is so much healthier. Even farm-raised salmon is healthier than Lucky Charms. I just have to tell you. And there's some other things too. If you're still into eating fish and you want to get omega-3s, you can try the mash fish, mackerel, anchovies, sardines, herring. Now, if you won't take any kind of animal product, but you want to get omega-3s, yes, you can get them with something like this. You might not be able to see it very well, but these are seeds. These are flax seeds. And yes, there are going to be people that start hating on flax seeds that already do. Flax seeds have to be fresh. They have to be ground. It's a problem for your body to digest them. And even if it digests them, your body does struggle to turn the omega-3s in flax seeds into the specific kind of omega-3s that your body needs. So yeah, there are challenges. Every food on this side of the table. So speaking of every food, here's another one. And this sort of mixes up the two sides of the table. This is sauerkraut. People love to think about the idea of supporting their gut biome with healthy bacteria, probiotics, and prebiotics. Now, when you think about that, most people think yogurt. I love yogurt and kombucha and some of these other things. One of the reasons those are so popular is that most of them, they're sweet. The human taste loves sweets. And unfortunately, most of the yogurts and kombuchas that you'll find out there have too many sugars. They actually belong on this side of the table. Now, some of them are healthy. But if you really want to take a reliable version of a fermented food, just stick with my favorite, sauerkraut, or something I'm trying to learn how to like. I had to learn how to like sauerkraut too. I'm trying to learn how to like kimchi as well. Again, all acquired tastes. Now, speaking of oxalates, like I mentioned a few minutes ago, and again, I won't go down that bunny hole of my pain from my kidney stone. I'm still a big fan of nuts, and there's several types of nuts. We've got 3 kinds here. We've got almonds, pecans, macadamia nuts. You know, a lot of people will say, besides the oxalates issue, they'll say, well, almonds have carbs in them, so they're not good for a keto diet. Oh, come on. I can eat plenty of almonds and still remain ketotic. Well, let me just say one other thing about almonds. Yes, they may have some carbs in them, but like Robert Lustig would say, and I agree with him on that point, those carbs in almonds are clearly wrapped in the antidote, fiber. And no, I'm not going to get started on that debate about fiber and whether it's really as healthy as people think. It can be a part of a healthy diet. Now, my 2 favorite nuts are the other 2, macadamia nuts and the nut from my region of the world, pecans. Or as so many people from around here say, pecans. These are great parts of a healthy diet. Now, that's it, right? Well, no, that's not quite it. There's one more thing. Saturated fats. Good old red meat and eggs. Now, if you're one of those people who still thinks that saturated fats cannot be part of a healthy diet, please think again. That's just not true. Maybe if you're a reader, read the book, The Big Fat Surprise by Nina Teicholz. Or if you're more of the science geeky side, there's a couple of really good meta-analyses that have been published since then in JACC, the Journal of the American College of Cardiology. Anyway, let's get a little bit deeper in this. We said diet is just not enough. Diet is king, but you need to use the energy you're consuming. You just got to burn it. If you don't burn it, it's going to start sticking there on your hips, your thighs, your belly. So movement improves circulation. It strengthens your heart. It helps burn off harmful fats. And that contributes to artery blockage. So that's what you want to do. You do want to move. You want to exercise. And exercise can be painful. It's also necessary. People in my generation may remember that old Listerine commercial, The Taste You Hate, once a day. And the point they're making is it may be bad, it may not feel good, but it's what you needed. We have found since then that it wasn't what you needed either. But it sort of underlines, what the guys say in Pumping Iron, no pain, no gain. Or what others will say, the road to heaven sometimes feels like hell. Sometimes you just got to do the work. And that's the case with exercise. So talking about exercise, what's the first thing that you need to do? Well, it depends. It almost always depends. It depends on the context. Now, if you're new to exercise, it's totally different from somebody who's got a long history of exercise and is already in good shape. Let's say you're new to exercise and you haven't exercised much at all in a long time. You might be thinking, I hate exercise. Most people that haven't done it a long time hate it. They think it's painful, and I don't really want to see benefits months from now. If I'm going to exercise, I want to see benefits immediately. Well, be careful about that, going down that road, because if you want to see exercise benefits immediately, you're probably going to try to go from 0 to 100. And not only is that not going to work, it can result in an injury. So here's what you should do. Start with small efforts, even walking. Walking is a great base to get started from. Some people go ahead and go from that to jogging or even sprinting. And sprinting is one of the big things that we want to do. In fact, the combination of walking and sprinting is a great long-term goal. But again, let's go back here. Let's rewind. Do that gradually. Don't get started immediately from doing nothing to sprinting. You just shouldn't exercise with difficult kind of things right out of the gate. Now, something else you need to remember is resistance training. I hate to say it, but the guys are right when they say, quote, no pain, no gain. But they're only right in certain contexts. The first context to remember is you don't want to start with pain. You don't want to start getting anywhere near pain for the first few months. Just start with something simple. Isometric exercise, just pushing against there like that, or squeezing something. Squeezing something gives you a better start on your grip strength. And grip strength has been shown multiple times to be a great bioindicator of longevity, healthy longevity. We don't know why. We don't know if the muscles here happen to stimulate your brain and your metabolism, or if it's the other way around. A good brain and a good metabolism stimulate those muscles. Or maybe there's a little bit of both. Nobody knows that. But what we do know is grip strength helps a lot. So again, even simple isometric exercises, and the aficionados here are going to say, and I'm going to get comments about it, isometrics are no good. Come on. I understand that. Isometrics are not the best for an advanced resistance muscle trainer bodybuilder. They don't use that. But that's not who we're talking about right now. We're talking about someone who's just getting started. And guess what? If you're in that position, starting is the most important part. Somebody who's not developed the routine of exercise is just should start doing the least possible as many times as possible. Again, what we call them, the iron heads, the people that are just into really working out, they're going to say, you need to do high weight, small reps, meaning as much weight as you can actually do for just 5 reps. I get that. There's clearly a place for that. And it's not with the beginner. I'd rather see you exercise 3 to 5 minutes, very simple, not getting a huge burn, 3 to even 5 times a day, than see you start off by going to a half hour or 1 hour thing at the gym once a week, even 3 or 4 times a week. I'd rather you take these things we call exercise snacks. Exercise snacks. You can end up feeling discouraged if you're just doing it once a week because you're not going to see that much difference. These 3 to 5 exercise snacks per day are really going to start improving your muscle tone. And that's a great place to start. As you progress, you'll see benefits. And then when you least expect it, your body's going to be saying, hey, let's push a little bit harder. Let's get some more exercise and let's make it a little bit harder. Exercise is great medicine for arteries. It promotes vasodilation and it reduces inflammation, improving chances of arterial plaque reversal. Now think about it. We're talking about short term here. Long term, it's even better because metabolically active muscles, meaning muscles that are strong, are your best internal safety valve against rising blood sugar, because your muscles don't need an insulin receptor to pull sugar out of that blood where it can damage the artery and into the muscle where it's safe. So think about it, both short term with vasodilation and decreased inflammation, and long term with that decrease in glucose. Both of these things will help you with muscles and your arteries. Now, let's talk about the seasoned athlete for a minute, or those of us who at least exercise regularly. I got a quick tip for you too. Aerobics and resistance training are both fine, and we need both. We need a base of aerobics. You don't need to turn the basics into jogging. Walking and rucking both are great, and other things as well. Resistance training's fine too. But one of the biggest gaps that we find, even in people who've been doing this for a while, they're seasoned, it's the intensity training. We'll talk about that in a minute, but before we do, Intensity training for what? Your arms? You talk about exercise to men, and they always think about their guns, their arms. That's not what changes your metabolism. We want you to focus on your legs. Resistance training, for example, is not something that should be for your arms. It should be targeting your legs. Look at the big bodybuilders. You know, the classic old Arnold Schwarzenegger. Huge arms, but his legs were far, far bigger than his arms. And the bodybuilders all say this. Oh, here comes a rookie or a newbie. He keeps working on his arms, but they're not growing because he's not working on his legs. You see, the bodybuilders have discovered just by doing it that your legs really jumpstart your metabolism. Why do I talk all this stuff about bodybuilders? Not because I'm trying to make anybody a bodybuilder. That's not our goal here. But our goal is this, to change your metabolism. So it's like Ben Bickman would say, friends don't let friends skip leg day. And he's talking about metabolism. Legs improve your metabolism when you have metabolic disease. Prediabetes, diabetes, insulin resistance. Now, a few minutes ago, let's get back to something I said I was talking about. High-intensity interval training, or HIIT. HIIT is looking for improving those capillaries. Now, what's a capillary? It's that microscopic artery penetrating the muscle. Why is that so important? Well, you remember we keep talking about insulin receptors. You remember we keep talking about insulin receptors pulling sugar out of the blood where it causes damage and putting it into the muscles? So there's a lot going on right there. Think about it for just a minute. Where does our body keep most insulin receptors? In the muscles, because there's a lot more muscle than there is liver or fat. For most of us, there should be, if we're healthy. And where are the biggest muscle groups? In the legs. So it just so happens that when you have insulin resistance, most people with insulin resistance have begun to lose their capillary penetration of those large muscles of the leg. So basically what's going on is they're losing the major surface interface between their arteries and their muscles. Now, think about that. There's a real chicken or egg question here, and that chicken or egg question has not been answered by science yet. Are we losing our capillary penetration of our leg muscles because we have insulin resistance, prediabetes? Or are we developing prediabetes and insulin resistance because we're losing our capillaries, the place where our biggest concentration of insulin receptors lies? The bottom line is we don't know. Now, why did I go there? I thought we were talking about high-intensity interval work. We were, and that's why. Because diet may be king, but diet has not been demonstrated to re-drill those lost capillaries in those muscles like high-intensity interval work. So if we want to regrow the insulin receptors that we're losing, we need to do HIIT training, high-intensity interval work. And people say, oh, that's so hard. I agree, because in order to do high-intensity interval work, you have to be going. You know, with level 2 training, mild aerobics, you're able to talk, you're able to hum. That's just a lot more comfortable than going. But you think about the whole thing. If you're struggling to breathe, that means a large part of your body is struggling to get oxygen. And if you're doing high-intensity interval work, you're pushing your muscles, those large muscles, their ability to get oxygen. It goes back to no pain, no gain. You want to stress those muscles and their ability to get oxygen. That has been shown to help re-drill those microscopic capillaries in those large muscles. Now, I've gone way deep into high-intensity interval training. I'm just going to make a real quick comment about the newest kid on the block in the high-intensity interval training area. It's called REHIT, Reduced Exertion High-Intensity Interval Training. The standard HIIT program was like at least half an hour. It included going up to 80% or more of your max for a minute, and then coming down for a minute to a recovery phase, doing that 10 times, that's a lot, and you feel totally washed out. But with the new kid on the block, reduced exertion only has 2 intervals, not 10, and you can do it in 5 minutes, and only 20 seconds per high-intensity phase, not a full minute. You're getting great impact. The evidence would show that, but you're not feeling washed out at the end. Heck, I can get a few minutes between patients, go down and do some rehab. How do I do it? On an old Schwinn Airdyne, 30-year-old bike. I'm cheap. I also do them on a rebounder, which you think is very low intensity. Not if you actually go into a flat sprint on the rebounder. And I've got hills near the house. I go out and run up those hills. So again, not going to go any further on that. I just want to make sure that you understand the importance of intensity training and why it's so important. It's redrilling those capillaries because most people don't understand it. Okay, now let's talk about something else. Diet and exercise are important. They're the base of the pyramid. But when you exercise, you're not really improving your body tissues at the time that you exercise. When are you improving them? When you're resting, when you're sleeping. If you're not getting good sleep, all that work on the exercise is not benefiting you as much as it could. You can really mess up your progress with poor sleep. We need to get at least 6 to 8 hours of adequate sleep every day, and the right amount of deep sleep, the right amount of REM sleep. I'm not going to go too deep into those areas. There's just too much for right now. But if you'd like to hear us go into that, it's a big interest of mine. And so just make some comments down below if you'd like for us to. You got to get a good sleep. You got to get REM, which is rapid eye movement sleep. It's when we're dreaming, and it has a big impact on reconfiguring our brain. Deep sleep appears to have a big impact on reconfiguring our hormones and other physical components. So how do you make sure that you're getting good sleep? And those of you that think, oh, I do fine on 5 hours, you really need to think again. How do you do this? Start with the basics. Sleep hygiene. Simple things like creating a comforting place in your room. Be careful using your phone when you're going to sleep. Meditation can help, but when you're thinking about meditation, one of the key things that a lot of people forget is slowing that breathing down. Normal breath rates are 16 to 20 per minute. With meditating, get less than 10. It has a big impact on your vagus nerve, which calms you down. It also has some other impacts as well. It slows your heart rate. The key is relaxing instead of just trying to go to sleep. Also, if you're dealing with prostate issues, like most of men my age, if they make you pee at night, that's something that really needs to be addressed. And again, if you have some issues there, let us know down in the comments. And again, we'll respond to your comments and start getting some more content in that space, some more information out. Sleep apnea is another major issue. For most of us with sleep apnea, weight loss can help a lot. But not everybody. I have sleep apnea problems. I have it even when my BMI is like 22. So it's not always weight loss and fat buildup around your airway. Sometimes the bones, like your palate, you have a high arch. Sometimes you have a narrow arch on your teeth. Sometimes the tongue gets in the way. So these are all things that you need to be aware of and think about. Quite often, one of the biggest things for sleep apnea, very simple, very easy, is training yourself to sleep on your side instead of your back or your stomach. But again, that's just a very simple, easy thing. You really got to understand what's going on. And that often involves a sleep evaluation. Now, a lot of people would say, you know what, heck with all that. I just take a pill and I go to sleep. Lunesta or one of the other pills. The problem with pills, I don't recommend them at all. In fact, I would strongly advise against use of pills for sleep, especially regular use. You're just not going to achieve quality sleep. And when you try to get off of those pills, it's got a physically addicting effect to where you really, really can't sleep then. So it decreases the quality of your sleep when you're using sleep medications. And then when you try to come off, it really messes you up. Some supplements that might help include magnesium threonate and even things like vitamin D. We're not going to go deeper into the supplement world right now. But we're only halfway into this process. Let's talk about a couple of factors that are so intertwined. They're behind a lot of cases of heart attacks and strokes. You ready? Stress and relationships. Believe it or not, job and social related stress can raise cortisol levels. Among other hormones like insulin, which is impacted by cortisol, you create a cascade of inflammation, fat storage, and more inflammation that ultimately leads to plaque in your arteries. Implement strategies to manage stress. It's critical. To avoid stress sources, that's one way to do it. Exercise is a key thing. It's one of the bigger things for me. I sort of enjoy putting myself in positions where I have stress. So, for example, I'm supposed to be retired. The reality is, I would be bored to tears. I like golf. I like travel. I'm not that good at either one of them. I love doing what I do, and people tell me all the time, we're saving lives. So I do more and more of that. Running a channel, running a clinic that sees patients, running programs like our Metabolic Reset program, all of those things can be pretty stressful. But exercise is my way of pushing through that, burning out that cortisol, and relaxing and sleeping well at the end of the night. You know, hobbies and meditation are alternatives as well, and I use both of those. One of my hobbies has become exercise, though. And meditation is something that I actually do almost every night, either when I'm going to sleep or when I wake up early in the morning, like 3 or 4 in the morning, which I often do. Not always, but I often do. And I'll slow my breathing down and start to meditate. That helps me get back to sleep. Something that's one of my favorites, but we just don't get a lot of airtime on it, is life purpose. You know, there have been a couple of studies which show very conclusively having a life purpose, it makes you like the ever-ready bunny. Was it the ever-ready bunny where it took a licking but kept on ticking? Well, that reminds me of the study, the Holocaust survivor study. These people that survived concentration camps survived the rest of life, too. And you'd look at that, your first reaction, you know, as an epidemiologist, a scientist, is, well, they had good genetics. They didn't succumb to diabetes, prediabetes, cancers, the other major killers genetically. No, they looked at that, and these people actually had more cancers, more diabetes. So how did these people survive so much longer than their peers? Either in concentration camps or in life outside of concentration camps during peacetime. That's clearly what happens. The answer is we don't know, but we do know this. They have a life purpose, a strong life purpose. Now, you may push at that and say, well, Ford, you tell us all the time, don't look at just one study. I'm not. There was another study, the retiree health study in the U.S., it had a great gauge for grading retirees and their sense of purpose, how strong that sense of purpose was. Guess what? There was what we call a dose-response curve, and that's very powerful in terms of science and epidemiology, if you care about that stuff. Basically, it shows the higher your strength, the stronger your strength of purpose, the higher your strength of purpose, the longer and healthier your life. So again, having a sense of purpose is no joke. It's very, very powerful. And like I said, it's maybe my favorite thing out of all of this. I grew up Christian in the deep South, South Carolina, and was a Bible teacher, a Sunday school teacher for many years. And to me, I do feel very, very strongly that what I'm doing is helping people. I'm diving into an area where there's just untold damage to humanity. And every time I can make a difference, it just makes me feel like I'm fulfilling my purpose. That is my purpose in life, to continue to get this message out that there's something that's killing and disabling more of us than anything else, and there's something we can do about it. It's not just all doom and gloom. It's with just a little bit of discipline and a little bit of awareness, we can take most of these risks right off the table. And when I say off the table, it sounds like just a term. No, I mean off the table, because you get right back to the very beginning: carbs, 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 especially ultra-processed carbs. Cereals, breads, pastas. You start by taking that off the table, you take all of the major risks, the biggest risks for heart attack, stroke, blindness, kidney disease, erectile dysfunction for men. So for men, which would you rather have? The ability to have good sex or pasta? Some of you may have trouble with that decision. Most of us don't. There are several supplements that we would consider, that we would focus on. The two most important ones are vitamin D3 and niacin. Both of these can be dangerous, or there's clearly evidence that they can be dangerous if you take them too high a dosage. And in both of these, the current recommended dosages are too low. With vitamin D3, the dosages that have been recommended are like 2,000 international units a day. Most people don't reach even 40, a serum level of 40 at that dosage. What I have seen in reviewing the evidence in the literature is that you should take 5,000. All of us can and should assume that we have some vitamin D3 deficiency, and it's a big deal, impacting our glucose metabolism as well as depression, other things. So just go ahead and start taking 5,000 international units of vitamin D3. Then titrate that to a blood level between 60 and 90. Again, the current labs would say up to 40, and then 40 is good. 40 is good to prevent rickets. It's not good to manage metabolic health. I'm very much aware that there's a lot of debate. Some YouTube content creators saying that, no, all this stuff about vitamin D increase is malarkey, is no good, it's not true, and that you can go as high as you want. Take 10,000, even 25,000 international units per day. I can tell you, I've reviewed the science, and I've seen multiple episodes where people were taking 10,000, 25,000 units per day. Their blood levels got 115 or higher. Their calcium levels went up. It injured their kidneys, and it died. So I recommend being, I will acknowledge there's some facts behind what some of the other YouTube creators discuss on this area, but I just recommend being a little bit safer. Keep your blood levels 60 to 90. Don't go above 90. That's what I do. That's vitamin D3. Niacin is the second really big supplement that we use for cleaning arterial plaques. There was one study that showed that niacin didn't help. And I remember I did a video where I picked up the recording of the principal investigator, and he said, it was my study, but it was a disaster, because people are going to think niacin doesn't work. And we know that it does. We have no doubt that niacin works. Unfortunately, he was right. The American side of the Atlantic picked up that study and said, niacin doesn't work, don't take it anymore. So you'll hear a lot of doctors say that. On the other side, though, the cardiology community and preventive community in Europe continued to use niacin. I recommend continuing to use niacin as well. Niacin is really the only thing that we know of that accomplishes four things. One, it improves Lp(a). Two, it improves HDL. Three, it improves triglycerides. And four, it improves LDL. These are all things, markers that we want to see happen in our metabolism. So we know that niacin is actually probably improving metabolism. Now, final comment about niacin. What are the dosages? I recommend starting at 250 milligrams, and you can go actually up to 2 grams. When you talk to people that actually use niacin for prevention, especially some cardiologists, for example, they'll say, nope, you got to get all the way to 2 grams or it's not going to do anything. That's not true. I mean, when you watch Lp(a) and some of these indicators that I discussed earlier, I've seen patients get better and drop their Lp(a) from 150 down to 25 with just 250 milligrams of niacin. Vitamin K2. Now, that's one of our more popular topics, and one of the reasons is it has grown. For 3 years in a row, vitamin K2 sales doubled, then doubled again, then doubled again. There's a perception out there that vitamin K2 actually takes calcium out of the artery wall where it shouldn't be and puts it back into the bone where we want it. Although there's probably some truth to that, I think that it's a little bit more complicated than that. I think there are a few enzymes that are involved in helping put calcium back in the bone, and other enzymes that help take calcium out of artery walls, like MGLA, matrix GLA protein. Not going to get any more technical than that, but I think that there's evidence that links that to the things that we want to see, getting calcium out of the artery wall and into the bones. Now, a couple of other things to think about is those enzymes, when they're activated, seem to be linked to decreasing insulin resistance, metabolic disease. So there's something in there where there's a linkage between metabolic disease and this calcium movement using those enzymes, those proteins. Have we seen significant evidence with that specific linkage? Yes, I've actually seen studies where middle-aged men with insulin resistance were given vitamin K2, and it did improve it. There's more studies going on. It's just a research signal or a study signal. In other words, an early study showing improvement. Let's wait until we see a little bit more studies before we know exactly what's going on. But yes, I do take vitamin K2. Now, what do I take? It's unfortunate the way most vitamin K2 is provided, because it's provided quite often in pills with D3, and they give you 100 micrograms. 100 micrograms of K2 is just not going to do anything. Even the study that showed some improvement with metabolic disease, prediabetes with middle-aged men, it was 400 micrograms. So I recommend getting at least 400 micrograms of vitamin K2. How do I do that? I have natto powder and I take vitamin K2, both as supplements. The thing to remember about dosage for vitamin K2 versus vitamin D3 or niacin, deaths have been associated with the latter two. With niacin, with damage to the liver. With vitamin D3, damage to the kidneys. There have been no deaths associated with high doses of vitamin K2. And in fact, when you look at dosages, there's a thing called megadose K2. It's in milligrams. We're talking about like 50 to 150 milligrams, which is what, 50 to 150 times the dosage of these 100 to 400 microgram doses of K2. So sometimes I just take the megadose. The megadose was developed and has been studied, by the way, for people with osteoporosis. Again, helping repopulate their bones with calcium. So you know that these doses, 1 to 400 micrograms of K2, they're not going to do damage. And finally, berberine. Now, many people see berberine as a replacement for metformin. It's not, but it does have some similarities in terms of helping with metabolic disease. Some people talk about it decreasing LDL, and as you know, I don't focus on that very much. What's the dosage? 1 to 1.5 grams per day. And can it help with arterial plaque? Yes, there's some evidence that it does. So nattokinase. There was a study that showed actually even plaque reversal from a dosage of 10,800 units, fibrin units or fibrinolytic units of nattokinase. So I recommend doing at least 6,000 to 8,000 units per day. Now I get mine from natto powder. If you take natto, you can get that. You can also get K2 from the same thing. Lifestyle is king. You've seen how critical it is, not just for prevention, but for actual reversal of risk. And this is where things start to really move the needle. Let's get practical. If you're wondering what specific foods I actually recommend, The ones that don't just lower blood sugar or inflammation, but actually help stabilize plaque. You're not alone. This is one of the questions I get most often. And while there's no single magic food, food's not magic, but there's a pattern here. Certain foods consistently support better metabolic control. They improve endothelial function. And when you hear the term endothelial or intima, think that gentle but incredibly important, critical lining of the artery wall. Foods can improve the health of that intima. These foods can reduce the oxidative stress that makes plaque dangerous, that damages that intima lining of the artery wall. So in the next section, I'm going to walk you through the foods that make the biggest impact and why they do. Now, some of these foods might surprise you. Let's get into the list.
I love avocado, and it's a good thing. Avocado is great for your heart. I didn't always love it. I had to teach myself. And avocado has its problems too, even its dark side. Before we start, let me share a personal story about how I developed this list of foods. It was the year 2014. I was in the same position as a lot of people in the U.S., Mexico, Brazil, other places in the world. I thought I was healthy. I was thin. I was running marathons and eating what I thought were the right foods at the time. It was a low-fat diet. It was what I'd been taught. I ran the program in prevention at Johns Hopkins, and that was the best that we knew at that point. I avoided medications and supplements. I thought supplements were just expensive urine or pee. But one thing happened that made me question my healthy lifestyle. In my late 50s, I developed high blood pressure. I got tested using a CIMT and found out I was building arterial plaque. Now, let me tell you, that's scary. With all the work that I was doing, and I practiced what I preached, I still was developing plaque. As I dug deeper, I found I'd been making some errors in my health habits. It was like thinking I was growing a beautiful garden, only to realize I'd been watering the weeds the whole time. The weeds. After years of experience, going through the research, going through my own story, I wanted to share with you these top 5 foods everybody should eat to avoid a heart attack. Let's get started. Now, which would you rather eat? A bowl of cereal or an avocado? If you chose avocado, you're right. Obviously, this is the first food everybody should eat to avoid a heart attack. Studies show that eating half an avocado twice a week reduces the risk of death by heart attack up to 16%, and the risk of arterial plaque buildup by 21%. But why are avocados so special? They're full of nutrients, those right there. A bunch of vitamins and minerals, choline, and many healthy fats. Avocados can lower your triglycerides and increase your HDL. Both things are critical to avoiding heart attacks. But as I mentioned, avocados do have their problems. First, avocados can be pricey, especially with tariffs and some of the fights that go on politically over them. You might have heard of the avocado crisis in 2022 in Texas. That year, guacamole became a luxury item during the Super Bowl. Second, they can rot quickly. A ripe avocado can go bad in a couple of days. They might lose nutrients and their taste changes. And let's be honest, most people just don't like avocados to start with. They've got that waxy consistency. They are an acquired taste for most of us. I didn't like them at the beginning, and I learned to by eating them. Now, if you want fresh avocados, because they rot so quickly, that means multiple trips to the grocery store during the week. And then, in addition, there's a very dark side behind the avocado industry. It seems that exploitation is involved. Poor work conditions, inappropriate payment of workers, and even child labor. You know, where there's money, there is conflict and abuse. So, what to do about this? Well, first, the problem with freshness. So the industry realized freshness was a problem, and they came up with their own solution, a plastic vacuum pack. Now, that plastic vacuum pack will keep the avocado fresh for weeks, especially in the fridge. Now, have you ever heard the phrase, every solution creates a whole new problem or even set of problems? Well, here's the next problem with that solution. Have you heard of microplastics? So, again, a lot of challenges, but I still eat avocados. Here's what I do. I try to eat avocados as often as I can, despite the problems. I eat some slices or guacamole on bacon and a salad, sometimes with beans. I get fresh avocados when I can, and I just cut them in half and just spoon it out of the peel. I can also buy some ripe and some unripened avocados to have at home, and the unripened ones last a few days longer, again, especially in the fridge. I just don't try to solve the ethical concerns. I don't know how. If you live near a farm, you can make sure to source ethically. You can try getting some from a local farm if you have that available. Now, enough about avocados. Let's go to the next one. How about yogurt, Greek yogurt versus kefir? If you chose Greek yogurt, you might be right and wrong at the same time. In the past, I've made the same choice for years. It was my go-to breakfast. But let me explain. Most Greek yogurts are actually deceiving. Once you look at the labels, you find that most Greek yogurts, especially the, quote, healthy, low-fat yogurts, end quote, replace fat with sugar. That's the opposite of what we need, as well as other chemicals from food processes. Now, Greek yogurt can be really healthy. There's evidence it can improve biomarkers such as glucose, triglycerides, and cholesterol. So I'll go with both healthy Greek yogurt and healthy kefir, as well as other fermented foods like natto and kimchi. My favorite go-to is actually sauerkraut. You can find more discussions about natto and kimchi in some of our other videos. And if you're wondering about fermented foods to begin with, here's the thing. Fermentation is a process in which yeast and bacteria break down sugars. Fermented foods are those that have undergone this controlled microbial growth fermentation. Greek yogurt and kefir are fermented milk. They're using colonies of yeasts and bacteria to do the fermentation, in which the sugars are eaten by the bacteria and mostly the yeast. Kimchi is a Korean dish made out of fermented vegetables, mostly cabbage and radish. Natto is fermented soybean. Sauerkraut is fermented cabbage. Evidence shows fermented foods can improve cardiovascular risk markers, decrease inflammation, and reduce risk of heart attacks. Well, what's so special about fermented foods? This neglected player that we haven't discussed yet. It's involved in heart attacks and strokes, and it's called the gut biome. You see, inside our intestines, we have about 1 trillion bacteria. So you're not eating for one, you're eating for 1 trillion. That bacteria, those microbes, are more important than you think. They help produce multiple vitamins, nutrients. They keep your body safe from harmful bacteria, and they help with fat metabolism and a thing called neurotransmitters. You remember we mentioned that beautiful garden earlier? That's the gut biome. We really are walking around with a garden inside. You need to take care of it. And anytime you eat processed junk, you're causing a fire, burning all the healthy bacteria and watering the weeds. We call that dysbiosis. Dysbiosis is the growth of unhealthy bacteria and other microorganisms. It's very common in people with prediabetes and diabetes, and it leads to inflammation, arterial plaque buildup, and heart attacks. That's why fermented foods are so good. For preventing heart attacks, you eat fermented foods, you feed the good bacteria, you promote anti-inflammatory effects, and produce healthy micronutrients. You're watering your garden and removing the weeds, and in the process, escaping a heart attack. But just like with avocados, there are problems with fermented foods as well. First, Similar to commercial Greek yogurt, some other fermented foods like kefir or kombucha might have a lot of sugar. Most of the time, they add the sugar back after the fermentation process. Why would they do that? Well, fermented foods also are an acquired taste. Most people don't grow up or naturally like them. They have sugar, but most of the sugar's already been consumed by the yeast, so they add that sugar back. The second problem is amines. Amines are compounds related to ammonia and related to proteins. Examples include histamine, tyramine. You might not have heard of putrescine or cadaverine, but yes, those are present as well. These last two are ones that give rotten food its unique smell. And sometimes you can smell that with fermented foods. When amines are consumed in excess, they can mix with nitrogen oxide and turn into nitrosamines. Nitrosamines have actually been linked to cancer. Some research suggests fermented foods might have high levels of amines. Really, that's only true for some fermented foods, like fermented fish, red meat, and some cheeses like mish, which is a salty Egyptian cheese, Parmesan, which is a very popular cheese, and other hard cheeses. Not so much in kefir, kimchi, or Greek yogurt. Now, there's another problem, salt. You might hear that a large amount of salt can actually increase your blood pressure. Well, there may be some truth to that. It's been the prevailing wisdom for decades, but newer research is indicating that actually salt may not be so much the problem as insulin. This means that the sodium in fermented foods like natto and kefir, sauerkraut, might not be as big a problem as you think. Another problem is bloating, gas, even diarrhea. In my opinion, this has more to do with that change in the gut biome. People who have dysbiosis. Remember that geeky term? People with unhealthy bacteria will experience this, but it's usually temporary and is part of replacing an unhealthy gut biome. If you think, gosh, this just sounds like too many problems. Again, slow down. Let me tell you what I do. I'm careful to read labels. If I buy kefir at the store, I avoid eating it or drinking it if it smells sour or rancid, or if it has some clumping or clear liquid in it. And this also applies if you make your own kefir. I often use nattokinase powder, and as I said before, I eat a lot of sauerkraut. And usually when I eat sauerkraut, I'll eat it with pecorino cheese, pecorino romano. It thickens that sauerkraut, put some butter on that, and I love it. Now, back to the amines. You remember those things? This can be a problem for some people with allergies to these foods, but allergies to amines are really not that common. I recommend introducing fermented foods slowly, in small portions, once or twice a week. Increasing it slowly avoids bloating or gas. Let me know in the comments if you have tried any of these foods, and if so, how you do it. I used to eat Greek yogurt for breakfast every day for years, and it turned out that the yogurts that I liked had way too much sugar. I quit eating them for years, but again, with the evidence supporting fermented foods, I'm going back to those. Now, let's go to another quiz. Which one would you choose for your heart? A protein bar or nuts? Just to continue the trend of misleading labels, there's a lot of unhealthy protein bars out there that are full of sugar and preservatives. I'm not saying never eat any protein bar. There are some good options, but most of them are not. I have to go nuts for this one. Pun intended. Research has shown a decrease in heart attacks. The best options include almonds, hazelnuts, Brazil nuts, walnuts, pistachios, and even peanuts. My favorites, my go-to, are walnuts, almonds, and especially macadamia nuts, and most of all, pecans. I live in southeastern U.S., and pecans are grown here, so I can get and eat a lot of pecans. Macadamias and pecans are very, very good for a low-carb diet as well. So why are nuts in general so good for heart attack prevention? Well, they have plenty of beneficial components, from healthy fats, omega-3 fatty acids, fiber, plant sterols, choline, and even L-arginine. Now, that's an amino acid. It's well known to help produce nitric oxide, and therefore opening blood vessels, reducing blood pressure, and boosting vascular health. You may have guessed by now, there are some downsides to going completely nuts, at least all the time. Some people have described bloating, weight gain, even poisoning from selenium. Nuts have their own dark side, yes. Cashew nuts have been linked to exploitation of workers in Kenya. So, let's address all of these real quick. Bloating is actually a side effect of improvement in the microbiome. Nuts can help build that healthy bacteria and the healthy gut biome. Is it possible to gain weight with nuts? You've heard people say, oh, if I eat too many nuts, I'll gain weight. They're just fat bombs. Ask those people what else they eat. You usually don't hear that in someone who's on a low-carb or keto diet. Most people blame the fat in nuts and neglect to tell you they're eating a lot of sugar. Now, let's talk about selenium and cyanide. Selenium poisoning might actually be a thing. I don't recommend eating more than 2 Brazil nuts in a day. Cyanide poisoning, maybe not so much, but still at least limit your almonds to 10 to 15 a day. And again, selenium and cyanide will not be an issue for you. If you really love cashew nuts, try thinking about ethical sourcing. And again, I don't eat cashew nuts for that reason, because I can't figure out a way to ethically source cashews here. I get mostly walnuts from Amazon. I eat a lot of those. I prefer raw walnuts, but dry burnt ones are good too. I just don't get those very often. Avoid any sugar-coated walnuts or other types of processed nuts. Now, there's one more food that has even more omega-3 fatty acids. It's a food I've recommended for years, and it was one of the foods I've come to really appreciate once I made my change from low-fat to low-carb. So we have another decision to make. Real quick, don't think about it for very long. Apples or salmon? If you chose apples, let me tell you, years ago I would have chosen that as well. I liked them. They were nice and sweet. They had a nice crunch. And again, it took me a while to learn to love salmon. And we always used to hear, an apple a day keeps the doctor away, right? So they had to be healthy, apples did. Well, there's a problem with that. Despite all their nutrients, apples have a lot of sugar. They're not packed with enough fiber to counteract that sugar. And I'm not saying don't eat apples. I eat maybe a slice or 2 a month. Just don't eat a lot of them. If you do eat apples, make sure that you either eat fiber or meat before the apple, measure your glucose levels, and just don't drink apple juice. And drinking apple juice is like almost pure fructose, and it's just like drinking non-diet sodas. The same thing applies to oranges and most fruits, unfortunately. But we're not comparing apples and oranges here. We're comparing apples and salmon. Salmon wins this one. Okay, I know salmon can be expensive. I recognize that. So that's why I give you a couple of alternatives in a few minutes that are just not that expensive. But why even consider salmon or other fish to begin with? Just eating fish has been shown to reduce cardiovascular death by about 5%. And that increases for every 5 grams you eat, especially for those fish with high omega-3 fatty acids. Omega-3 fatty acids are the healthiest fats. They include Geek Alert, EPA or eicosapentaenoic acid, DHA, docosahexaenoic acid. Again, I hate that one. And there's a third one, ALA. We've mentioned it before when we're talking about nuts. We'll mention it again a little bit later. These omega-3 fatty acids have been found to be very protective for cardiovascular health. Now, guess which fish has the most omega-3? If you guess something like tuna or swordfish, you may be right. Those are followed by salmon with 2.5 milligrams for every 100 grams. kippers or kippered herring almost as much as salmon, and sardines at 1.6. So, wait a minute. I said salmon at the beginning. What's the problem with tuna or swordfish? I used to love tuna or swordfish until we found out the biggest problem with fish products. These top predator fish like tuna and swordfish run high in mercury. And again, especially true for tuna and swordfish. Mercury poisoning can be a serious issue. Do you remember Alice in Wonderland? You remember that story, and you remember the Mad Hatter? That was a real thing. That story was written in England a couple of hundred years ago, at a time when hats were very, very popular, and especially a specific hat called a beaver felt hat. Those beaver felt hats were made using mercury. So hatters were often crazy. So, to go back to modern days, we have since discovered that mercury exposure can cause problems. Kids have low IQ, walking problems, problems talking, even personality problems and memory problems like the Mad Hatter. Additionally, other fish have been shown to have more nutrients than tuna, so that's why I prefer to recommend salmon first, tuna, and again, my old favorite, swordfish last. Salmon's not free of its own problems. We mentioned cost, we mentioned mercury, and then you have microplastics, which, due to water pollution, it's been seen that fish with significant amounts of plastic being eaten and end up in your arteries, causing inflammation. There's another major problem associated with salmon, and that is how you access it. You have wild salmon, which is very expensive, and farm salmon, which is less expensive. Wild salmon are caught in their natural environment, such as oceans, rivers, and lakes. They have more natural diets. They have less exposure to animals, to drugs. They've been found to have a better nutrition profile. Farm salmon is raised in captivity by farmers. They control its breeding, its feeding. They give it medications, including antibiotics. And guess what? 75% of salmon consumed is farmed. So, when it comes to this question, what can you do with this information? Let's just boil it all down. And let me just tell you what I do. I obviously prefer wild-caught salmon. I try to eat it at least a couple of times a week. I used to eat it 4 and 5 times a week, but I've changed some of my habits now. I'm not worried so much about mercury with salmon or microplastics. Not because they're not a problem, they might be, but eating fish, even with these challenges, has been shown to be a much better bet than not eating fish. I don't eat tuna and swordfish anymore. I hate that. I used to love it. Now, when you cook the salmon like this, it's a delicious option. I also supplement with omega-3s. That's another option. It won't include plenty of the other nutrients that you find in fish, and as you know, omega-3 supplementation has its own set of problems, which I'm not going to go down, other than to say you've heard of supplements going rancid. So you have to make sure to focus on the type of supplement you use if you supplement with omega-3s. Now, if you don't like meat, and you want to add another omega-3 source that doesn't involve supplements or meat, there's another option. What do you think that is? How about canola oil or flaxseed? If you chose flaxseed, you're right. Canola oil is a type of seed oil. Seed oils are plant-based foods derived from plant seeds. And although some studies suggest canola oil can improve cardiovascular markers, the major improvement is seen in LDL cholesterol. Now, LDL cholesterol used to be considered the number one risk factor for heart attack and stroke. That LDL theory is coming under a lot of scrutiny these days. The evidence is beginning to show something very different. In fact, I don't worry too much about LDL. If you have more interest on it, we've got a video on the worst lie about cholesterol. You can also see our perspective on seed oils in this video. But let's talk a little bit more about the winner, flaxseed. I know flaxseed might be the preference of a lot of people. There are challenges with it, though, and I understand, but allow me to elaborate. Flax seeds or linseeds are small seeds from the Middle East. They're packed with nutrients, especially ALA. You remember that omega-3 acid? It's called alpha-linolenic acid. It also has EPA. Both of these are, again, those omega-3 fatty acids. The seed can be hard to digest. You have to ground it into a powder. I know many people recommend against flaxseed because the conversion of ALA is very low. In fact, ALA is considered to be one of the required fatty acids, and that's because with ALA, your body can make the other two omega-3s, and that is EPA and DHA. Now, regardless, for those that do use flaxseed, I use flaxseed as well. I use it as a powder on my salads. About 4 to 5 tablespoons a day is the goal. And it is a great option. But there's another problem. Again, another problem with flax seeds. For those of you who are familiar with it, you may already be thinking about it. Flax seeds full of plant estrogens. Estrogen is a female hormone. It helps maintain female body characteristics. Lack of estrogen is a major cardiovascular risk factor for women. So it's no surprise that heart attacks in women can happen during menopause. That's when they happen. And in fact, just as many women die of heart attacks as men. They just die a little bit later, usually a few years to a decade after menopause. Now, flaxseed has those phytoestrogens or plant estrogens. Do they really impact humans to begin with? And if so, is it really a problem? The answer is yes. Flaxseed does have those phytoestrogens. They've been shown to increase estrogen levels in postmenopausal women, which in turn combines with the benefits of omega-3 fatty acids. And it can provide cardiovascular protection, that is, fewer heart attacks for women. It's great for postmenopausal women who are at big risk for heart attacks. But what about men? Can men get the same benefits, or is it bad for men to eat these types of phytoestrogens? For men, testosterone is the most important male hormone. One of the biggest problems you see online with flaxseed is this high amount of estrogen in flaxseed lowering testosterone levels and causing problems for men. Problems like difficulty building muscle, sexual performance, maybe some getting blamed for hair loss, even depression and sleep issues in men. Now, is that the truth? Well, when you look at the evidence, there are 2 small studies suggesting that this might be a problem for men. But there's a lot more stronger evidence out there that really doesn't indicate that. I've not seen evidence of a problem. And as I mentioned, I do eat some flaxseed on my salads. It's safer for men than what social media might tell you. In the end, it's up to you. There are other sources, as we've already mentioned: salmon, kippers, sardines, even chia seeds, which we didn't discuss. There are other options there for omega-3s. Now, I do have a bonus food on the list just for you. Let's see if you can choose correctly. Would you rather eat margarine or eggs? Well, the right answer, most of you know, is eggs. The result of the Attica study showed that eating an average of 1 to 3 eggs a week can decrease the risk of heart attack and stroke by 45%. Another meta-analysis, again, a study of studies involving 21 studies, showed that eating more than 1 egg a day was associated with less arterial plaque buildup. There's a clear reason for why eggs are healthy. They have no sugar. They're rich in plenty of nutrients, including things like choline, vitamins, and healthy fats. Now, there are studies that show other things. There's one meta-analysis showing an increased risk of heart attacks when eating eggs. But you got to dig deeper in any of these studies when you look at them. The problem with this study was that the authors assumed that higher LDL means more risk, and that was how they based their conclusion. As we've said before, LDL being the major risk for heart attack and stroke, that may have been the biggest cholesterol lie in history. Yes, scientific evidence has not shown that saturated fats, which many label as unhealthy fats, are actually harmful. That's why I think foods like free-range chicken eggs and unprocessed meats are great for metabolic health. Now, a paradigm shift is necessary to prove that eating red meat and eggs is not dangerous, as you've been told time and time again. Without going further on the vegan versus carnivore controversy, I do believe as long as you avoid sugar and processed and ultra-processed foods, you can achieve a healthy metabolism. Now, I've covered a whole lot. Let's recap real quick, and then we'll talk about why the list makes sense. The top 5 foods. First of all, let's run through the list. Everybody should eat these foods to avoid a heart attack. Avocados, fermented foods like healthy Greek yogurt, kefir, kimchi, natto, sauerkraut, nuts, fish like salmon, herring, kippers, sardines, back to nuts, macadamia nuts, almonds, pecans, and especially walnuts. Flaxseed, eggs as a bonus. But did you notice something about all these that they have in common? Yes, these foods are all high in fat and low in sugar. That's the major lesson that changed my life. See, my problem is, and what I discovered when I was creating that plaque was, my body cannot process carbs. That happens to all of us as we age. It happened to me in my mid to late 50s. I found out I had prediabetes. Not eating sugars and carbs is key for me. Right now in America, millions of Americans have been doing the exact opposite. Low fat, high carbs. The base of the food pyramid is grains. But the problem is, over half of American adults have prediabetes. Once you get into your 50s and 60s, that increases to 70 to 85%. Ultra-processed garbage food is high in sugar, low in healthy fats, high in unhealthy fats like trans fats, very low in nutrients, and it leads to the current diabetes and obesity epidemic. It actually stimulates the insulin that we want to decrease. It results in heart attacks. That's why heart attacks are the number 1 cause of death. There's another group of people who are living healthier lives, avoiding fats and still eating lots of carbs, sometimes even processed sugar, and thinking that because they're thin, they are healthy. That was me a couple of decades ago. The problem is they still think that cholesterol is what causes heart attacks, but that's just not true. The problem is metabolic disease, or prediabetes and diabetes, or as the doctors call it, insulin resistance. Speaking of doctors, why haven't doctors helped us out with this problem? Well, I mentioned over half of adults in the U.S. have this problem, but 90% that have it don't know it. Unfortunately, it's because the doctors, the primary care doctors, family practitioners, internists, and cardiologists, 3/4 of them don't know how to diagnose insulin resistance. So again, that's where I was about a decade ago, eating a low-fat diet, healthier than most people by staying thin, but still developing arterial plaque. So the key message here, the current dietary recommendations are just wrong. Grains should not be the base of the food pyramid. Putting grain products like bread, cereal, and rice and pasta as the base of the food pyramid and demonizing fats is what got us to the point where we are now. Half of us are obese, pre-diabetic. The healthiest foods to avoid a heart attack share the opposite in composition. They're low in carbohydrates or sugars, high in healthy fats, not processed, and rich in omega-3 fatty acids. If you don't know what's healthy to eat, look for the characteristics that we just described that made up this list, the patterns: low carbs, higher fats.
These foods are nutrient-rich, low in processed carbs, and powerful when it comes to metabolic control. they're not just heart healthy in a vague heart healthy sense. They actively support insulin sensitivity. They reduce inflammation. They lower the metabolic stress that drives plaque formation and softening of plaque and inflammation. But food is really only part of the equation here. There's more to it than that. Over the past decade, research has uncovered specific nutrients and natural compounds, some found in food, others in supplement form, that show real promise in reducing plaque, improving arterial flexibility, and calming the immune system, the immune response inside your arteries. We're not talking about trendy pills or gimmicks. We're talking about evidence-based compounds with measurable effects used in clinical trials and in real patient care. So in this next section, I'll walk you through the ones worth paying attention to and how to use them wisely. Let's take a look at the compounds that go beyond food and deeper into true cardiovascular repair. Just how reliable the evidence is. Arterial plaque is a metabolic problem. We're going to show you the data. Top 7 foods to reverse plaque. When you see evidence of foods that can decrease plaque by 22% and then realize that just a 1% reduction in plaque equals a 25% reduction in cardiovascular risk, you have to pay attention. From aged garlic extract to Iranian whortleberries, here is our list of the top 7 foods that will clean plaque from your arteries. As we review those top 7 foods that will clean plaque out of your arteries, you'll hear examples of small decreases that may not sound like very much, but they are. Even a 1% reduction in plaque has been associated with a 25% decrease in the risk of a heart attack or stroke. Jumping right in, we have number 7, aged garlic extract, and we're looking at a specific study. This trial involved 72 participants who underwent CT angiogram to determine changes in the type and amount of arterial plaque in their hearts. Matt Butoff's study team looked at adults aged 40 to 75 who had at least 2 criteria for prediabetes, at that point called metabolic syndrome. Examples include fasting blood sugar over 110, triglycerides over 150, significant abdominal obesity, high blood pressure. Now, one group was administered 2,400 milligrams of aged garlic extract every day, while the other group received a placebo. The study was designed to last for 1 year, 52 weeks. They found a significant change in the average amount of what they called low attenuation plaque. It's like soft plaque. The artery plaque in participants receiving garlic was reduced by 1.5%. The placebo group gained 0.2% of that low attenuation plaque for a total difference of 1.7%. Again, remember, if this sounds like a small difference in plaque, the tiny difference in plaque drives a huge difference in heart attack and stroke risk. More than 25% reduction in this case. The fact that this study involved a specific product could indicate that it was partially funded for commercial gains, and therefore is partially biased. But then again, the pharmaceutical industry has been doing this forever. And if you wait for the perfect study, you're going to be waiting forever. You'll never try anything. This study's not the only investigation of garlic. It is a powerful signal in the literature that something really is there. The researchers compared the effect of garlic extract to the effects of statins without the side effects. I personally have been very busy in my professional and personal life for the past 18 months. In the hubbub of moving and some of the other things, I dropped some of my routine supplements. Garlic extract was one of them, so I've reordered it. Again, after reviewing this study. Kimchi, number 6. Now, for this food, we're looking at one particular study. The study compares the effects of freshly made kimchi, which is only 1 day old, versus kimchi that's been fermented and is 10 days old. So it's really looking at a critical question in the evidence about preventive medicine. Does the fermentation in fermented foods really help as much as many of us think? Kimchi is a mixture of ginger, garlic, cabbage, Korean red bean paste, fish sauce, salt, and sugar. You place all this in a jar to let it sit. This causes fermentation. Allegedly beneficial bacteria then begin growing in it. So this study design contributes to that critical question. Does the fermentation make a difference? Is it the fermentation? Now, this study involved 22 overweight individuals divided into 2 groups to test the effects of fresh and fermented kimchi. They followed a crossover design. This means each participant experienced both conditions. So all participants experienced eating 10-day-old kimchi and 1-day-old kimchi for 4 weeks each in 2 separate phases. The experiment was split into 2 phases, each lasting 4 weeks, with a 2-week break-in between the time period when participants did not eat any kimchi at all. This 2-week break is known as a washout period. This washout period aims to ensure that the effects of the first phase don't influence the second phase. One group started by eating fermented kimchi for the first phase and then switched to the fresh kimchi for the second phase. The second group did exactly the opposite, and this increases the power of the study design. Now, dietitians planned the meals for the participants to maintain consistency throughout the study. Participants were instructed to eat 300 grams of kimchi every day, divided among their meals. So, what were the outcomes? Drum roll, please. Regarding notable outcomes, the researchers found, on average, during the study phase, where participants ate fermented kimchi, the fermentation clearly appeared to help. Body fat decreased by 2.2% in the fermented kimchi group compared to 1% in the fresh kimchi group. Now, these decreases are big. Body fat releases hormones that make it a core contributor to metabolic disease, and that causes risky plaque to form. Average fasting insulin. These levels went down by an average of 11% in the fresh kimchi group and an average of 26% in the fermented kimchi group. So again, another big difference. The effects on insulin were still pronounced when the participants were challenged with a 75-gram glucose challenge. At the 30-minute mark, when we expect insulin to rise because of blood glucose going up, the fresh kimchi group's insulin levels actually increased by an average of 4.8%. That's not what we want to see. While the fermented kimchi group's insulin levels decreased by an average of 4.6%. At the 120-minute mark, the 2-hour mark, after being challenged with glucose, the fresh kimchi group's insulin levels did not change after 4 weeks of eating it. But the fermented kimchi group's insulin levels decreased by approximately 16.6%. Now, these are dramatic differences. And the differences in the participants' fasting and glucose-challenged insulin levels are of major importance. They directly point towards a decrease in insulin resistance, one of the key components of metabolic disease, the key driver of metabolic disease. Additionally, the more insulin you have, the harder it is for you to burn fat away, and the more likely plaque is to build up in your arteries. Triglycerides are important because higher levels of triglycerides lead to smaller, denser LDL particles. They're much easier to oxidize and therefore get stuck on your arterial wall and form plaque. Triglycerides decreased in both groups, likely because dietitians assigned diets in the study to eliminate noise in the results, and those diets were likely a bit healthier. However, triglycerides decreased by 40% from 118 to 71 in the fermented kimchi group, while they decreased by 28% from 116 to 83 in the fresh kimchi group. Now, let's step back and just let me talk about my notes, my focus on this study. This is some of the best evidence I've seen yet that any fermented food actually improves metabolic disease. Again, many of us have suspected it, but proof has just been very slow in coming. Despite how well designed this study was, though, there were only 22 subjects. When you only have 22 participants, you must consider genetic variability. But considering this study's design and powerful results, I'm going to add kimchi to my diet. Kimchi isn't a replacement for my lifestyle changes, especially body composition, body fat versus muscle, metabolically active muscle. But kimchi doesn't have negative side effects. We just don't really see any. And there may have been none. At least I've not seen any reported. So some people even think it's tasty. Now, I haven't liked it in the past, but you know what? In the very beginning, I didn't like salmon, kippers, or natto. And I've learned to like it, or at least tolerate it. And I plan to do the same with kimchi. Pardon the interruption, but I've got something important to tell you about the channel. Did you know that 70% of our viewers have not subscribed? Now, if that describes you, you're one of them, consider clicking the subscribe button and the notification bell. With your help, we can reach more people who need this life-saving information. The best part is it's free and easy. And by the way, if you're tired of your current cardiovascular prevention care and are looking for help, call us 859-721-1414. Become a patient and get the level of care that you deserve. Now let's get back to that video. Number 5, nattokinase. We're focusing on another specific study here, one that was done in China on something called nattokinase. It's a special chemical extracted from natto, a fermented soybean dish often eaten in Asia. It's derived from bacteria fermenting in the soybean. This study included a much larger sample size, 1,062 participants. The researchers compared the amount of plaque in subjects' carotid arteries, the arteries in the neck, before and after 1 year of consuming 10.8 grams, 10,800 milligrams of nattokinase daily. The researchers observed an average reduction of about 22% in plaque thickness in the carotid artery. They also measured the before and after levels of other biomarkers like LDL, HDL, triglyceride, and total cholesterol, all of which also saw impressive reductions. On average, there were 15% fewer triglycerides, 16% greater HDL cholesterol, and 17% less LDL. This potent effect was somewhat polluted because there was no placebo group or randomization in this study. But let's examine the study further. 62 participants who only decided to take 3,600 milligrams of nattokinase per day showed a 4% reduction in plaque compared to the 22% in the group that took 10.8 grams. Now, this is very interesting. It's what the epidemiologists call a dose-response curve. Dose-response curves are potent indicators of a causal relationship or cause and effect relationship. In cases like this, where the dose-response curve is so pronounced, you might also wonder, is there a threshold effect? Either way, this is helpful evidence. Now, unfortunately, the study also did not measure the types of plaque in the carotid artery, such as whether it was stable or calcified, or unstable, uncalcified. Since there was no randomization or control group, we must consider the possibility of what's called a healthy user bias in this research. This would mean that people who actively choose to take certain health supplements, in this case, nattokinase, the people that took those supplements, nattokinase, might also be the ones who live healthier lifestyles in general, therefore cleaning up their act, indicating that their lifestyles could have been the major factor. We have to consider other factors too, such as the number of steps subjects walked per day, the number of subjects who smoked, the amount of alcohol users drank, and actually they did look at this. And here's what they found. In groups of subjects who drank more alcohol, smoked, or walked less than 5,000 steps per day, the effect of the reduction of plaque was still just about as strong as that of the users who had healthier lifestyles. In other notes, the funding for this research was not clear. The nattokinase used in this trial was mentioned specifically coming from Sunjin Bioscience Company Limited in Shantou, China. So, like the aged garlic study, you could say you don't trust it due to potential funding sources. That can be an important issue. As we said, though, unfortunately, it's too familiar to ignore. And without interested parties, there would often be no research evidence to consider. The things with the least financial confusion are also the strongest, and that's lifestyle. We'll talk more about that later. In this study, for example, the results seemed so strong that maybe they appeared too good to be true, which is also something to watch out for. If nattokinase or nattokinase can have this type of effect on its own at the alleged dose of 10.8 grams, it would seem extremely important to have further follow-up research on this magical compound to verify if it does what it says it does. However, dramatic and yet potentially flawed, this study is not the only research signal about nattokinase. And there is another thing: the risk of eating natto or taking nattokinase. It appears to be non-existent. I used to use it in my coffee or smoothies in the morning. Then I got distracted again by personal changes in my life and forgot the garlic and the natto. I'm adding both of them back, again, based on the science reviews for this video. Now, number 4, fish and omega-3 fatty acids. Okay, it's time to jump into number 4, fish, specifically the beneficial omega-3 fatty acid kind of fish. We're talking tuna, herring, mackerel, and salmon, all of which have extremely high ratios of omega-3s to omega-6 fatty acids. You already know omega-3s were healthy, but did you know just how healthy they were? The study we're referencing here is one of the most potent forms of research, a meta-analysis. It's research that compiles all of the research done to date together, and using a lot of study logic and statistical work, it determines if there really is a beneficial effect, at least based on all the studies they could find that fit. Now, for this meta-analysis, researchers scoured medical journals from 1947 to 2015 for research on omega-3 fatty acids and their effects on people's risk of heart attack and stroke. They included 34 different studies. The researchers found that an increased intake of omega-3s of about a gram a day resulted in an approximate 9% decrease in any cardiovascular event, such as heart attack, angina, stroke, etc. They found that this risk reduction was even greater in people who are at risk, such as those with high triglycerides. And since then, there's been more and more focus on high triglycerides specific to omega-3s. This study really covered most of what was known about omega-3s up until the time that it was done, about 2015. Now there's a whole new debate about omega-3s. Big Pharma raised this debate. They did what Big Pharma often does. They took a supplement known to have benefits, they modified it, and were going for improving it and securing a patent. Then they sought FDA prescription protection. This was done with the original statins as well as many other medications. And now in the omega-3 space, the drug they created was called icosapent ethyl, or Vascepa. It's a modified version of the EPA, eicosapentaenoic acid, in fish oil. The pharmaceutical trials showed a very powerful effect, about a 25% reduction in deaths, with their modified version of fish oil. Still, they also gave participants 4 grams a day of their version. This is the most ever given in a fish oil trial, as all other research we found only gave up to about a gram per day. Now here's the debate. The debate is whether a weaker omega-3, DHA, competed with, replaced, and weakened the more powerful EPA. While I occasionally use the prescription source, sometimes in my patients, I often recommend and personally use the over-the-counter omega-3s. Berries are a big deal, diet-wise. We found an interesting study. It was done in Iran on whortleberries. Now, that's not exactly one of the berries I'm used to eating. Raspberries, blueberries, blackberries, and strawberries have been my thing. Now, what they did was they took 40 people aged 20 to 60 with high cholesterol or triglycerides, and they gave them a whortleberry extract, a capsule every 8 hours for 2 months, while another 40 people took a placebo. That was the control group. The results showed that the whortleberry lowered total cholesterol by about 28%, triglycerides by 20%, LDL by 26%, and most importantly, raised HDL cholesterol by a whopping 37.5% without side effects. Now, the whortleberry used in this study was, quote, collected from the lands of the Ardabil province of Iran in October, and a botanist authenticated its identity and also mysteriously said a voucher specimen of the plant, number 1023, was deposited in the Central Herbarium of the Research Institute of Medicinal Plants. Does that sound like a regional play for the whortleberry business? It does to me. The researchers supposed that the high anthocyanin content of the extract was partially responsible for the dramatic changes in lipid metabolism. However, they also said the specific bioactives mediating the anti-dyslipidemic, in other words, the ability to decrease blood fats. The effects of the plants belonging to the Vaccinium genus, or whortleberries, are not yet characterized. Let me translate that. They don't know what happened, but they think that it did happen. That's their assertion. Although in our research, the whortleberry extract appeared in the literature as showing the most effects of nearly all berries, blueberries, strawberries, elderberries, cranberries, etc., from another meta-analysis, a study of studies. It concludes, this review has presented a considerable amount of evidence to support the consumption of berries for cardioprotective effects on endothelial function, the lining of the artery wall, arterial stiffness, LDL cholesterol, oxidized LDL. Considering these findings, I do encourage berry consumption. So again, even though this one study may have had some regionalism effect, that whortleberry study, there's still a lot of research showing the beneficial effects of berries on various biomarkers of metabolic health. And it's impossible to fit it all into one video, especially one section of one video. Now, you might ask why we even discussed the whortleberry study. It's actually very interesting. It appeared to be the only berry that dramatically increased HDL, one of the strongest factors affecting the buildup of plaque. The results were, in fact, so impressive that they perhaps should be interpreted again with a degree of skepticism. Number 2, eggs. Eggs are number 2 on our list, which may surprise you given the conflicting advice about them, especially due to their cholesterol content. Now we're looking at an exciting study from northern Manhattan examining how eating eggs might affect the risk of stroke and heart disease. The researchers examined over 1,400 people, looking at their eating habits and using ultrasound scans to measure the thickness of their carotid arteries. CIMT again. The major blood vessels in the neck that supply blood to the brain. Carotid intima media thickness test. They wanted to see if there was a link between how many eggs these people ate and the health of their carotid arteries, specifically the buildup of plaque. This can lead to severe problems like strokes, and it also reflects the condition of the arteries in the heart, therefore heart attacks. It turns out that the more eggs people ate, the less plaque buildup they had. In fact, the researchers found that eating just one more egg per week seemed to reduce the risk of plaque by 11%. Up to a specific limit, of course. Eggs are not going to make you invincible. The thing is, eggs don't cause rises in blood sugar levels, so they don't set your arteries on fire, like cereal. This leads to your artery wall being stickier and thus building up plaque, again with things like cereal, processed carbohydrates. The researchers also note that eggs led to an increase in HDL particle generation. The thought that eggs are bad for you is really an old thought. It's outdated advice. Now let's get to number 1, cruciferous vegetables. We're diving into a study that focused on how different types of vegetables influence the thickness of the carotid arteries. Again, thickness of the carotid arteries, the arteries in your neck that supply blood to your brain. This study began in 1998 using a detailed food questionnaire to assess the participants' daily vegetable consumption. The veggies were grouped into categories like cruciferous. Think broccoli and cabbage for cruciferous. Allium. Onions, garlic that has allium in it. Yellow, orange, and red vegetables, leafy greens, and legumes. A few years later, in 2001, researchers used high-resolution ultrasound to measure the thickness of these participants' carotid arteries. Again, a version of CIMT. Here's what they found. Those consuming at least 3 servings of vegetables each day had between 4.6% and 5.0% thinner carotid artery walls compared to those eating less than 2 servings. Again, 5% may not sound like much, but remember, 1% thinner artery wall results in 25% decrease in risk. This reduction is significant. Thinner artery walls mean a lower risk of heart disease. Cruciferous vegetables were particularly effective. To the carnivores in the crowd, sorry to have to tell you that, and to the vegans, I get your drift on it. Every 10 grams per day increase in these veggies was linked to a 0.006 millimeter or 0.8% reduction in the average carotid artery thickness, and a 0.007 millimeter or 0.8% reduction in the maximum thickness. Cruciferous vegetables, including cabbage, Brussels sprouts, cauliflower, and broccoli, contributed the most toward this beneficial effect. The researchers, again, were not sure. They didn't understand why cruciferous vegetables had this effect. Besides various compounds such as polyphenols, polyphenols can scavenge radicals that oxidize LDL particles and cause them to infiltrate the artery wall. Or other compounds such as isothiocyanates. They can block oxidative stress. Other factors that could play a role could simply be the amount of fiber contained in the vegetables, causing participants to eat fewer calories, or to help push that food further down into the lower gut where the bacteria are eating the food, not the human. The calories are going to the bacteria. The effect could also help keep blood sugar levels low by slowing down digestion. The research for this article helped remind me to get back up to speed with a few things in my diets and supplements. I'm adding kimchi back to my diet. I always hated kimchi, but you know what? I think I'm going to have to learn how to like it. And I added kyolic garlic back to my supplements and natto back to my coffee. Now this brings up a topic. If you're thinking, wait a minute. The title says food, but there are a couple of supplements, like aged garlic and natto. These are actually foods, but supplement companies created convenient supplement preparations. You see the same thing with omega-3 oils, fiber, and other supplements and foods. Be careful to watch dosages in these situations. And another warning, remember that you cannot out-supplement lifestyle. Lifestyle trumps supplements, prescription medications, stents, surgery, everything. And among the lifestyle components, diet is key. In other words, you can't outrun a diet problem. You can't out-stent a diet problem, and you clearly cannot out-supplement a diet problem. You just can't. It's not just BMI or your weight. The presence of metabolically active muscle is as critical as the absence of metabolically active fat, especially as we age past 65. Metabolically active muscle, especially in the legs, is our critical internal safety valve, pulling sugar out of the bloodstream where it can cause damage. It can damage the delicate wall of the artery. Resistant insulin receptors. Let me repeat that. Muscle bypasses resistant insulin receptors. Resistance training is important for muscle mass and metabolism, as measured by muscle biopsies where they actually found higher levels of mitochondria in people that did resistance training. Now let's talk about HIIT, because they found even more mitochondria in people that did HIIT training, high intensity interval training. I know that can be uncomfortable. I have more people skip the HIIT than any other type of exercise. But it's an even more powerful stimulant of muscle mitochondria. HIIT is the best way to reverse the loss of capillary surface, that interface with those large muscles in your legs that are going to protect you from prediabetes, resistant insulin receptors. So for many, it's just hard to think about HIIT. You may have a knee problem or a hip problem or a back injury. You may not have the time for a couple of half-hour HIIT sessions, or at least think you have the time for those half-hour HIIT sessions each week. Your most intense level of exercise might be walking. If this fits for you, think again about HIIT. There is a new thing called ReHIIT. It stands for Reduced Exertion High-Intensity Interval Training. It can be done by walkers for people with joint injuries. You can accomplish a ReHIIT session in as little as 5 minutes. Let me repeat that. You can accomplish a ReHIIT session in as little as 5 minutes, and these have been shown by science to be very helpful. Now here's a short version of ReHIIT. A typical ReHIIT session involves only 2 intervals, not 10 like you see in the standard HIIT session. In addition, the intense phases are 20 seconds, not 60. Now you see why it's called ReHIIT or Reduced Exertion HIIT. Only 2 intervals and only 20 seconds per intense phase. Now there is a trade-off. It's in intensity. Instead of getting to that 80 or 90, even 90% of your max heart rate on the typical HIIT training, in ReHIIT, you're going all out, 100%. But even though you do that, going 2 instead of 10 intervals and 20 seconds instead of 60, that's a really big deal. You don't feel washed out. You can complete it in as little as 5 minutes, an entire session. And you can do more complete sessions because you're not as worn out. So, as you see, many of the studies we discussed reference HDL, LDL, and triglyceride. Now let's talk about that for a minute. Why did we look at that? You might ask, well, if metabolic health is the strongest driver, why look at cholesterol values and triglyceride? Now here's why. These are what we call bioindicators of metabolic health. When we see patients, we help them interpret these lab results to determine their level of metabolic health. Now, these ingredients are more than just hype. Some have shown real measurable plaque reduction in both clinical trials and patient outcomes, even in patients in my own clinic. We've seen improvements in inflammation, reversal of insulin resistance, even regression of soft plaque on imaging. Let's go a little bit beyond science. Let's talk about something very personal. I didn't just research this next part. I lived it. Years ago, I found out I had plaque, despite a healthy lifestyle. Good cholesterol numbers, great cholesterol, and no symptoms. And yes, I practiced what I preached to teaching doctors at Hopkins. I was not cheating, but still, there was a wake-up call here. I decided to apply everything that I knew. I went back and re-examined my own life to see if there were things that I was doing that I could adjust. Let me show you what I did and what the scans revealed. I reversed 20 years of arterial plaque. For years, I was eating the wrong diet. When I actually got tested, I was emotionally annihilated. Despite my efforts, I still developed cardiovascular plaque. I truly believe that what I did can be done by many people. Not everyone can reverse plaque, but almost everybody can stabilize it and decrease your risk of a heart attack. Take the vast majority of that risk right off the table. This is what I did. This is my story of how I reversed my arterial plaque.
This video is about how I found plaque in my own arteries and what I did to reverse it. I hope my story can help you identify whether you have plaque and what you can do to minimize it. I'll cover the dietary, lifestyle, supplements, and medication changes I did after I found out that I had plaque. You'll see both my actual CIMT studies showing the presence and then the reversal of plaque in my arteries. Stay until the end, and I'll show you how my latest numbers turned out. We'll also show medical lab tests demonstrating the exact cause of the problem, and then blood tests that show what reversed that plaque. Spoiler alert, I'm like most of us. Aging took a toll on my insulin receptors. Remember, growing old is just not for sissies. At the end of the video, I'll share a confession with you. It's about an unpopular choice I've made to manage my plaque, and I've already caught a lot of grief. Here's what happened. At age 57, I thought I was healthy. I've been a prevention doc for over 40 years, about 4 decades. I ran the preventive medicine program at Johns Hopkins. So I taught the doctors at Johns Hopkins, and that's arguably the #1 preventive medicine program in the world. As far as prevention was concerned, I also practiced what I preached, and that was all about lifestyle and no medications. Low-fat dietary guidelines were the standard at that point in time. Nobody questioned it. At that time, we were just discovering that cholesterol in the diet might not be the cause of cholesterol in the artery walls. So as that concept turned around, it was turning towards calories. Since fat was the most calorie dense, fat must be the biggest problem. That was the logic anyway. I believed it at that time, and for decades. Not anymore. But that's a different story for later. Back to those previous decades of my lifestyle. I overachieved in the cardio exercise space. I ran half marathons, sometimes more than every week. I ran a dozen full marathons by age 55. I was not only against medication, but also against supplements. To me, supplements at that point were just expensive urine. But something happened at age 54. I should have paid a lot more attention. During a routine screening, I noticed my blood pressure was 130/90, and it didn't come back down. I didn't like it, but I finally agreed to take medication to lower my blood pressure. I retired, yet again. I've retired a few times, and started looking for something to do. A mutual friend introduced me to Brad Bale and Amy Doneen. Brad and Amy teach their own form of preventive medicine. I read their book, Beat the Heart Attack Gene, which opened the door to 2 other perspectives for me. First, It made me question the standard model of heart disease focused on LDL cholesterol, or quote, bad cholesterol. Like most docs, of course, I knew that diabetes caused heart disease, but I had no clue just how common prediabetes is. And also, like most docs, I didn't know how to diagnose it. And like most docs, I really had no clue that metabolic disease causes most chronic diseases, and even most of what many of us call normal aging. The second perspective I got from reading Brad and Amy's book was test, don't guess. Coming from Hopkins, I'd always been focused more on William Osler's advice on history, listening to the patient. Getting focused on Brad and Amy and thinking about test, don't guess gave me a whole different perspective. I began to realize that patients listen to lab tests when they won't often listen to their doctor. So, Brad and Amy invited me to their next event. They were training doctors in Las Vegas. I joined them there. Some vendors were providing a free screening test called CIMT. It was a quick test, literally less than 5 minutes. Safe. There is no radiation. And inexpensive. The routine price was between $200 and $300. That test, again, is called the CIMT. It stands for Carotid Intima Media Thickness Test. It's an ultrasound of your neck with a special measurement technology component. It's used to measure plaque instead of what most tests, like the stress tests, do, measuring blood flow. So why looking at the neck, the carotid, instead of the heart? Plaque formation is due to metabolic issues, metabolism. Metabolism's the same all over your body. So if you have plaque in one artery bed, you have it in all the others. But here's the key. CIMT doesn't focus on blood flow. It focuses on plaque. And more importantly, the type of plaque. Again, that's why cardiac stress tests, which measure blood flow, do not predict heart attacks. Back to the story. So I took the CIMT test, expecting to see no plaque. I was wrong. Look at this chart. This was 2015. And you can see my name and 2 pictures, my right and left carotid arteries. What really impacted me here was the number next to it, 1.209 millimeters on the right side and 1.215 millimeters on the left side. Now, what does that mean? This is an artery, and it has many layers. Let's focus on 2 of these layers. The one in the middle is called the media. It's made mostly of muscle. It allows the artery to expand like one of those expanding garden hoses. Then you have the inner layer of the artery wall, the intima. It deals with the essential metabolic functions of the vessel, like dropping off oxygen and picking up cellular waste materials. Guess where plaque builds up? Nope, not on the inside, but between those 2 layers, the intima and the media. That's why they call this test the Carotid Intima Media Thickness Test. The ideal thickness is 1 millimeter or less. Any time you go over that, it's considered a significant plaque. Some more conservative researchers don't count plaque until it reaches 1.3 millimeter thickness. Now, it took me time to realize that despite all of my healthy habits, I had still developed cardiovascular plaque. That was a gut punch. At first, I felt like all that work, that discipline to stay healthy, was wasted. I felt like maybe I should have just let myself go, eat all I wanted, lie on the couch, watch TV, be lazy, eat nachos, etc., etc., etc. It took me weeks to emotionally wrap my head around the other side. If I still had plaque with my focus on prevention, what shape would I have been in if I had not taken care of my body? it slowly dawned on me that I could already have had a heart attack. I could even already be dead. It doesn't take much plaque to cause a heart attack. Now, here's another thing that changed my life. Right here, you can see, even though my average IMT was below 1 millimeter, I still had more plaque than the average 57-year-old. I actually had the arteries of a 73-year-old. And that's when I started to think, I've got to change something, or I could die. I lived in Lexington, Kentucky at the time. Each Saturday morning, I ran my half marathon through some of the most beautiful horse country in the world. I remember starting the Saturday morning after discovering my plaque. It occurred to me that if I had a heart attack out there in those horse farms, it would be hours before my body was found, cold and lifeless. Pardon the drama, but those fears are normal for someone that's first recognized their mortality, and often from finding the first time your own cardiovascular risk. Then I finally composed myself and realized I'm a professional in this space. I know more about it than most, and I needed to listen to my own medicine. For example, exercise like jogging doesn't cause heart attacks, and I needed to move on. So that's what I did. When I returned home from that run, I decided to make a few changes. I did a few more tests. I did multiple tests, but the most important was an oral glucose tolerance test. These next 3 sentences are the 3 most important sentences in this video. If you hear nothing else, at least hear this. My blood sugar peaked over 160. That meant I had enough prediabetes to cause cardiovascular plaque. Let me repeat, my blood sugars peaked at greater than 160, indicating enough prediabetes to cause plaque and heart disease risk. So, you remember those changes I committed to make? One of them was, and the biggest one was, I switched from a low-fat diet to a low-carb diet. My biggest change out of all of them was switching from a low-fat diet to a low-carb diet. And today, I've tested multiple diets ranging from carnivore to vegan to paleo, ketovore, and everything in between. But all were on the low-carb side. Now, I'm doing even keto. I'm ketotic about 5 days a week. I've been fat adapted for about 10 years. These days, I blow acetone in the range of between 5 and 20 parts per million, again, 5 days a week. So if you didn't get that, let me say it differently. I'm ketotic most days. I'm burning fat, no matter which diet I'm on. I just don't eat enough carbs to change that part of my diet, no matter which diet I try, vegan or carnivore. I especially avoid processed carbs and grain products. Let me show you the progress. This is the biggest progress I've ever made. In about 1 year, I was able to reduce my average CIMT from 0.88 to 0.67 millimeters. That was 1 year, reduced my average CIMT, intima media thickness, from 0.88 to 0.67 millimeters. Now, let me explain what that means. If you look at the image right here, it means that I was able to reverse my arterial age from 73 to 52 years. In 1 year, I was able to reverse about 20 years worth of arterial plaque deposition. Now, how did this happen? Let's go back and talk about what does, quote, plaque reversal actually mean. When you reverse plaque, you're not necessarily taking calcium out of the artery. It doesn't even mean taking cholesterol out of the artery, necessarily. Here's what you're doing. What you are doing is taking the inflammatory liquid, the swelling and pus, out of the plaque, So it's like you're deflating a balloon or a tire. It will decrease the size of the plaque and the size of the intima media thickness. Loss of inflammation makes plaque shrink. Calcium deposits are just biomarkers. They're biomarkers of decreasing inflammation. But not everything is sunshine and rainbows. I still had plaque. Take a look at another CIMT from 2019. You can read the description of the CIMT in different areas of the carotid artery here in the comments. My right carotid bulb says 1.3, again in millimeters, and the letter H. H stands for heterogeneous. Heterogeneous, this sounds geeky, but hang in there for a minute. It's essential. You'll see why. You've seen the word heterogeneous. Heterogeneous means mixed, just like homogeneous means consistent. Heterogeneous plaque is a mixture of soft and calcified plaque. How calcified? Well, it's actually mostly calcified, as you can see in the white in the image right here. Soft, hardened, and mixed plaque is classified by the amount of calcium embedded in that plaque. New plaque is homogeneous, soft, and deadly. It can squeeze into the bloodstream, where the inflammatory goo causes clots. The clots cause the problem, not the plaque itself. The inflammatory liquid is basically pus. Soft plaques have a very thin cap near the intima. It doesn't even have to be big, just soft. As the body heals the plaque, it calcifies. This is an example of heterogeneous, partially calcified plaque. You can see it has some calcium, which is good. Calcium in this case helps with the healing and scarring process. It's a biomarker of plaque stability. Now, here, this is not the healthiest calcification. Calcium is all over the place. It's not organized, and it's surrounded by a lot of hot liquid, like islands of hot liquid and calcium. This plaque can still rupture if the cap is thin. This is calcified plaque. The calcium is well organized, and it has a thick cap. It won't break. It's stable. It won't cause a heart attack or a stroke. Removing inflammation or reversing plaque causes more stable plaque and less or no soft plaque. The best goal is to have no plaque at all. But most of us develop plaque as we age into insulin resistance. When we do, here's what to do. Stabilize that plaque and keep it stable. So, what did I do to reverse my plaque? Remember when I said I came back from that first long run after finding out my plaque, and I decided to change a few things. I changed the way I ate. As I said, I went from low fat to low carb. I changed the way I exercise. I changed my mind on supplements. I changed the way I slept. And yes, I even started medications. Some of these changes, like medications and supplements, were helpful, but far less important than lifestyle. That's been proven time and time and time again. Lifestyle is king. The most important change for most people is weight loss. At 5'10", I weighed about 157 pounds, so I didn't have much opportunity there. I did lose 5 to 10 pounds, and that did help. I also traded in marathon-level distances for a lot more HIIT and resistance training, especially in the legs. Metabolically active, strong legs are the most effective internal safety valve against rising blood sugar. I started taking supplements. I started with vitamin D3, 5,000 international units, and niacin, 2,000 milligrams a day, mostly because I had some HDL issues. I've updated that list to my current needs. And now I'm taking vitamin D3, 5,000 international units a day, K2, 400 micrograms a day, with an additional tablespoon of natto, L-citrulline, magnesium L-threonate, magnesium chloride, kyolic garlic, and I'm also taking more natto. Let me tell you where I am now. This is my latest CIMT from December 2023. This CIMT is from CardioRisk. CardioRisk has world-class CIMT quality processes. As you can see, in my left carotid artery, I still did not develop more significant plaque. It stayed mostly below 1.2 millimeters. On my right side, that plaque I had from the beginning is still 1.3 millimeters, and it's still stable or heterogeneous. Let's take a closer look at that obnoxious plaque. As you can see in the image, it's very white. That's calcium. It's mainly calcified. Again, it's stable. I was 66 years old when I did this test in December of 2023. My arterial age is now, drum roll please, my arteries are still back at the healthy level of 58 years old. And I'm still way below the average for my age. Now, regarding labs, we talked about those early on. I've had low HDL for most of my life. I've actually increased my HDL when I went low carb. I did that even though I was aging. And most of the time, people age and decrease their HDL. Now, why is that important? Low HDL is a very strong warning sign of unhealthy carb metabolism, meaning that I've probably had subpar carb metabolism even when I was much, much younger. In other words, probably bad genetics. Getting those carbs out of my diet has helped my metabolism, as shown in lipid or cholesterol profiles and fractionation. Now, what am I doing at this point? First and foremost, I keep my body fat down. I've had 2 DEXA scans. Here are the images. My body fat stays around 20%. That's equivalent to an 18-year-old, the average 18-year-old. My visceral fat stays around a half a pound to a pound. That's also very healthy for an older man like me. And it's not incredibly easy either. But after decades of watching my body fat, it's not that difficult either. By the way, I have ice cream twice weekly. As you can see, my diet is usually, but not always, lightly to moderately ketotic, even with the ice cream. I never had positive urinary ketones until recently. Recently, I went on a 5-pound water fast and really got very ketotic urine strips. But I've always known, or over the past couple of years, I've known that I'm ketotic because of breath ketones. I exhale about 10 parts per million acetone most days. Yes, acetone's finger polish removal stuff, that chemical. And yes, your body makes it when it's burning fat. Urinary ketones are far more challenging to see if, 1, you've been fat adapted for a long time, and 2, you remain mildly to moderately ketotic. Both of those descriptions fit me. I've been managing my carbs at this point for over a decade. I also work out regularly and hard. I do HIIT and ReHIIT, high-intensity interval training. As you see on the screen, I'm not just jogging, I am sprinting uphill. I followed Sean Amara's uphill sprinting advice long before I'd ever heard of Sean Amara. These uphill sprints are also aggressive for a 67-year-old man. I do multiple types of muscle training, especially in my legs. Strong, metabolically active leg muscles are our best safety valve against rising blood sugar. And I do this work multiple times each week. It takes discipline. But whether it's diet or exercise, the hardest part is actually making that change and making the change stick. So, if you're sitting there and thinking, everybody knows that you should get a stress test and then a stent and then just be done with it instead of all of this hill sprints and diet management. If you're thinking that, be aware that I wrote a whole book on why stress tests don't predict heart attacks and stents don't prevent them. The calcium score is more well-known, and it's harder to mess up than a CIMT. But calcium scores don't tell you everything. In fact, they don't tell you the most important thing. They don't tell you anything about soft plaque. Also, a high calcium score can mean either unhealthy calcification or healthy calcification, so it has its limits. I do recommend it to find out if you have plaque for the first time. But even a score of 0 is no guarantee. There are plenty of people that have had heart attacks with the 0 calcium scores. After watching this video, you may understand why. If not, we'll cover that in another video. Lastly, the new kid on the block, CT angiogram with AI, artificial intelligence. I'm a big fan. It can show both soft and calcified plaque with a lot of detail. However, it has some downsides. It's more expensive. It is invasive somewhat. And with the wrong interpretation, it can also put you through the process of getting an unnecessary stent or bypassed. I chose CIMT because, despite its challenges, it's the only quick, non-invasive, inexpensive way to identify soft plaque. Again, soft plaque is the key. You're right if you think the lack of radiation is an advantage too. It is. The other ones all have radiation. But I don't think the radiation from a CT angiogram, or clearly a calcium score, is significant if you're dealing with cardiovascular disease risk. I do plan to get a CT angiogram with AI analysis at some point. As we said, it's expensive, time-consuming, requires radioactive dye. I just keep putting it off because the only reason I really need to do it, a CT angiogram, is to provide it to my viewers on YouTube. And I obviously like you guys a lot, but CT angiogram's a headache. We've yet to talk that much about what caused all this. In short, I belong to those 52% of us over age 18 with prediabetes. And guess what? Within a couple more years, my insulin receptors continued to age into a state of full type 2 diabetes. Now, I took all the risk off the table. I'm not worried about it. Again, I took the risk off the table. Many people like Jason Fung, Eric Westman would say, I think they would say, I cured my diabetes. In other words, I don't eat carbs. I don't eat enough carbs to cause a problem. Now, I also told you early on that I was going to give you a confession. The next thing is going to create controversy. It already has. I've gotten hater comments from some of the most prominent content creators and viewers in this space. But be patient with me. Cutting carbs was not the very first thing I did. I didn't even know I had prediabetes for the first few weeks. The very first thing I did was to take a medication. And guess what type? It was a statin by the name of simvastatin. It was low dose. And I wasn't trying to beat down my LDL cholesterol. In fact, LDL cholesterol was very low. And if you're about to click away, just hear me out for a second. Yes, I know, statins are associated with significant problems. And yes, Big Pharma has made more than a ton of money from statins. But here's the problem. It's mainly used at higher doses, and it's mostly used to beat down LDL cholesterol. Everybody beats up on statins, and they beat up on me for saying that I used them. So what is the purpose of a statin? Is it like most people think, to decrease cholesterol? No, I don't use statins to lower cholesterol. So why did I take it? The evidence is clear that low-dose statins can decrease cardiovascular inflammation. I only use low-dose statins myself or for my patients who choose statins. And I only recommend either rosuvastatin or pitavastatin, the generics. I actually switched from simvastatin to prevestatin, and even now, I take a low-dose rosuvastatin, 5 milligrams, 2 or 3 times per week. Also, you don't have to take it every day, especially the ones like rosuvastatin with a longer half-life. Now, this sometimes needs to be clarified, and I get comments like, here is a video from Dr. Brewer selling statins. I'm not selling statins. This video's not sponsored. The reality is statins can help, but they're not central to plaque management. They get way too much focus. They're simply an adjunct to lowering cardiovascular inflammation, not LDL. I also took baby aspirin. There is risk of bleeding, but it has been proven to decrease the risk of heart attacks by not developing clots. Baby aspirin is also not for everybody. I only recommend it when there is evidence of plaque. Anyhow, let's move on. Multiple studies plus just plain old logic have shown multiple times prescription medications cannot come anywhere close to lifestyle. You cannot outprescribe or even outsupplement a lifestyle. And the most important part of lifestyle is eating habits. Supplements are far more popular than prescription medications. There are times in my practice when over half of my patients have chosen 0 medications. And not only am I okay with that, I'm very impressed with it. If you're wondering about LDL, recently, my LDL, I've got another story there. Recently, when I transitioned from low carb to a keto diet, my LDL increased from 55 to 110. I'd always had low LDL. And then the next month, up to 180. Additionally, even though I'm still technically diabetic, my triglycerides, A1C, and insulin are as low as they can be. They're very, very low. And I have a healthy HDL cholesterol. So, if you've made it this far, thank you for your interest. I'm retired, sort of. Yes, I love travel and golf, but I love having an impact far more. People tell us all the time that we're saving lives every day with this information, and we believe them. There's no travel or leisure activity that can ever match saving a life.
So I turned to something most doctors still are not using, despite the fact that it's proven to be the most advanced method for evaluating plaque and therefore risk of cardiovascular disease, health of your arteries. It's AI, artificial intelligence-based imaging. This technology analyzes the arteries with far more precision than traditional scans, and including traditional CT angiograms that have been interpreted by trained radiologists. AI beats them hands down. And it can detect changes most tools just completely miss. So what I wanted to know, had the soft plaque that was in my arteries, had it really stabilized? Was the reversal visible, not just on paper, but in my arteries, in the images? Jesus was nervous. He said, Doc, well, what happens if we find that you've got a lot of soft plaque in there? And my response was, well, we share that information. That's the purpose of getting this. And we also share what I'm doing in terms of doubling down on some of the things that I need to do to control this. But that's not what happened. The results were clearer than we had expected. Let me show you exactly what those scans revealed and why those scans, even they're on my heart, why they matter for you. I reversed 20 years of arterial plaque, and I've got the report to prove it. So, if you're thinking that you're unhealthy and you can't get over it, that's not true. You can stabilize your arterial plaque. So, about 10 years ago, when I was 57 I got a test called CIMT. It showed that I had the arteries of a 73-year-old. I made some changes, not huge changes, but they were important changes. Over the year, I got probably a half dozen CIMTs. They showed a steady decline in my arterial age. Now, people that don't know this study said, look, hey, that's arteries in your neck. What does that tell you about your heart? So we've described CIMT, the science behind it, and how plaque is a metabolic thing, not an anatomic thing, not a localized thing. So if you've got plaque here, you've got plaque here. So at the end of the day, I said, you know what? The channel's important. I'm going to go ahead and get a CT angiogram with an AI, artificial intelligence analysis. It's called Clearly analysis. These tests are expensive. It's a couple of $1,000. And I really didn't feel like I needed it to manage my own case. But again, the channel's important, and I wanted to get that information out there. These really are the state of the art in terms of not only showing the anatomy of the plaque, which we don't care quite so much about, showing the consistency and the character of the plaque. That part is critical. But enough about all my jawboning. Let's go up to the office and actually look at the results. Now let me walk you through the results step by step using the Clearly report. So this is the Clearly report, and it shows three basic things. Number one, they call atherosclerosis, and that's mostly the quantity. The second one is stenosis, and the third is dominance. Now, as I said, I do have plaque in my arteries. There's no question about that. I've had that for at least 10 years, had it before then. And that's fairly common. In fact, it's very, very common for a 67-year-old man, and it's common for a 57-year-old man as well. Now, to go deeper in that, I have 75.6 cubic millimeters of plaque. That may sound like a lot, but it's not very much at all. The bottom line is, even though I have very little plaque, if I have the wrong kind of plaque, it can set me up at risk for heart attack. The most important part is here. It's the character of the plaque. You see three different categories: low density non-calcified, non-calcified, and calcified. Now let's go a little bit deeper into those. This first one is the one that you don't want, low density. It's also called low density non-calcified. It is soft plaque. It's that plaque that's boiling with what we call immune cells. It's where your body is saying, we don't want plaque here, and we're going to get it out. It's releasing enzymes, trying to metabolize or eat up and get rid of that plaque. It's liquefying it. That's the kind of plaque that can slip back into the flow of the blood, cause a clot, and then the clot causes heart attack, stroke, or damage to other tissues. So here's my results. I have 0.1 cubic millimeters of soft plaque. In other words, on a practical basis, I don't have soft plaque in the arteries of my heart. So I can say with comfort and security that I don't have significant risk for heart attack right now. Now let's talk about the other two types of plaque. They're both stable, but there's a difference. The calcified or very stable plaque is exactly what we're saying. It's stable. It's not likely to go anywhere. In fact, studies from people like Honda and many other groups have shown that stable plaque does not create risk for heart attack or stroke. So again, so much is involved and so much depends on understanding plaque itself and what's actually happening. Soft plaque is that boiling, inflamed, soft stuff that can leak out and cause a clot. The other types of plaque, they don't do that. What happens when your body begins to decrease that inflammation is it starts to form a scar. A strong signal of that scarring is your body starts to deposit calcium. It starts to calcify. Once that happens, the plaque is stable and is not a risk for an event. Now let's go back to my results. I have 75 cubic millimeters of plaque. 31 of those is this stable, calcified, not going anywhere, locked in cement kind of plaque. Now that starts to get to the rest of it. The 75 minus 31, the 44 millimeters that I have extra. So the real question is, does it cause risk, or is it a risk type of plaque? And I'll give you the answer that our channel manager, Jesus, hates for me to give. But the bottom line is, it's the reality. It depends. So this mid-range plaque, technically called non-calcified plaque in this report. It's a higher density, but still non-calcified. This plaque is interesting. It can go either way. It depends on your lifestyle. So I know from working with these, this is stable. You ask the folks that clearly, you ask other folks that know this work. They're very clear. That kind of plaque is stable, but it can go either way, depending on how you manage it. Now, that was a whole lot. And I hate to tell you, but that's just the first part of this report. But again, if you want to summarize it, you want to think through it, that's the most important thing. If you remember only one thing from this video, remember that. Soft plaque, that's what causes risk. Let's move on to the second big category though, and that is stenosis. Now, stenosis, that's just a fancy technical word. It means narrowing. So narrowing of the arteries. And I get this all the time. Patients will come to me in a panic saying, my doctor told me I have 95% narrowing of my heart, usually that LAD, the widowmaker. And yes, there's some concern there, but not as much as you might think. In fact, most patients, when they come to me, end up getting a very pleasant surprise about their risk, their actual risk. And that pleasant surprise comes from understanding the difference between plumbing, a 95% blockage, and the character of the plaque, whether or not the plaque is stable. You know, one of the things that we often do, a patient will say, I've got 95 or even 100% sometimes blockage of that artery. And I ask the question, well, you just told me a few minutes ago you're running or you're doing high intensity interval work. Are you having pain? Then you start to see them think, and the answer is no, I'm not. So then the obvious point is, well, you're getting flow, and that can come from a couple of different places. It can come from what we call collaterals, arteries that have grown around that stenosis, or even more often, the fact that arteries are not like rigid plumbing. They're like those new garden hoses that expand. They're made with muscle, not copper. So again, as I said before, most plumbers, that is cardiologists, think about how much blood flow you're getting. Patients assume that's the correct thing. You're not going to get symptoms until you have 50% or more blockage. You're not going to have anything show up on a stress test until you get 50% or more. That's half the artery wall blocked with plaque. Most heart attacks actually occur with people with less than that much plaque. So again, that helps you understand the importance of soft plaque, not how much plaque. But let's go and look at mine. If you look at mine on the report, you go next to this number 6, and you see basically what they're saying is that soft plaque is minimal. So again, minimal risk. Now to get a little bit deeper into detail, I have areas of plaque in my right coronary artery and my LAD, left anterior descending. The LAD you might have heard of, it's called the widowmaker. It's one of the most common places to find plaque if you're going to have plaque in the coronary arterial bed. So I have a tiny bit of plaque in the proximal or closer end of my right coronary and my mid right coronary. I also have a little bit of plaque in my proximal LAD. I also have a little bit of plaque in the circumflex, again in the proximal area. Most places I have less than 10%. The LAD is the only place where I have more. It's at 17%. And just to remind you, as I said, most of the time, if you're going to have plaque in the coronary arterial bed, it's most often found in the LAD. So let's get way back up to 50,000 feet. And again, ask the question, am I worried? The answer is no. I'm actually relieved. I was hoping that I would find this. I had that suspicion, and it's like a really nice Christmas present to find what we found. Now, let's talk about dominance. Now, dominance may not be what you're thinking. It's which artery supplies blood to the lower part of the heart. And in my case, I'm right dominant. It's not because I'm right-handed. My artery just happens to be right dominant. So my right coronary artery is sending blood to the bottom of my heart. So the bottom line is, if you want to get the definitive study for plaque and cardiovascular risk, this is the study you got to get. It's a CT angiogram, and it shows not only the location, not only how much. Those are important, but those aren't really the critical issue. It shows you the character of your plaque. So I'll go into detail in a minute on how I kept so little plaque in my heart and have so little cardiovascular risk. But before I do, let's go a little bit deeper into the analysis here of my report. Now, this is another way, maybe a little bit more technical way of looking at the amount of plaque. Percent atheroma volume. It's looking at how much of your volume or flow is being taken up by the atheroma. For someone less than 5%, that's practically no plaque. And as you see on my report, mine was 2.5%. We will talk a little bit more in depth about how I got there next. I'd like to take a quick moment to introduce you to my Metabolic at-home risk program. This is a real game changer for anyone thinking about your metabolic health and your longevity. And it's priced at just $169.50, so it's an incredible value compared to other programs that cost 3 times as much. And you can find links below to a special limited time promotional code. Plus, I've included a lot more information at the end of this video. Just last week, hundreds of other viewers invested in their health with this kit. Why not join them on their journey to a healthier and more fulfilling life? Now, back to the show. So again, to get back up to 50,000 feet, what's the number one thing, the number one change that protects your arteries? It's diet. Number one, recognizing if you're one of those 90% of people that have metabolic disease problems, that has poor metabolic health. And then number two, do something about it. If your body cannot process carbs without a bad health effect, just don't eat the carbs. So now you go back and you think, okay, well, what is a low carb diet then? A low glucose or a low carb, a low sugar diet. Does it mean skipping desserts? No. Go back and look at the things that cause your blood sugar to go up and to stay up. That means cutting processed cold breakfast cereal, grain products like oatmeal, believe it or not, especially instant oatmeal or quick oatmeal. I hate it, but grits for me as well. I'm a southern U.S. boy. But the biggest items that you tend to see in most diets throughout the world are breads, pastas, rice, those kind of grain products that you get in lunch and dinner. So the bottom line is, it may sound complicated, but it's really pretty simple. Just stay away from anything that makes your blood sugar go over 140. And when it does go over 140, take a walk, do some sort of gentle workout, and you'll pull that sugar out of your blood and back into your muscles. For me, that means no bananas, no apples, clearly no apple juice or grape juice. And you might say, yeah, but I heard that fruits were healthy. You maybe also heard that oatmeal was healthy. Eat some and then measure your blood sugar. You might know people, and you might yourself drink sodas. those things that are sweetened with high fructose corn syrup. High fructose corn syrup doesn't raise your blood sugar actually as high as it should, but it still does damage from the liver side. Please just stay away from high fructose corn syrup. And then start reading food labels. You'll find that it's not just Coke or Pepsi or sodas. Most foods that are highly processed have high fructose corn syrup. So I used to get most of my calories from carbs, like breads and pastas. That has totally changed. I get most of my calories now from healthy fats. As I said, I tried to switch over to proteins, but a high protein, low fat diet has its challenges. Your body can actually stimulate insulin and even turn proteins into glucoses. Not so much with fats. So here's the sort of things that I eat. For breakfast, I didn't have oatmeal, and I certainly didn't have cereal. Haven't had cereal in, I don't know, many decades. This morning, I had 2 fried eggs, fried in butter, not margarine, and some bacon. Yep, bacon and eggs and butter. Much better for you than oatmeal, and clearly so much better than cold cereal. For lunch, I got most of my calories from avocado and olive tapenade and a couple of slices of beef. So as you see, I also eat red meat. If you're worried about red meat, maybe you should read Nina Teicholz's book, The Big Fat Surprise. Now, what about my diet? I have other protein and fat sources that I eat more than red meat. For example, fish, like the mash fish, mackerel, anchovies, and especially salmon and herring. And I almost forgot my favorite animal protein, poultry. I love chicken. I get a lot of greens, I eat a lot of salads, and one of my favorite healthy foods in that space is fermented foods. There's a lot of fermented food options, like Greek yogurt is one of the most common. Be careful with Greek yogurt, because some Greek yogurt are just sugar bombs. They slip all these stealth carbs in there. But the one that I eat just does not have anything in it except fermented cabbage and water. Yep, I'm talking about sauerkraut. Now, sometimes in my sauerkraut, I love to put pecorino romano. It's a powdered sheep's cheese. And if you haven't heard the story on C15 fats, you should check it out. Now, I get a lot of grief about this next thing. I quote cheat, I have fun with my diet. I have ice cream a couple of times a week. Yeah, I know. I'll wait for you to quit laughing before I go on. But here's the thing. The ice cream that I eat is sweetened with allulose, stevia, and erythritol. Now, here's another thing. I just had a patient, and he and I were talking about how to not stimulate his insulin. He had a big insulin response, and it was causing him problems in losing weight. There's 2 key lifestyle ways to decrease insulin. One is low carbs. We already talked about that. Guess what the other one was? Not eating at all. Fasting. Even just lowering that window of eating during the day from a typical 16 to 18 hours down to 12, that's a big deal. And even 4, I have a lot of patients who do intermittent fasting and really only eat for 4 hours during the day. There is no way to decrease insulin like not eating, fasting. So here's the thing. Diet is number 1. But if your body composition is not where it should be, then you're going to struggle to get there. Bottom line is you want to decrease that body fat to 20% or less and visceral fat to 2 pounds or less. And you're not really going to get any of those kind of numbers unless you just break down and get a DEXA scan. Not DEXA bone scan, and make sure that you clarify that when you go to get it. A DEXA body composition scan to understand the visceral or belly fat. This whole discussion about body fat and visceral fat brings up one of the key components of exercise. In the old days, even 15, 20 years ago, people thought it was all just about jogging, aerobics. The reality is there was a good study, and actually many at this point, that have proven that you get better mitochondria, you get better muscle capillary penetration using something else, not gentle aerobics, not long, slow distance, but significant resistance training and HIIT, high intensity interval training. So when I made my change, I went from long, slow distance to resistance and HIIT. So we have some basics that we share with our patients, and that's what I've done too. Number one, you want to work on your legs. Your upper body's okay, but your upper body's really more cosmetic. Your legs are what drives your metabolism. They're by far the biggest muscles that you have. So when working out, instead of that long, slow marathon distance, I'm doing short, quick exercise snacks. Hill sprints, a quick hit or re-hit on a Schwinn Airdyne, or even a rebounder, believe it or not. Well, now once a week I do a long HIIT session. That's closer to half an hour. I've got a 4-mile track with some hills, and I get about a minute running up the hill that's hard. That's a full HIIT. Again, takes half an hour. On the other days, that's only once a week, and on the other days, I'm just doing short snacks, re-hit, 5-minute sessions, about 4 of those per week. Now for resistance training, it's the same sort of thing. I have some dumbbells and barbells out in the garage. I do some quick lifts for about 5 minutes in the morning when I get up and in the evening before I go to bed. I also do some silly things on the stairs that Jesus doesn't like to talk about. It's basically like you're going upstairs. It's called a one-legged step squat kind of thing. And I also do a lot of calf raises. Even though I've got thin chicken leg kind of calves, I've got good strength there. And I do those resistance snacks twice a day for about 5 days a week, and then a hard session in the gym for about an hour. I do the re-hit snacks once a day, about 3 or 4 times a week, and then one long HIIT session each week. So yeah, back in the day when I lived in Manhattan, stairs was something you had to take if the elevator broke. These days, stairs are part of my longevity program. So I don't expect people to start at the level that I'm at. Some people are beyond me. I mean, I'm not that great, but I'm in a great place in terms of aging and longevity. Now, a lot of people are just at the stage of walking. If that's the stage that you're at, by all means, walk. You know what? I almost forgot to mention my latest discovery. You know those rebounders? I always thought those things looked wimpy. And I never really invested money in getting one of those. But I had a patient and friend who got one. He has an old ankle injury and he couldn't use it. So he offered it to me. I took it, and just bouncing really isn't much. But have you ever tried sprinting on a rebounder? Oh my gosh, it really hits a couple of my weak spots. Lower calves, hips, and distal quads. Man, it wears me out, and it's one of my most common forms of re-hit and HIIT today. So I haven't really clarified a couple of things that people often ask about HIIT training. What is an interval? So here's an interval. Getting up to a high rate. If you're doing like 8 intervals in a session today, 8 or 10, get up to about 80-85% of your heart rate and do that for about a minute. Now, you do 20 of those intervals per week, and cut down to 10 intervals times 2, or 7 intervals times 3. Now, what do you do in between the intense phase and the next intense phase? You go as slow as you want. You can even go down to a walk, but you do something to recuperate. That's called the resting phase. And as I mentioned, the new kid on the block is rehit, reduced exertion, high intensity interval work. And the rehit is, instead of 80%, you try to go to 100% of your ability. You're going like this. You can't talk, you can't hum. You're doing that with both of these, both regular hit and hit. Now with rehit, you do only 2 of those intense sessions, so you can do a session in 5 minutes. And I'll sometimes do those between patients. And you don't have to just limit those to 20 in a week, but you usually will. I'll do it 4 or 5 times a week, 2 intense intervals per session. That's going to be, what, 8 to 10 times total. So let's go through a typical rehit session. Let's say I'm on the Schwinn Airdyne or an assault bike. I get on it, go 2 minutes, slow and easy. It's a warm-up. Then I hit it hard as I can for 20 seconds. Then I back up for another 30 to 120 seconds, somewhere in between. Again, recovery phase. Then I hit it again hard for another 20 seconds. And then I go back into a recovery phase, 1.5 to 2.5 minutes, and I'm done. So with running a rehit session, you jog out to that hill, take about a minute or 2, sprint up that hill for 20 seconds, and you need to time that area. And sprint as hard as you can, jog slowly back down, sprint back up that hill, jog slowly back down, or jog or walk back over to the house, and you're done. So again, to make it short and simple, I eat real food. I do short bursts of intensive activity, not long, slow distance. And I measure what matters. So you see, I'm not trying to win the suffering Olympics. I'm not the greatest monk in terms of lifestyle. I'm just trying to extend my healthy life. And I'm succeeding. And guess what? You can too. Now, that's a little bit about exercise. That's a little bit about diet. Let me talk for a minute about a couple of other things. Sleep and stress. I always had trouble sleeping. One thing that I did, you wouldn't believe it. I used to have problems. My teeth were not straight here. And I had a high arch. What has that got to do with sleep? Well, the high arch caused my teeth to bunch up, but it also caused the back of my tongue to get in my airway when I'm sleeping. That's called sleep apnea. I had a couple of sleep apnea evaluations, and they improved dramatically when I used an Invisalign, improved my arch. So here's another thing that was at least as big. I learned this from my second sleep evaluation. I went to sleep on my back because I knew that sleeping on my back made it worse. It was very interesting. We looked at the sleep pattern. The doc said, you know what? You had a real problem for about an hour. And then I'm guessing that you went to sleep on your back and then you turned over on your side because you didn't have any more problems the rest of the night. So here's another thing that I did for sleep. And it also impacts stress. It's called breathing. It's something we all do. But I'm talking about slowing your breathing down. Now, you may have heard of this with Eastern yoga practices and meditation and breathing. I tried those and never really got that far until I tried this device. It was called Respirate. And it was a biofeedback mechanism. What it did was it measured how often I breathed. And what I found out then was all those times I thought I was meditating and slowing my breathing down, I wasn't really. To slow your breathing down, we're talking about going from a typical, normal 15 to 20 breaths per minute down to half that. 7 to 10 breaths per minute. You really slow it down. What does that accomplish? Well, believe it or not, the Far Eastern practitioners that did this for decades, hundreds of years, centuries, even millennia, 4,000 years, they had something there. Now we know from science what they had. Number one, slowing down your breathing increases your carbon dioxide. That opens up arteries in your brain and relaxes you. Number two, slowing down your breathing like that it stimulates your vagus nerve. Your vagus nerve is sort of like the anti-cortisol, anti-fight or flight, anti-adrenaline. It slows your heart rate down and calms you down, all with decreased breathing rate. I'm going to get hater comments about the next thing. I know that because I already have. I've gotten tons of hater comments. You know, my original video that was the most popular for the first 7 years of the channel was about when I decreased my plaque. Part of what I discussed at that point was I actually agreed to take a statin, believe it or not. And oh, did I get the hater comments. Now, in reality, I don't take high-dose statins, don't recommend them for anybody. I don't take mid-dose statins. I don't take atorvastatin. There's only 2 statins that I would agree to, and both of those very, very low dose. One would be Crestor 5 milligrams a day, the old rosuvastatin. Crestor, which is generically called rosuvastatin. The other one is Livalo or pitavastatin, 1 or 2 milligrams a day. The most popular one, atorvastatin, high doses, no. It will lower your LDL, but I'm not sure that's accomplishing very much. In fact, I don't think it is. Meanwhile, it's causing diabetes and not really dealing with your inflammation, especially if you're diabetic, which most of us are. We have metabolic disease. That's how we got plaque in the first place. And if you're a woman, yep, it doesn't decrease your inflammation that well either. Now, I'm going to talk about 4 different medications and get a little bit deeper in each of those because, again, that's part of my experience. I'm not saying you have to take medications. Even people that want to argue with all medications, and that was me 8 years ago, 10 years ago, 12 years ago, they used to call me Dr. 3 Days because people would come to me thinking they were going to get an antibiotic or a medication, and I'd say, well, let's just wait 3 days. But there's a time when medications are needed. My first experience was with high blood pressure. When I started getting high blood pressure, I knew I needed to take a medication. I had already tried losing weight a couple of times, and that helped, but only to a certain extent. I started with Ramipril. It's an ACE inhibitor, and that worked well for a couple of years, but I continued to have a classic problem with the ACE inhibitors, a cough. And so I ended up going with the ARBs. I now take losartan. Now, if you have high blood pressure, we've got a lot of content that can help you with that. There's a lot of things to look at, more than just making sure you manage your weight, more than just slowed breathing, more than just exercise, and more than just medications. But we're trying to keep it fairly high level for this discussion. The second medication I wanted to mention was aspirin. As soon as I found out I had plaque, I decided to start taking a baby aspirin. Again, we've got lots of content on why. If folks are telling you they read the recommendations and you should not take preventive baby aspirin, ask them to get into a little bit more detail. And in fact, check out our other videos on this, because the bottom line is aspirin is really not recommended for primary prevention. In other words, prevention based on your age alone. But if you have plaque in your arteries, that's no longer primary prevention. You're already a cardiovascular disease patient. Now, the third medication, metformin. Oh, gosh, I tell you what, metformin has gone up again, down again. It's the favorite. Everybody's taking it for preventive purposes, including David Sinclair, Rhonda Patrick, you name it. And then everybody decides, no, it's poisoning your mitochondria. Here's the thing, it does stress the mitochondria, especially if you're taking it at levels like equivalent to 6 to 8 grams per day. I don't have anybody on that. 2 grams is the standard maximum. Here's my standard, and here's what I do personally. I take about 1 gram per day, 3 or 4 days a week. So after all this, the running, the low-fat diet, the switches from long, slow distance to high-intensity interval work, to low-carb diet, the scans, looking at blood pressure medicines, the work on my mouth, sleeping on my side. What does all of that mean anyway? So it means that 67 years old, over the work I've done over the past decade, yes, I've got plaque. Yes, I've got my insulin receptors are equivalent to diabetic insulin receptors, but I've got very little plaque. I turned it around. Despite what I was doing wrong and some of the stuff that I was doing right many years ago. I've got practically no unstable or dangerous plaque in my heart. I'm not worried about a heart attack, and I feel better than I did 30, 40 years ago. Now here's the most important thing, and it's not me. In fact, that is the point. This is not about me. If you've been told it's too late, that's wrong. It's not too late. All it takes is not easy, but it's simple. Change your lifestyle. Slow down those carbs. Find out if you're one of the majority of us that has metabolic disease problems, poor metabolic health. And if you're one of that 90% of us, you probably need to slow down on the carbs. There are other things to do too, all of which continues to add up to taking this risk off the table. You know, some of this gets intense, but at the end of the day, I'm not perfect. Nobody is. I'm a human. You're not perfect. You're a human. You don't have to be perfect. You just have to make progress, one step at a time. So at the end of the day, I did it. You can too. You know, back in the 70s, we thought these new running shoes were the thing. We thought jogging was the thing. We thought everything plant-based was the thing. And some people still are into plant-based. You can get there plant-based just like you can low-carb and carnivore. You just have to watch what hurts you. As Jesus and I were making this video, we began to wonder if it was going to sound like we're minimizing the risk on this report. And we thought maybe we should give you some perspective. Now, Jesus's perspective was, well, Ford, most people under age 40 have from 10 to 30% blockage. And I said, well, now wait a minute, you need to back off on that. It's high risk. And the reality is, I am high risk. I carry a diagnosis of diabetes. So remember that. Now, by the time you reach age 50, it goes as high as 40% blockage. And it increases 10% every decade after that. Age 60, 50%. I'm closer to 70. I'm 67 years old now. If you noticed, my highest level of obstruction was 17%. And that was on the LAD, where I had the most plaque. That matches the usual for somebody less than 40 years old. Now, you may ask the question, well, why didn't you say that during that discussion? Again, because we're not plumbers. That level of obstruction is looking at plumbing. And as we've said, how many times on this channel, this is not a plumbing issue. The arteries are living things, not copper pipes, and obstruction is not the issue. But this information, this comparison helps you understand the level of difference between what we saw on my study and what you would normally expect from a 67-year-old male with diabetes. So what did we cover? We covered the stuff that's most important, and that is, how much soft plaque did I have? Practically zero. I had a very low amount of plaque, a very low volume of plaque, and a 0.1% reading of that plaque being soft or unstable. Practically zero risk. I created the video that you just watched because I have a passion about educating and empowering people like you to take charge of your health. It's the same reason why I created our metabolic risk assessment. This at-home assessment kit contains everything you need to work with one of our coaches to understand the details. It gives you a comprehensive picture and details of your metabolic health status. Using this information and the report that we develop, you'll spend an hour with one of our health coaches to understand your own unique metabolic needs and strengths. Now, all of this equipment is high quality. It's not throwaway stuff. You'll continue to use this for assessments and training during your metabolic health journey. And here's all the information that your coach will review with you from the report. Retail labs and online services charge over $500 for this. And here's the other thing. Those other tests don't even include the most important components, like the oral glucose tolerance test or the grip test. My at-home metabolic risk kit only costs $169.50. Yes, that's right, $169.50, less than $200. If you want to help a family member or friend, you can get an additional box. It's just $119.99. Our goal is to train and help 500 people just this month. We're well on our way. Let's hope one of those is you. Use the link below to start your metabolic health journey now. The scans confirmed it. Nearly no soft plaque left. It was a visual and measurable proof that the strategy worked. Which brings up another point, another question I hear all the time. Well, in talking about strategies, what about medications? You talk a lot about lifestyle. What about those statins? What about aspirin? You know that what they call baby aspirin, but is technically low-dose aspirin. You don't give it to babies. Do you still need those things, medications, if your lifestyle is dialed in? The answer, unfortunately, Jesus hates this answer. He used to hate it, but now I hear him giving the same answer. It depends, because it really does. Some medications play a crucial role, especially early in the process for people at high risk. In some cases, they buy you time while lifestyle changes take effect. Other cases, like aspirin, were once given out like candy. Then more recent information and evidence indicated, well, in some people, the risks really outweigh the benefits. And then the media got involved. And then YouTube content, social media content creators got involved. And they started saying, don't take it at all. We'll go into details on that in this next section. We'll break it down. When medications make sense, when they don't, and how to know whether you're a candidate for low-dose aspirin or whether you might be better off just skipping it. As we've said, it's unfortunate, but it's not a simple one-size-fits-all kind of answer. Let's talk about the data and the evidence and how to apply that to your situation.
This little pill, I don't know how well you can see it, but it's a tiny pill, and it has saved about 100,000 lives per year. Really. It's because of its ability to prevent clots, the clots that might end up causing a heart attack. But in the last few years, people have stopped taking this little pill. So why are people stopping now? Isn't it relatively safe? Isn't it something that, it's an over-the-counter, right? Here's what happened. In 2022, the U.S. Preventive Services Task Force changed its recommendation for aspirin for prevention of heart attack and stroke. What they said was not everybody should take it. Now, again, if it's so harmless over the counter, And if it's saving lives, what's going on and why is this happening? We'll get into the misunderstanding in this video. We'll clear that confusion. We'll talk about how to use aspirin to clear your arteries, prevent heart attacks, prevent strokes. And most importantly, once you begin to understand this, we'll also talk about when to not use aspirin. We'll talk about alternatives. We'll talk about medications and natural supplement alternatives as well for blood thinners. One of the places that we're going to talk about is atrial fib. And we'll talk about atrial fibrillation, what it is, and why it is so important in the aspirin story. It is, in fact, that place where you need to know that's not the place to use aspirin. And we'll talk about why. We'll also talk about Lp(a). What is it and why? What's the Lp(a) wrinkle in the aspirin story? So grab something to drink, preferably in a steel cup or glass, not plastic. And let's get started. My name is Ford Brewer. I'm a preventive medicine doc. I started off as an ER doc, and it just drove me crazy that so many people were having heart attacks and strokes and other things that coulda, woulda, shoulda never happened. So I decided that I was going to become something I didn't think I was going to do. I was going to go into prevention. I've had 40 years of experience in preventive medicine. Now let's get to the basics of aspirin. You need to understand three things. The first is, what is aspirin? Part of the aspirin story is, how does aspirin work? That's the second thing you need to know. The third thing you need to know is the side effects and whether or not it's as harmless as people think. First of all, what is aspirin? In 1897, Felix Hoffmann, a chemist, discovered a compound that went on to become known as Bayer aspirin. He worked for a company called Bayern, and again, the rest of the story is history. But this was not an accident in the lab when Fleming discovered penicillin because some bread mold flew in his window. This was an example. In fact, the first example of Big Pharma doing what Big Pharma does so well. They knew of a natural remedy that was working, and they decided to make some changes in it, maybe recreate it in the lab, and make a ton of money in it. You see, aspirin had been known for 4,000 years, not 50 years, not 100, not 1,000, 4,000 years. The ancient Sumerians actually noticed that if they took the bark of a willow tree and boiled it, it decreased fever and it decreased pain. So that's what Felix Hoffmann was going after. Just a few years before Hoffmann made his discovery, the compound in that willow bark was discovered. It was called salicylates. And for those of you who might know this or have an interest, what he actually created was acetylsalicylic acid. So how does aspirin work? One effect is it improves pain. That's what the Sumerians noticed, and that's what Felix was going for. But there's another effect, and that's what we're interested in today. It's decreasing clots. Aspirin binds to platelets, the little things that start the clotting process, the platelets in your blood. It prevents platelet activation. Other blood thinners, like warfarin, like some of the natural blood thinners, have more of an impact on the clotting cascade. Clotting cascade is a series of a dozen proteins which form together to create a clot after platelets form a lattice work to start the clot. Warfarin and heparin, you've probably heard of those. Those are what we call vitamin K-dependent clotting factors. That's clotting factors 2, 7, 9, and 10. The NOACs, novel oral anticoagulants like Xarelto and Eliquis, focus on one clotting factor alone, 10A. That's a little bit about how it works, and thank you for your patience as we got through that geeky part. side effects. Now, what's the problem with that aspirin? As we said, it's over the counter, so that means it's safe, right? Maybe not so much. In fact, I often say if the FDA were to review aspirin and metformin now, they might make, if they were smart, which is not always the case, they might make metformin over the counter and aspirin a prescription drug. Why is that? Well, there's some side effects. First one is allergic reactions. Another one is stomach ulcer, gastrointestinal bleeding. But the major side effect, the one that caused the U.S. Preventive Services Task Force to change its recommendation, is bleeding. Again, bleeding in the gut is by far the most common, but there have been episodes of bleeding in the brain as well. So here was the previous recommendation. Before 2022, the U.S. Preventive Services Task Force said 60 years and older, everybody should take aspirin because you've got risk for heart attack and stroke. If you're curious about my recommendations, no, I didn't recommend that. My recommendation was not unless you had plaque. If you had plaque and no matter what age you were, you needed to consider aspirin prevention. If you didn't have plaque, no matter what age you were, you needed to not. You didn't have to worry about considering aspirin. And guess what? The U.S. Preventive Services Task Force changed their recommendation to go to what I had been using prior to that. So I'm obviously proud of that. Now, this starts to get into what we call primary prevention versus secondary prevention. Why is that important? When the previous U.S. Preventive Services Task Force recommendation was for primary, meaning even if there's no signs or symptoms of a disease, that's primary prevention. Secondary prevention is you already have a sign or symptom of a disease. So what's the difference between primary and secondary? Why separate those two out? With primary, there's much less risk of continuing on in the disease. Once you already have shown your first sign or symptom of disease, you are much more likely to develop it further and further and further. So that was the issue here. Once you understand the difference between primary and secondary prevention, you begin to understand how the U.S. Preventive Services Task Force really changed their recommendation for aspirin. What they did was they went from a primary prevention recommendation to a secondary prevention recommendation. As I mentioned, my recommendation had always been secondary prevention only, never primary. Why did they do that? Because there's been some improvements in cardiac disease, mortality, death rates, disease rates associated with cardiac disease. And it got to the point to where this risk of GI bleed, this risk of brain bleed associated with aspirin, it was just no longer worth that risk because of decreasing risk of heart attack and stroke in a primary prevention population. So the U.S. Preventive Services Task Force said the juice is just not worth the squeeze for people over 60 for primary prevention. Now, the problem was, and here's where the confusion came in, reporters like the New York Times, a really smart physician reporter, still didn't pick up the distinction here. He said, U.S. Preventive Services Task Force doesn't recommend aspirin anymore for cardiovascular disease prevention. No, they don't recommend it for primary prevention anymore. They still do recommend it for secondary prevention. And here's one of the other things you should consider. By the time we're age 60, what portion of us have plaque already? The majority. So, again, just boatloads of confusion piling on this change in recommendations. Here's the problem. It was misinterpretation, and again, it was based on the difference between primary and secondary prevention. Now, as I mentioned that, let's think about some really good examples. You may be aware of it already. What if you're having a heart attack? Don't the recommendations still say, take an aspirin? And in that case, not even a baby aspirin, a full adult aspirin. While I'm here and while I bring that up, this is a good time to just mention the differences. Baby aspirin is smaller. It's 80 milligrams. Adult aspirin is 2 to 4 times that amount. It's 160 to 25 milligrams. So yes, if you're having those symptoms, you think you may be having a heart attack, the two things to do: call an ambulance to get to the ER, to take you to the ER, the hospital, and take an adult aspirin. That still saves a lot of lives. Doesn't sound like that it's that complicated at this point, does it? But we did. Our culture screwed up, confused that whole thing. Let's go a little bit deeper in terms of understanding secondary prevention. There's some words that you'll keep hearing and seeing. Now, when the American Heart Association task force on this started defining secondary recommendation, they started using things like previous heart attack, plaque in your arteries, peripheral plaque down in your legs, plaque up in your coronary arteries, the arteries of your heart. And there's some things that you may hear already, a couple of patterns that you may notice. These patterns are plaque and ischemia. Again, I'll give you a couple of definitions. Don't worry too much about them. The definitions basically say if you have plaque, you should use aspirin because you're now in secondary prevention. Ischemia was a word that I used too, and it's 50% or more blockage of blood flow. Don't wait for that level of blockage. Don't wait for a stress test. If you've got plaque, start taking baby aspirin. Now, I've used the term plaque a couple of times. What is plaque? It's worth describing that. Most people think plaque is a waxy substance or a fatty substance on the inside of the artery, what we call the lumen, where the blood flows. Both of those are incorrect. It's not a waxy substance until it stabilizes. The plaque that's dangerous is a goop. It's a mucus. It's like snot. And it's actually the same thing as a mucus or a snot because it's full of inflammatory cells. These cells and the inflammation liquid that goes along with this goop, this mucus, they trigger clots. So when they squeeze back into the blood flow, they form a clot. They trigger a clot. And it's the clot that causes the heart attack or stroke. If it's big enough and the clot goes to the heart, it's a heart attack. If it's big enough and it goes to the brain, it's a stroke. And some people have microscopic levels of plaque showering in their bloodstream all the time. That can lead to, after months and years, that can lead to heart failure or dementia. Microscopically, the tissue of their heart or their brain starts to look like Swiss cheese with tiny microscopic holes. Now you're beginning to understand another concept. This whole issue, this risk, does not depend on the amount or size of plaque. You don't have to have 50% blockage or more. That gets back to that concept of ischemia. Ischemia comes from a Greek word meaning stopping blood flow. That requires 50% or more blockage of the artery, the lumen, the place where the blood flows. Now, again, you don't need that much to form a clot. That's the common misunderstanding. It's common sense, and unfortunately, common sense is wrong in this area. You don't need 50% blockage for this to happen. So here's what my recommendation is. Who should consider aspirin? Regardless of age, I recommend baby aspirin, 81 milligrams, to anyone who has no allergy to aspirin, low risk of bleeding, obviously, but has any evidence of cardiovascular plaque. If you have plaque and you don't have allergies or special bleeding problems, you should be taking a baby aspirin. All this brings up the most common procedure for heart attack risk, and that is, hey, doc, my uncle had a heart attack, and I know I'm a little bit overweight. Why don't we just do a stress test to make sure I'm not going to have a heart attack? That's not the way to do it. It's common sense to say, let's do a stress test and let's see if I'm at risk for a heart attack. That's not the way it works. Stress tests only show any kind of problem if you have more than 50% occlusion of blood flow. Is that starting to ring a bell? You remember we talked about that a few minutes ago. The Princeton Longevity Center said 2/3 of heart attacks occur before you have 50% occlusion of blood flow. So why are we depending on stress tests? It's unfortunate, but I'll tell you, number one, it's something that we all assumed would work, the doctors and patients. And unfortunately, it's too lucrative now. It makes too much money for the clinics, for the doctors. They're not going to stop recommending it. The American Heart Association, the American Boards of Internal Medicine, all of the leadership groups in this area have said way too many doctors are doing way too many stress tests. Now, you may be thinking, well, Ford, what do you do? Sometimes this gets a little bit confusing. You're telling us a whole lot of facts. Why don't you tell us what you've done? Okay, I will, and I have. I've gone into significant detail about my own story. When I retired the first time, again, back about age 53, I was introduced to a fellow named Brad Bale and Amy Doneen, a couple of people. They were traveling the country teaching their way of preventing heart attacks and strokes. They kept talking about a test that was non-invasive, inexpensive, and told you whether or not you had soft plaque. That's the key. So it's called a CIMT, Carotid Intima Media Thickness Test. So I thought I was going to ace that CIMT test because I'd been eating low fat and doing marathons and, some of the things that I needed to change. I was wrong. I had plaque, and I decided to start baby aspirin. I looked deeply at my own lifestyle and made a few changes. And a little bit after that, I discovered I had prediabetes. So if you want to see the rest of that story, we're not going to go all the way down that bunny hole. But if you want to see the rest of that story, I'll show you at the end of the video how you can do that. Aspirin's a life-saving tool. But one of the things you need to know is when not to use it. And I brought up the point of atrial fibrillation. So let's talk about atrial fibrillation and why that's an issue. First of all, what is atrial fibrillation? Here's a short version of it. You've got the 4 chambers in the heart, the 2 on the top, the atria, and the 2 on the bottom are the ventricles. The ventricles are the workhorses. If ventricles don't work, you die within a minute or so. Here's what the atria do. They basically they assist the ventricles by loading the ventricles up and getting them ready. If the atria don't work, it's bad. It's a 20% decrease in the performance of the heart, but it's not going to kill you, or at least not kill you immediately like ventricle problems will. What's fibrillation? So instead of a normal coordinated heartbeat, with fibrillation, the heart loses its normal beat and starts to go into a quivering. That's what happens with atrial fibrillation. The ventricles continue to contract with a normal heartbeat, but the atria are quivering. Now, what's the problem with that? That multiplies the risk of stroke by 5 to 8 times. Most cases of stroke in the past have gone undiagnosed. We called them cryptogenic stroke, meaning we didn't know what causes it. Now, beginning to find out more and more that these are coming from atrial fibrillation. Now, so let's get back to the point. Why doesn't aspirin work for atrial fibrillation? We don't know, but there is some assumption that it's because of the clots are being formed in these atria that are quivering, and for some reason, those clots are just not susceptible to this mechanism of this antiplatelet mechanism that you see for aspirin. Aspirin's just not good for prevention of atrial fib-related strokes. No clear reason, and it may be what I just mentioned. You see, I have paroxysmal atrial fib. Paroxysmal means it comes and it goes. And the vast majority of atrial fib is this paroxysmal kind. In fact, it's sort of like prediabetes. We knew a lot of people had it. We knew that it was killing a lot of people, But it wasn't until we really started testing more and finding that as we age, the majority of people develop this. The same thing is happening with atrial fib and its risk of strokes. We knew that atrial fib was a major cause, the major individual cause for strokes. We also knew that atrial fib was common. By far the most common rhythm problem with the heart, we knew is much more common as you get older, much more common with people that have prediabetes and diabetes. But we had no clue how many people actually have atrial fib. We still have no clue, but we're finding more and more and more. So back to my atrial fib story. 5 years after I started aspirin, so back at about age 55, 57, I noticed I had the CIMT at the Bale and Deneen event. So I started taking baby aspirin. And then that's when I discovered about 5 years later that I had atrial fib. I was using a home device. It's called iCardio. These devices are available on the internet, online, even places like Amazon. Apple Watches even have these things now. They're about $100. You see, I had felt these palpitations occasionally over the previous years. So I suspected that I might have atrial fib. I had also had some genetic testing indicating I had a genetic variation called 4q25 that put me at risk for atrial fib. I was also an endurance athlete, also creating increased risk for atrial fib. I also found out that I had prediabetes, increasing my risk for atrial fib. One night, after I had bought this iCardia, I woke up and my chest was it was like a fish was in my chest. You know, when you catch a fish, you pull it out of the water, it's just flipping. I took my pulse. It was 150 and irregular. A pulse that's between 100 and 200, and especially a pulse that's irregular, those two things are major tip-offs for atrial fibrillation. It was 2 a.m. I knew I had a lot of risk factors for atrial fib. I'd had a few palpitations. I got up. I had a pulse of 100, a lot of flipping in my chest, a pulse of 150, irregular. I used that iCardia. Yep, I had atrial fib. So tell me on a comment if you'd like to get further. I'm not going to go much further into this whole atrial fib story, but give us a comment if you'd like for us to do that. I actually have a series of videos for those of you who are interested in atrial fibrillation. And if you're not, because you think, I'm not going to be touched by atrial fib, you might be one of those people that also thinks you're not going to be touched by prediabetes, and you might need to think again. So if aspirin doesn't work for stroke prevention with atrial fib, what does? NOACs. It's a new type of prescription blood thinner. NOAC stands for NOAC, New Oral Anticoagulant. They're better. They're better than aspirin. They inhibit thrombin or factor 10A. You may remember me mentioning that. In that coagulation cascade, those proteins that fill in the clot once the platelets have created a lattice work. Common names for these NOACs are Xarelto and Eliquis. So if you're watching this video, many of you have already heard of NOACs, Xarelto, or Eliquis. Now, I mentioned earlier on that I was going to talk about natural options for blood thinners. Those are for people that don't want to take medications. Prescription medications, are usually prescription because they have risks. The NOACs are no exception. They do have risks too. But many of us would say after you get deeper into the NOACs, they may actually have less risk than aspirin. That's a different discussion for a different time. Let's go back to the natural options. Fish oil, for example. Fish oil or omega-3 oils decrease platelet membrane stickiness. You may have heard that fish oil or omega-3s are natural blood thinners. Serrapeptidase or serrapeptase, depending on how you define it, decreases or actually cuts up the fibrin in a clot. Ginger, garlic, nattokinase, turmeric, all of these have antiplatelet functions. I take them, they have benefits, But the bottom line, you're not going to like hearing this. I didn't like hearing it either. And I'm going to get a lot of hater comments. The natural ones are not better than the medications, especially for atrial fib and stroke prevention, and especially for aspirin and heart attack and stroke prevention. Heart attack and stroke prevention is serious business, so don't take chances with heart attack prevention. And that's what I do for a living. And my patients, most of them develop into the same opinion that I have about strokes. Stroke prevention is even more serious than heart attack prevention because stroke is the number one cause of permanent disability, ending up the rest of your life in a wheelchair or bedridden. That stroke is the number one cause of that. So we don't want to mess around with either heart attack or stroke prevention. Now, all this stuff, I admit, it can be a little bit complicated. So if you're looking for medical care where we're open to different treatments, we're open to lifestyle, we acknowledge from the very beginning that yes, medications are important, supplements are important, but nothing is as important as lifestyle. Even all the stuff I've talked about today with NOACs, aspirin, those still aren't as important in preventing heart attack and stroke as the lifestyle components that we've always talked about. Managing your weight, looking for prediabetes, making sure that you manage those risks. How do you do that? And if you're a little bit confused about how to do that, come see us. We're not paternalistic. We respect your decision and support you. Now, what do I mean by paternalistic? In movie vernacular, I'd say, look, you're Luke Skywalker. I'm just Yoda. Luke Skywalker had to fight his own battles, just like you have to make your own decisions and fight your own battles with heart attack prevention, stroke prevention, etc. So if, for example, you say, I can't lose weight or I don't want to lose weight, I understand. I will support you any way I can. If you say, I know I have plaque, but I don't want to take aspirin, I'd rather take turmeric. I get it. I understand. I want to make sure you know the details, but I'll support you any way I can. Even if you have atrial fib and you say, I don't want to take one of those prescription NOACs, one of those prescription blood thinners. I'd rather take baby aspirin. I get it. I want to make sure you know the details, but I will support you. I'll tell you the benefits, the risks, what's known in terms of the evidence, and I'll also tell you what I would do and what I have done in my own situation. So if you'd like to come see us, check the description at the end of the video or the link and come see us. Now, I mentioned something earlier on that I didn't talk about yet. It's Lp(a). You know, a lot of people think that's a new cardiovascular risk marker. The reality is it's been around for a long time, but doctors did not know what to do to manage Lp(a), so they just didn't look for it. And you still see that with most physicians. They don't look for it. Most physicians don't even know what it is. But a few years ago, a fellow named Bob Harper had a heart attack, and he surprised everybody because he was in his early 50s. He was very fit. He was the trainer for the show, The Biggest Loser. And he had a heart attack. Then, so people started saying, what was going on? His lifestyle was so good. Well, Bob came out and said, I've got Lp(a). I inherited it from my mom. Lp(a) is a cousin of LDL. It's very similar. It's a genetic variation. The docs call them lipoproteins. You don't need to remember that. Lp(a) does increase risk for heart attacks up to 4 times. Aspirin can decrease the increased risk of heart attack and stroke, which comes from Lp(a). It decreases it by a lot, 52%. Now, you've been very patient. This has been a long video. If you've made it this far, I appreciate it. And hopefully you know a lot more about how aspirin works, the benefits, the risks of aspirin, when to take it, and when not to take it. You also know about its use or not use for atrial fib. a lot more about atrial fib, about Lp(a). I do focus on lifestyle as the major intervention. We do use medications when appropriate and the patient wants to. Supplements help, and we know about supplements as well.
So as you saw, aspirin just isn't for everybody. And it's certainly not a substitute for lifestyle. But like many tools in cardiovascular prevention, it has its place. It has a place there. The key is knowing when it helps and when it doesn't. Because this isn't about chasing a simple quick fix. It's about understanding the full picture and using the right tool at the right time for the right person. And that's what this guide has been about from the start. Let me show you how you can start that plaque reversal or stabilization journey. Here I was, 57 years old. I practiced what I preached, so I expected to not have any plaque, even though most men do at that age. So I got my CIMT, and sure enough, we found plaque. And that was frustrating. That's when I really started digging deeper into this whole thing.
So did you actually reverse your plaque to some degree?
I did, and you could see it on the CIMT. It wasn't like the CIMT results were going all over the place and one went down. You could see a very smooth, simple, easy curve coming straight down. Metabolically unhealthy in most situations means you're not burning your carbs well. But here's what happens when you're not burning your carbs well. Your blood sugar starts to go up, and when your blood sugar goes up, your insulin goes up. And both blood sugar and insulin irritate the lining of the arteries and actually cause inflammation of your artery walls.
Dr. Brewer, if there's one thing you would recommend to do that would really help address this problem, what would it be?
I'm reminded of that statement time and time again. Today we have a special show. I'm going to be talking with my friend Fred. He's going to be asking a few questions. Fred has appeared on the show before too, and he wanted to know how to reverse his arterial plaque. Now, he's going to ask me a few questions, and I'm going to share all my secrets and go into the details. So Fred, take it away.
Good. Thanks, Dr. Brewer. Let's start out. You've talked a lot about metabolic health in general. Can you just kind of elaborate how you came to the conclusion about how important it is for arterial health as well as general health, and kind of talk a little bit about the journey of how you arrived at that conclusion?
Sure. I used to be at Johns Hopkins. Well, many people would say the best prevention program in the world. I taught doctors there. We taught a lot of stuff, but I found out the hard way that there were some things we were missing. The hard way meaning I found out with myself. I found plaque at a time when I thought I shouldn't have it yet. And that hurt. So back 30 years ago when I was at Hopkins, it was all about a low-fat diet. We knew even back in those days that full-blown diabetes was a disaster for your arteries, and therefore a disaster for heart attack, stroke, dementia, heart failure. We knew all that stuff. We knew that it was number one cause of blindness, kidney disease, for men, erectile dysfunction. We knew about prediabetes, but we didn't know, for example, until recently that only 10% of us are metabolically healthy. The other 90% are metabolically unhealthy, have metabolic dysfunction, prediabetes, or even diabetes. We didn't know
Can I
that.
stop you there? What does it mean to be metabolically healthy?
So that's a great question. So one of the things that you'll hear quite often is this term, metabolic health. Basically, metabolism is how you burn your fuel. There's been a lot of talk about hybrid engines recently. You got your ICE engine, internal combustion, gasoline, and then you've got electrical cars. But there are cars, Toyota's had a whole lot of hybrids. Now a lot of other companies have them as well. They burn two fuels. The reason I'm going down that path is our body's like that too. Our body burns two major fuels, carbs and fats. Of course, it can burn proteins as well, but that's not really important for this issue right now, for what we're talking about. Our body, like a hybrid car, can switch from one energy to another. Blood sugar can irritate the lining of the artery walls. So what our body will do because of that issue, and maybe some other issues as well, is that our body, if it notices that we have carbs to burn, it will burn carbs first. Some people describe the comparison as like this. Carbs are sort of like pine needles that'll catch quickly and it'll burn up fast, but then it'll leave a lot of junk. Burning fat is more like burning a log. It's harder to get that fat started, but once you get it started, it burns cleaner, longer, and you don't have these flashes and flares. It's just, it's sort of like diesel. It burns a long time. It's just harder to get started. Now, metabolic health means that your body's doing both of those things in a healthy fashion. Metabolically unhealthy in most situations means you're not burning your carbs well. But here's what happens when you're not burning your carbs well. Your blood sugar starts to go up. And when your blood sugar goes up, your insulin goes up. And both blood sugar and insulin irritate the lining of the arteries and actually cause inflammation of your artery walls.
Let me stop you there. You know my story about getting diagnosed with heart disease. I won't go into the whole thing right now, but not once by the age of 68 had any doctor who was monitoring me ever made that correlation. They never looked at, I never even heard the term. I was getting lab work on an annual basis. And I was, the story, how I eventually was found to have 80-90% blockage in 3 main arteries when I had no symptoms, no indicators on the lab tests that I had gotten all the time. And the only thing they ever asked me to they even talked about was cholesterol. And it was the overall number. So metabolic health was never related to me as a factor in heart disease. How did you come up with that? I'm assuming most doctors are not taught that.
True. And even back in the days of when Hippocrates and I were med students together, we knew that diabetes was a problem. We just didn't know how common it was and how common the prediabetes and lower levels were. Here's another thing that happened. In somebody that's metabolically unhealthy, they've got prediabetes. As you start getting more and more of it, usually your LDL, quote, bad cholesterol, goes up in your bloodstream. Here's another thing that starts all these correlation problems. You know that plaque that we talked about in your artery wall?
I know it well.
Guess what it's mostly made of? Cholesterol. So it just seems obvious when you think about those facts that cholesterol is the culprit, right? Unfortunately, most doctors still think that.
And you're saying this is like epidemic level.
Okay, well, yeah, that's one of the things we didn't know 40 years ago. If you look at the National Health and Nutrition Examination Survey, it's a portion of the U.S. Census. And they said, just using A1C and fasting glucose, how many people have prediabetes or diabetes? That's more than just metabolically unhealthy. That's diagnosed areas, hemoglobin A1C of 5.5 or higher, 5, 6. Guess what the number was?
The number of people who what?
Who had prediabetes or diabetes out of the U.S. population, adults.
I guess it was very low.
52%.
Using those factors.
Using those factors alone, that's not starting at age 60. Age is the major driver of this issue. Age, genetics, and body composition, body fat, loss of muscle. Those are all important, but we're talking about 18 years and above already have prediabetes, diagnosable prediabetes and diabetes. Now, once you start flipping it over and start looking at metabolically healthy, no evidence of problems with insulin or insulin resistance, It's only 10% of us. Very, very common.
And you're saying most of those people don't know.
Yeah, so that's exactly where I was going next. Great question. So guess what portion of people actually that have metabolic health problems actually know it, or diabetes or prediabetes?
I was going to say 25.
10%.
It's even worse than that.
Yeah.
So are you saying typical doctors are not testing right, are not giving us the right tests, or they're interpreting them wrong?
Two questions, and both of them I'm saying yes. And I'm not saying it. That's in the studies. One of them came out of Hopkins, and they basically did a survey. And this is not orthopedists. This is not surgeons. This is not people that you'd say, well, they don't deal with this. This is internists, family practitioners, even cardiologists. 75% did not know how to diagnose prediabetes, let alone know what metabolic health was. They did not know how to diagnose prediabetes.
Why are they not taught this?
Well, one of the things is they're testing wrong. Even the American Diabetes Association, even they have admitted these two tests, fasting glucose and A1C, miss more cases of diabetes than they pick up, let alone prediabetes and poor metabolic health. So we're testing for it wrong. Our doctors don't know how to define it. They don't know how to diagnose it. It's really no wonder that the vast majority of people, 90% of us that have it, just don't know it. So, as we say in the South, we're barking up the wrong tree.
Well, and even in my case, like if you were looking at my A1C and my fasting glucose, it was never a warning sign.
Yeah.
And yet my arteries were on fire, just getting a lot more plaque. Now, they also looked at, I know I used to get these measurements on inflammation. Does that play any role?
Yeah. So a couple of really smart guys from Harvard, they noticed in a lot of studies that even though people had high LDL, bad cholesterol, if they were on a statin, they tended to be protected from heart attack. And vice versa, if they had low LDL, even if they had low LDL, low cholesterol, quote, bad cholesterol, when they weren't on statins in these studies, they had higher risk. They began to think, well, statins do seem to protect from heart attack and stroke, but it doesn't appear to be LDL, bad cholesterol. Maybe it's inflammation. Sure enough, the past 20 years of research have shown that, yes, that's very, very true. And that's one of the things that we do. We use a panel inflammation test, C-reactive protein, LPPLA2, myeloperoxidase, a bunch of technical things that we probably don't want to go into in this discussion.
And I know for me, you put me on very low dose statin.
Right.
I mean, 2.5 milligrams. Is that right? Or 2 milligrams? Where other physicians before were like 40, 60, 80 milligrams. So you don't use it, my understanding, you don't use it to lower cholesterol per se. You use it to lower inflammation.
So, yeah, here's part of what was going on with you, Fred. So, yes, you do have metabolic disease. And, you're what, 70 now?
Going to be 74.
So you're a healthy 74, but like most 74-year-olds, like over 90% of them, you have some metabolic health issues. You're tall and thin. You've got a very good BMI. So the doctors weren't picking up anything on A1C or fasting glucose. They were just assuming it was cholesterol. So they were chasing your cholesterol. Meanwhile, your metabolic disease was continuing to cause plaque.
They're looking at the wrong number.
Barking up the wrong tree.
So I had a false assurance that I was doing okay until I landed in the emergency room at Mayo. Yeah. And my arteries all plugged up.
Yep.
Okay. We've talked quite a bit about how messed up the testing is with conventional doctors and kind of the way that you look at it differently. Let's talk about how do you fix it? Because I know you've said it's even possible to reverse arterial plaque and at minimum to stabilize it. So can you just talk about how did the person go about doing that?
Well, first of all, I have to say this. a lot of docs I get a lot of hate comments. I used to get a lot of hate comments when I did my first video. My own plaque reversed. I was using a thing called CIMT. Some folks have challenges with that. I understand exactly why. So I get this reputation that here's this crazy doc talking about reversing plaque. Well, you've seen the data, you've seen all of the information, and you know what? It was true. Whether it seemed unusual or not, it was true. Here's the other thing. It's not just me. There's an article from the chair of cardiology at Harvard, 10 years ago in Harvard Men's Health, and he's talking about plaque reversal too. And he talked about the two most common places that you'd see. It would be somebody with massive weight loss, like 30 pounds or more. And as you know, you've talked to a lot of the folks that have joined our practice, a lot of the patients, and you know we've got a ton of people that have lost that kind of weight. The other place that you tend to see some plaque reversal, and again, I got haters on the other side of that debate. On that one was when you started a statin. Even low-dose statins help decrease inflammation. So when your doctors were chasing your LDL, they were having to use high doses of statin. Even low doses of statin can reduce inflammation. At the end of the day, it gets back to the very first thing we were saying. If your blood sugar stays too high or your insulin stays too high, you start getting inflammation of your artery walls. One simple, easy way to slow that down is with a pill, but it's not the best way to do it. The best way to do it is lifestyle. One of the key lifestyle components is what you've done. You've remained thin, a good BMI. Body fat is a major driver of inflammation as well.
So, Dr. Brewer, you mentioned you got quite a bit of criticism when you posted a video about how you reverse your arterial plaque. You had a video. How many years ago was that? 5 years ago?
Oh, at least 5 years ago.
At least 5 years ago. So talk about what was your journey to do that? We're sitting here with so many people with metabolic dysfunction that is going to lead to that problem, as well as many, many other health problems. So talk a little bit about your story, how that occurred.
So, yeah, thanks. I let you distract me when I was talking about it earlier. So I'll go back to that. Here I was, 57 years old. So I expected to not have any plaque, even though that's most men do at that age. So I got my CIMT, and sure enough, we found plaque. And that was frustrating. It was very frustrating. You're my age. When you hit the 50s and 60s and you first have high blood pressure or you first have something that says, I'm going there too.
Yeah, it's very unsettling.
It really is. But it's a maturing moment emotionally.
It's one way to put it.
Yeah. You find that you're not immortal. And I got really frustrated. One of the things I felt like for a long time was, dang, I did all this work for so long, and here I still have plaque. Why did that happen? And then it took me a few weeks to wrap my head emotionally around the fact that, given my obvious genetic challenges, if I had just eaten all I wanted, if I'd gone to 300 pounds and laid on the couch and not exercised, I could have already been dead. So I went back and rethought about things. The other thing that I did was I looked a little bit deeper at my metabolic health. And then I found out that, despite the fact that my BMI was 22, I was a marathon runner, ultra marathon runner, I still had metabolic disease. So that's when I really started digging deeper into this whole thing. Now, I had an OGTT, and my blood sugar spiked up to like 160 after 1 hour. And I can tell you now, from having done so many OGTTs and dealt with so many patients.
Let's just, for the audience, OGTT stands for what?
Oral glucose tolerance test.
Okay.
So there's a good comparison, I think, between a full movie and a single picture. So we could take a single picture of me standing in front of a bus, and it looks like everything's fine. If we take a movie, though, we may realize that bus is about to run over me, and actually does. It's the same thing with fasting glucose and oral glucose tolerance test. What we want to see with fasting glucose is, or what we will see is where our blood sugar is now. What we want to see is how our blood sugar reacts when we drink something that has sugar or we eat something. And we talked about oatmeal, for example. It's just super packed with sugars, which are called grains or complex carbohydrate.
You really don't know just with a fasting glucose.
You really don't. But the fact that the majority of cases of diabetes today that have been discovered with such a bad test as fasting glucose, that gives you an idea of what kind of shape we're in. Meaning we don't know how to diagnose it, and still we've got, using a bad test, we've still got a whole lot of people with a bad problem.
So did you actually reverse your plaque to some degree?
I did. And again, I had mixed emotions when I saw that happen, because I said, oh, now people are going to be interested in this on that title. That's going to look like clickbait. And then I also said, oh gosh. And all my friends and my academicians, I spent time with the American Board of Preventive Medicine. All these people are just going to romp all over me saying this guy's a nut. Well, you know what? The bottom line is what's real is real. And you could see it on the CIMT. It wasn't like the CIMT results were going all over the place and one went down. I was using that on a regular basis. So I had people coming in to do a good CIMT on my patients every couple of weeks. You could see a very smooth, simple, easy curve coming straight down. The other thing, and you know this from having been to a few of our events where we're doing them, it stayed down once it got there. So when you look at a thing called arterial age, a concept of how much plaque you should have according to your age, my arteries fit those of a 73-year-old at a time that I was 57. Over the next 2 years, it dropped down 20 years to those of a 53-year-old.
That's amazing. And what do you mostly attribute that to?
Very simple. You and I,
you were already exercising.
Yeah. Now, I was already exercising, but I wasn't exercising the right way. But that's the second thing. The first thing is, and we haven't mentioned that yet, think about it. If carbs are now at my age, at my genetics, at my level of metabolic not so good health, if they're now damaging my arteries, what should I do? First thing, quit eating carbs.
Get rid of the carbs.
Exactly. Very, very simple. I used to travel a lot. I'd go to the Delta Sky Room. They'd have all that oatmeal right there. That was my favorite breakfast. Then I found out what it did to my blood sugar. So
you could have been eating cereal.
Yeah, it was the exact same as eating cereal. So I started testing for my blood sugar, and anything that had carbs in it, I started backing off. That is the number one thing, and it's like, tell me we haven't heard this before. When you find yourself in a hole, the first thing to do is what? Stop digging. So
I've also learned from you and the team, there's good carbs and bad carbs.
Yeah.
You're not anti-carbs, you're anti-bad carbs.
Yeah. So thank you so much for bringing that up.
Give us a 30-second understanding of that. What's a good carb and a bad carb?
So broccoli's a great carb. Cauliflower is a great carb. Asparagus is a great carb. Brussels sprouts.
Most vegetables.
Yeah. The high fiber vegetables. Now, as things have continued to evolve, the carnivore diet has gotten very popular, and you'll hear carnivores say, oh, those are terrible foods. You'll have other people talk about lectins, and yes, Brussels sprouts have lectins in them. Some other plants do too. And then you'll hear other people say fiber is not great for you. I'm not going to go down that bunny hole today. That's a different type of debate. I do agree with Robert Lustig in that, yes, most diets can work. You can have a very healthy diet, even carnivore, all the way over to vegan, except for the standard American diet. And here's the problem with the standard American diet. It's full of really bad carbs, like fructose, high fructose corn syrup. Think McDonald's, a supersize me
32, 48-ounce soda.
48-ounce cup full of high fructose corn syrup, along with a whole bunch of more carbs in the supersized fries, along with more carbs on the burger buns, along with some seed oils if you want to get into that, and then some burger meat too. So you do that 3 times a day. Most people eat like that 3 times a day. A lot of people have glucose tolerance problems such that that kind of meal is going to have their blood sugar over 200, 16 to 20 hours a day. Nobody's testing it. Nobody feels it, and it's rotting your arteries out. And we wonder why we live in a world where you can be 60 years old and be surprised by dying from sudden cardiac death.
I know you've talked about exercise, sleep, stress, these kinds of things. Can you just talk about, it seems like everybody knows that we all should be doing this. Yet when you go to a conventional doctor, they just give you more pills and don't even barely talk about it. So how have you gone about it with your patients just to have success with them on these different kinds of lifestyle health changes?
Well, it's an interesting thing. I learned from some friends 20 years ago. Just like most doctors, when they graduate from medical school, they think, oh, this is simple. I'll just tell the patient to lose weight and to exercise, and they'll do it. But it's correlated to that old thing about test, don't guess. When a doctor just looks at some things that they know mean this patient's not that healthy, and they talk about it, they say, you need to lose some weight, and that ain't going to happen. But then when you start showing the patient that their blood sugars are peaking over 200 with a challenge, you give them a CGM, continuous glucose monitor, they find that they eat a little bit of oatmeal. They eat oatmeal in the morning, which is, quote, supposed to be healthy, and their blood sugar goes up to 160, 180, 200. It's like, oh, my gosh, wait a minute. I thought this was healthy. So once somebody begins to see with their own eyes what's going on, that's what motivates them. So we do test.
You can actually see the foods and spike your glucose.
Exactly.
Which I guess the theory is when you spike your glucose, you're in a position to form plaque.
So that's a good question. There's a book called Blood Sugar 101 by a lady named Jenny Rule. It was award-winning. It was out of a large website she had for other people like her that had diabetes. She did a great dive into what level of blood sugar is associated with arterial plaque. There's no conclusive ironclad answer, but plenty of evidence would indicate the longer you spend at a blood sugar of 140 or higher, the more at risk you are for forming plaque. And if that plaque is inflamed, that can cause a clot, which in turn can cause a heart attack or stroke.
So you eat the wrong carbs, you can be sitting there at a high level for an extended period of time.
One of the best ways to do it is to eat a big bowl of instant oatmeal.
That'll do it.
That'll do it.
And the arteries get on fire.
Yeah. Guess what portion of people eat cereal?
I bet it's very high.
In the U.S., 84% of the population eats cold breakfast cereal regularly. It's highly processed. There's little or no distance between tons and tons of sugar, not just glucose sugar, but the sugar in the carb, the grain product, the, quote, carbohydrate, complex carbohydrate, and your blood sugar level. And so it's true. We don't have a lot of variation in our breakfast foods. And those of us that eat cereal are just rotting our arteries out on a regular basis. I haven't had table cereal in probably at least 40 years, maybe 50.
Yeah, I gave that up 30 years ago. I would eat pizza for breakfast instead.
Well, that really helped, didn't it?
It got me where I am today. Okay, let's talk about, I know when someone, because I'm a patient, I know when someone becomes a patient, you go through quite an elaborate series of lab tests, different kinds of scans to see the kind of plaque you have. but I know you've been working a lot on another program that's an at-home test. Can you just talk a little bit about, I know you're trying to reach the masses. You've always, I mean, your YouTube channel, millions of people all over the world. So I know that's been a passion for you for a long time. What are you hoping to achieve with this at-home test? And how'd you go about putting it together so that it really diagnoses, not diagnose is probably the right thing to say, but it's able to indicate some level of risk that we have?
So I'm glad you asked that. I'm very excited about it and very interested in sharing it. So one of the things that I've always wanted to do is be able to get stuff out to a lot more people at a lower cost, make it much more accessible. We've developed a box, and I'll go get it in a minute. We've developed a box that actually gives people over 30 different biological indicators of their own metabolic health. We actually do have oral glucose tolerance that you can do at home. You don't have to go sit in a lab half the day. You don't have to pay thousands of dollars for a huge battery of lab tests. We have grip strength and very good grip strength measurements.
What does that have to do with metabolic health?
I'll tell you what, let's take a break for half a minute and I'll get that and we'll talk about it. You asked the question. It's a really good question. What has grip strength got to do with this? Grip strength is one of those biological indicators which is very helpful for predicting longevity, healthy longevity. We're not talking about one of those janky little spring things. We're talking about a real grip strength dynamometer. There's some other things. I mentioned a few minutes ago that we actually have it set up where you can do a blood sugar test, oral glucose tolerance test.
Now, that's not just the fasting glucose.
No, it's not just the fasting glucose. We actually have a packet in there with organic. I mean, you don't have, it's sugar. You mix it yourself. You don't have to buy a glucola from the store, and you don't have to worry about preservatives and all
that. You can't just drink a Dr. Pepper?
You could, but there are a couple of problems with that, really. I've actually done a couple of videos where I did a home glucose tolerance test. I did one with Mott's applesauce, and yes, it spiked my sugar up over 200. If you do something like a Coke, a Dr. Pepper, just remember that this is fructose, and fructose does not raise your blood sugar as high as glucose. So even though your blood sugar may only look like it's going up a certain amount, fructose is actually even doing more damage. So there's a problem in using fructose-related sugars for this test. Don't do it. So there's some other things that we have in here as well. I hate it, and especially, I think a lot of the ladies are going to hate this. You know what these are, looking at different places where we have fat. Some people have it here on the saddlebags. Some have it up in here. The reality is there's a reason for that. And you're going to be going over this. This information, by the way, is going to be going into a report using our internal formulae, stuff that will help you understand not only how much metabolic disease you might have, help you understand what the major sources are. But we need to know about body fat, because body fat creates a hormone called resistin. Fat cells, if they grow too big for their vessel, their arterial supply, will even start to die, to rot, to create things that are even worse than metabolic dysfunction, believe it or not. So while we're talking about some of the things that are a little bit harder to, you might not want to do for vanity's sake, but you really need to, we also got a tape measure. Getting pants size is not good enough, because pants, the old Dunlop's thing where your belly Dunlopped over your belt. You need to get a real tape measure and get your belly circumference around the level of
that. That's how we cheat and soothe our egos.
Right. So those are some of the things that we're talking about here. And so you can see, as you know, We're not making money off this box either. But this box is a great way to help people understand the whole picture of their metabolic health, so they don't have to worry about listening to a YouTube video or general information and think, this may not fit me. Well, this is me. This is what my body's telling me. Now, one thing that I didn't mention is, I mentioned that you'll get a report, but I didn't mention how you're going to get that report. The other thing is, you're going to get one of our coaches, one of our trained coaches who we've trained, we've certified internally, that will go over this information with you. So you'll get a full hour with that coach, and the coach will help you understand what's in the report.
Sounds great. And you really think this can be valuable information to help me understand my metabolic risk?
I have no doubt. I'm very excited about it, as I said, and I'm looking forward to the next steps. As you know, we put a couple of test runs out there, and we're not the only folks excited about it either. A lot of folks are getting interested.
And this is available now.
Yes.
Dr. Brewer, if there's one thing you would recommend to do that would really help address this problem, what would it be?
I'm reminded of that statement time and time again. It's wishful thinking doesn't really get you somewhere. Test, don't guess. And as we've been discussing already and several times, this box is the simplest, easiest way to get some real information from your body, what your metabolism's telling you. Blood pressure is one of the biggest factors involved in arterial plaque. Check out the best foods here to lower blood pressure